Blessings of all elders here, our teachers, and teachers to many generations of cardiologists. We begin one more edition of Speed, which we have titled Speed MMXX11, that's Speed 2022. I welcome all the faculty. There is no internal and external faculty for us. For us, all our teachers. So I welcome all of them once again for Speed. I have also put it in the group today in WhatsApp with all the delegates that this was done with a lot of uncertainty, but we were very happy that within 1 day of putting a link on, we had 190 registrations, of whom 201 have already confirmed that they are here, out of 204 totally. So it was a great and an overwhelming response for us. And even when it's just a 1 day program, we have all these stalwarts who have come from across the country to give their best to you so that you can do well in your exams. So without any further ado, let's start with the invocation ceremony. I request my team to invoke the blessings of the Lord, simultaneously with which we can also have the lamp lighting by the faculty.
गणानां त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमम् ज्येष्ठराजं ब्रह्मणां ब्रह्मणस्पत आनः शृण्वन्नोतिभिः सीदसादनम् प्रणो देवी सरस्वती वाजेभिर्वाजिनीवती हीनामवित्र्यवतु गणेशाय नमः सरस्वत्यै नमः श्रीगुरुभ्यो नमः हरिः ओम् निधनपतये नमः निधनपतान्तिकाय नमः ऊर्ध्वाय नमः ऊर्ध्वलिङ्गाय नमः हिरण्याय नमः हिरण्यलिङ्गाय नमः सुवर्णाय नमः सुवर्णलिङ्गाय नमः दिव्याय नमः दिव्यलिङ्गाय नमः भवाय नमः भवलिङ्गाय नमः सर्वाय नमः सर्वलिङ्गाय नमः शिवाय नमः शिवलिङ्गाय नमः ज्वलाय नमः ज्वललिङ्गाय नमः आत्माय नमः आत्मलिङ्गाय नमः परमाय नमः परमलिङ्गाय नमः एतत् सोमस्य सूर्यस्य सर्वलिङ्गकस्थापयति पाणिमन्त्रं पवित्रम् सद्यो जातं प्रपद्यामि सद्यो जाताय वै नमो नमः भवे भवेनाति भवे भवस्व मां भवोद्भवाय नमः वामदेवाय नमो ज्येष्ठाय नमः श्रेष्ठाय नमो रुद्राय नमः कालाय नमः कलविकरणाय नमो बलविकरणाय नमो बलाय नमो बलप्रमथनाय नमः सर्वभूतदमनाय नमो मनोन्मनाय नमः अघोरेभ्यो तघोरेभ्यो घोरघोरतरेभ्यः सर्वेभ्यः सर्वेभ्यो नमस्ते अस्तु रुद्ररूपेभ्यः तत्पुरुषाय विद्महे महादेवाय धीमहि तन्नो रुद्रः प्रचोदयात् ॐ शान्ति शान्ति शान्तिः स्वस्ति प्रजाभ्यः परिपालयन्ताम् न्यायेन मार्गेण महीं महिषाः गोब्राह्मणेभ्यः शुभमस्तु नित्यम् समस्तलोकाः सुखिनो भवन्तु समस्तलोकाः सुखिनो भवन्तु समस्तलोकाः सुखिनो भवन्तु ॐ शान्ति शान्ति शान्तिः
Again, I thank all the faculty and the delegates for being with us here today. SPEED 2022, we acronym SPEED to Sri Sathya Sai Preparatory course for exam going DNB DM students. And this is a course which is now in its 8th year. And the inspiration for SPEED, really was Swami for us. The question is, a lot of people ask us when we are organizing it, and even our teachers, is it just a refresher course for examinations? Is it just that much, or is it more than that? So essentially, it stems from this. It stems from a vision and a mission of our founder, Bhagwan Baba, whose 3 cardinal principles that he taught all of us was about free education, free clean drinking water, which was provided to more than 10,000, 15,000 villages in 2 or 3 states of India, and free healthcare. Actually, APJ Abdul Kalam sir called this as the ballistic missile, health, water and education, which is written right up there on the dais, right up there, that healthcare and education should be available to mankind for the asking and reaching where it should. This was one of the pictures of Narayan Seva that Swami used to do himself. It's a much larger organization than just a hospital. It has a lot of ramifications. This is the water project. The lower one is the Institute of Higher Learning, which is there in here and in Puttaparthi and in Anandpur campuses, as well as Ideal Healthcare, which Swami has given a lot of importance to and impetus to, considering the kind of lack of resources in our country in many places. But the nucleus of every limb of this organization, which has been taught to us as students, as people from the organization and by our teachers, is the concept of Seva. That's why it's called Sri Sathya Sai Seva Organization. When we had conceptualized why should there be SPEED, it's a refresher course with timely guidance. We generally hold it in Jan or February or March, that is just before the exam. So the exams got a little delayed this time. So we did it for both the DM and the DNB trainees, which is a week or 2 away from their exams, or maybe a month away. Stellar faculty all under one roof. You'll see it as the day goes on, how much you're going to benefit out of this. The other thing that was, actually the inspiration for SPEED, and one of the inspiring factors for us was a different training pattern and different examination patterns across the country. So we are searching for a common ground, both for DM and DNB exams, and particularly with the newer, OSCE exams which are happening for the DNB pattern. To simulate a pressure cooker scenario for the examination and to give you a feel of the real exam, how it happens, because you're going to have 11 examiners, not 3, not 4, 11 examiners asking you questions. So it's going to be a real melange of knowledge and expertise. And what Sir always used to teach us is that the knowledge in the mind should find correct expression on the tip of the tongue. You should know how to express what you think is important in the exam. This whole vision of SPEED for us is something which was initiated, as I said, by Swami, but put to practice by my teacher, Das sir, and of course Barua sir, and all those, Iyer sir, Panikar sir, all those who guided us in the initial years and still continue to guide us, who always follow Swami's principles that education should have no limits or barriers. There used to be a lot of observer students who used to come for Sir's classes, and Sir used to tell us one thing, that there are no internal and external students. So there are no our students and no external students. It's a teaching place for one and all are free to attend. So many students called me in the last few days saying, have you not registered? We have not stopped anybody or any person from coming here. So this is your institute, and no one enters here, without a connect to Swami, is what we believe. So this is a larger dimension of SPEED, more than being a refresher course for exams. One point that we all believe in was about this thing. There's a very special slide to me and ma'am and all of us who planned this, this whole event for us this time. So this is a very special edition. Actually, Bajendra sir also was mentioning there's no physical thing going on in any of the institutes that happen. So we wanted to do this, and we hope it continues with other institutes also. This is a very special edition. And in that sense, it is so because, it's happening at a very, very difficult time for all of us. This is an edition made only for the cardiology students of this, this batch or maybe a few batches more, because you've given your life to the country and we all accept it. Because you've been the actual heroes. A lot of us have worked in COVID units over the last 2 years. It's a tribute to all of you, whom we call as flu fighters. As is believed, not all heroes wear capes. This is the cape that you've all been wearing, sweating inside, doing your work. And I think it's going above and beyond the call of duty. We have two people who have actually represented India on war here. Iyengar sir and Dr. Hemant Madan will join us. So they have been there. So they understand it for sure. That not all heroes wear capes. This is the cape that you all wore, and you served the nation when you needed it most. And that's why you deserve the best, because not all of you could get the exposure that you should have got probably over the last 2 years. So this is really a tribute to all of you. With this small thing, we introduce you to Speed 2022, and we again invite all of you to be a part of this. So welcome to the Speed family, Sathya Sai family. This is your program. Make the most of it. I request Dr. Barua sir to please give the welcome address. Sir.
I pranam the lotus feet of Bhagavan. My pranam at the lotus feet of Bhagavan. This is a post-pandemic, very difficult session to arrange. Up until 1 month back, we were not sure we will have a speed because Karnataka infections rate were going up. Only last maybe 10 days, suddenly all over country as well as in Karnataka, COVID infection rate has come down drastically. So at the last minute, we could arrange this. And it's nice to see, in spite of last minute proposal, we have a good gathering of students. Of course, some exams are going to be started in Tamil Nadu from 1st of August. So a lot of them have dropped out. First of all, I'd like to welcome our most distinguished faculties in this country. And like to welcome you, all the students. They have come, leaving aside their regular assignments, leaving their family all the way on the Sunday, nice morning, to come with you. So please take as much from them, whatever they teach. Please take as much from them. It will be very handy for your exam. This is the type of exam going to be. Okay. Now, history taking has changed after the pandemic. Now, first thing we ask, have you had COVID? Have you taken vaccine? So pandemic has changed a lot to all of us. It has affected all of us. And you may be expert on treatment of COVID patient. And now nobody has time to prepare for the cardiology last 3 years. I know because I have seen our own students, how they spend nights and days taking care of COVID patients. So more or less we are expert in taking care of COVID. But now we have to get ready for the cardiology exam, and which is really ruthless. We have to be 100% correct to pass the exam, to score well. So I welcome you all. Please gain maximum out of this conference. Thank you all.
Thank you, sir. I now request Das sir, my teacher, sir, please, to expound upon the vision of speed.
For my most reverential pranam at the lotus feet of Bhagavan, and I extend my love, sincere regards, I respect all the distinguished faculty and I love to students. And it is a great pleasure on my part to stand here. After a gap of 2 years, last 2 years we were not able to hold this speed because of this corona. And I'm very glad to see my colleagues and students here. This is a kind of rehearsal for you to face the exam, both DM and DNB. And this is the final exit of your 3 years training period. You might have accumulated a lot of experiences, knowledges on cardiology subject. Now, this very short span of time, so you have to make rehearsal before all the distinguished teachers and examiners who is having experience of more than decades in this field. So you'll be indeed very much, your mission is very much fruitful, and this rehearsal or this kind of mock examination will give you enough strength and morale to face the examination. I wish you all be benefited much going through this type of CME today. So I am grateful to Swami to give me a chance to come and participate in this type of CME, and I'm very happy that I could able to meet my friends are here. Thank you, everybody.
Thank you so much, sir. I now request Das sir and Barwa sir to welcome all the faculty with a small memento, which they'll take back as Swami's blessing, sir. Can I ask Das sir to start? We welcome Dr. Balchandra sir. Memento. Sir has been the HOD of JIPMAR, taught generations of students and probably one of the most senior cardiologists in the country. Das sir, please invite Dr. Iyengar sir. Thank you, sir, for joining us. Dr. C.B. Patel, sir. Thank you so much, sir, for joining us again. Dr. Prabhavati, ma'am. Thank you, ma'am, for joining us, ma'am. Can I request Dr. Barwa, sir, to now invite Das, sir, to his own home, sir. Sir, Das, sir. Thank you for joining us again, sir. Dr. Kiran Varghese, sir. Dr. Ramakrishnan, sir. Thank you so much, all of you teachers, for please joining us for this function. We have Dr. Hemant Madan sir who will join us, Dr. Patnaik sir who will join us in due course. Dr. Patnaik sir is come. Oh, Dr. Madan sir has come. Sir, please join us, sir. Sir has not been very well, but still he said he's not going to drop out, but I think he's better now. Thank you so much, sir. Thank you for joining us, sir. That's sir, can I just ask you to welcome sir with a floral bouquet, please. Thank you for joining us, sir. We will begin with the academic session. Just get the patient is ready. Patient is ready. And can I request Das sir to now give a bouquet to Barwa sir, Pitama of the department, which this is. Sir, please welcome Barwa sir also, sir. Saram sir. He's the first. Come, sir. Come. There, sir. Very much. Thank you, sir, for guiding us all along in the planning, preparation, and conduct of speed. Thank you, sir. We'll start with the academic sessions right away. We have had a lot of requests from students to include more cases. So we thought we'll include more cases and cut down on the number of the, timing a little bit more. We'll cut back on that. 15 minutes of what we have written in section 1 and 2, we could include one more case there as we go along. So we'll start with the first case. It will be presented by Dr. Spurti from Sathya Institute of Biomedical Sciences, Whitefield. Can I request Dr. Das, sir, Dr. Iyengar, sir, and Dr. Balchandar, sir, to please start the proceedings, sir. We've written 45 plus 15. We'll try to go 45 minutes if we can. Because invariably it will stretch a little more. Surti, we'll give you 45 minutes for this case. And could we switch it? 45, Guru? Yeah, we switch it to 45.
Good morning, respected teachers and my colleagues.
Just one small request, because because of the prevailing situation, I'd request 5 or 6 or 7 people max to examine a case, because it's good for you and them as well. And we also request the same people not to come back. If you want, at the end of the day, you can go to the ward and see patients. Here it becomes a little difficult. So please bear with us. Thank you.
Good morning, respected teachers and my colleagues. Mr. Raju Raghavan, 66-year-old male, he's resident of Kerala, he's a businessman. He presented with chief complaints of breathlessness on exertion since 15 years, palpitations since 2.5 years, and giddiness on exertion since 2.5 years. Patient was apparently all right 15 years back when he noticed that he is becoming breathless while climbing 2 flights of stairs or walking up to 2 to 3 kilometers. It was insidious in onset, gradually progressive, such that he becomes breathless while climbing 1 flight of stairs or walking up to 50 to 100 meters since the last 2.5 years. There is no history of PND or orthopnea. There is no history of respiratory tract infections, cough or expectoration. No history of fever. The patient also complains of palpitations since the last 2.5 years. He insidiously noticed it while lying down, and he describes them as slow, regular, and forceful. He also noticed that the palpitations are increasing on exertion and relieving by rest gradually. Patient also complains of giddiness on exertion since 2.5 years. He developed this complaint while climbing stairs, which was around 2 flights, and that was 2.5 years back. It has affected him such that he does not exert more than 10 meters currently. And it was associated with slight blackening of vision, field of vision, but it was not associated with complete loss of consciousness. There is no further history of syncope. For the above complaints, for the complaints of palpitations and giddiness, the patient visited a local cardiologist where he was found to have a heart rate which was around 30 beats per minute, as so he was told, and he was also having his two valves were affected. He was told, and his heart pumping was reduced, and he will be requiring surgery for the two valves and pacemaker, and and the surgeries will be high risk because of his reduced heart pumping, and he was told to get it done immediately as soon as possible. On inquiry, he gives a history of swelling of feet since the last 3 to 4 months, which have been relieved after taking tablet called Tide, as told by the patient. There is no history of abdominal distension or yellowish discoloration of sclera or urine. There is no history of chest pain or hemoptysis or fatigue. There is no history of cerebrovascular accident or transient ischemic attack, or there is no previous history of any suggestive of acute coronary syndrome. There are no bleeding tendencies. On inquiry, further inquiry, patient gives history that when he was 10 years of age, he had fever and joint pains and swelling of feet, for which his father had consulted a local doctor, and it was relieved only after some 2 to 3 months. But he does not give any history of regular monthly injections, IM injections. Past history, he gives history of varicose veins surgery, which was done 5 to 6 years back, which was uneventful. And he gives a history of diabetes since 25 years, last 25 years, and hypertension since 1 year, since the last 1 year. His sleep is reduced, and he has difficulty falling asleep. But there is no history of altered appetite, bladder, or bowel movements. And he does not give any history of addictions. Treatment history, as told by the patient, he takes a tablet aspirin, tablet Rosastat, tablet Tide, and tablet Orsibest, and injection insulin, RNA.
Any other important history, because your time is short? Any
Yes,
important history there?
Yes, sir.
But see, your presentation language is not good at all. When you have taken the case?
Sorry, sir.
Last evening?
Sorry, sir.
When you have taken the case? Last evening?
So today morning, sir.
Today morning?
Yes, sir.
But the history is not very lucid. History presentation language is not good. Presentation not good. Local doctor, he should not gone to foreign. No, so I mean local doctor, local cardiologist. He considered physician or something, or on consultation he was diagnosed like this.
Yes, sir.
And he told like this. What he told, doctor told, this is not way to present.
Yes, sir.
That is okay. MBBS MD level okay, but DM level the presentation should be very good.
Yes, sir.
Very appealing.
Yes, sir.
So actually, in this regard, I keep repeating that there are two methods to present. One is the classical MD teaching, in which you start present illness, then go back, but the examiners will not have, especially nowadays with the OSCE type, and they will not have the patience to listen. So you go by the chronological events. For example, he started with a rheumatic fever, fever with joint pains, and then he was symptomatic or not symptomatic. So that will give the examiner the idea that he has had a rheumatic history. Then he was when did he become symptomatic? When did he consult the doctor? And when he was given the treatment. So that way it becomes more lucid instead of talking and going back to treatment.
Yes, sir.
And omit all the drugs which he is taking. It's not necessary. You can just say diuretics or some beta blockers or some, that's enough. You don't have to tell all the list of the drugs which are important, because that will give an idea that you have gone unnecessarily into some facts about history. And while elucidating the history, please stress on the important things which you have already said, like breathlessness, palpitation. That you have to elaborate in a little decent way. For example, PND, orthopnea with paroxysmal, with dyspnea, palpitations at rest, palpitations like that. So these are and giddiness. Giddiness also is an important symptom here. You have to say whether he has giddiness at rest even in the bed, which is a very important sign. You know what is the importance of giddiness in the bed or a syncope in the bed?
That's the cardiac etiology.
So it tells you that this is definite cardiac. Otherwise, it's very difficult. From pure vasovagal, you can have giddiness. Or fixed output states, you can have giddiness. But a giddiness in bed or something like that, tells you that there's likelihood of cardiac being the most.
And moreover, also don't translate the patient's language in English. You have taken the case, you present in your own language, not patient language. He has been told, he told like this, what he told.
Same thing I'll finish it off with pregnancy. Pregnancy is a very important thing, especially when valvular disease and worsens. So at that time, before pregnancy start, during pregnancy, what happens, and what happens in the last trimester, delivery, and following delivery, what are the symptoms have increased or not. So that will give us a complete history. So keep it as brief, and because even though we call it, it's not a long case, it's a short, long, or it's a very, so keep it as brief but informative.
Analysis.
I think before you go, I think I'm quite okay with your history. Would you like to say something more? Family history, personal history, quickly?
Not contributory.
What did you ask in family history?
No, I asked her that in economics you mentioned that.
Personal history mentioned.
Sorry, sir?
Personal history or is it?
Yes, sir. He gives history of diabetes since 25 years. And
Personal history.
What about his
sorry,
smoking
sir,
habits,
sleep is reduced.
alcohol?
Sleep is reduced. Denies any addictions. Otherwise, appetite and bowel bladder habits are
It
unaltered.
is not personal history.
Does he smoke
No, sir.
tobacco?
No, sir.
Have you
Alcohol?
mentioned angina pectoris here? Have you
Yes.
mentioned? No angina.
No, sir.
Okay, fine. I think we can go ahead.
Actually, even one small point is you must mention, especially in this case, where you are considering rheumatic, the overcrowding, the state of the socioeconomic status, and the environment which he lives still has relevance in our country, though we have progressed. But how many people live in one room? This will just give an importance to the examiner that you have gone through the important etiological factor.
He belongs to the upper middle class of Kupuswami's case.
Yeah, I think we didn't give a time to complete our history. Yeah, go ahead.
I'll summarize. A 66-year-old man with complaints of breathlessness on exertion in VIH functional class 2 since last 15 years, which has increased to functional class 3 since the last 2.5 years. With history of palpitations and rest, slow, regular, and forceful, and history of exertional pre-syncope present. After consulting the cardiologist, he was told to have slow heart rate with disease of two valves, which will require replacement, and reduced heart pumping.
Reduce?
Sir?
Reduce what? Reduce?
Reduced heart pumping was told.
Oh. Reduce pumping that.
Yes, sir.
What this is what medical term? Summary means you have to give medical
Sir,
terminology here.
LV dysfunction.
Huh?
There won't be presence of LV dysfunction, sir.
I think summarize in your words, basically, short, yeah.
So presence of, he also gives history of presence of pedal edema.
Give a history from here, provisional history from provisional diagram from history.
So chronic rheumatic heart disease with severe mitral stenosis. Mitral stenosis with severe, there might be presence of aortic regurgitation with complete heart block. And severe AS also. So history gives history of exertional pre-syncope.
Why? Pre-syncope has got heart block you're telling, no?
Yes, sir.
So why do you see AS outstenosis there? No angina.
Sir, he's it is exertional, sir. It is not at rest. Pre-syncope is exertional.
That means pre-syncope doesn't occur in heart block in exertional. Heart block, heart rate increases. How much increase heart? Infrahissy block. Heart rate will increase. How much
No,
will
sir.
increase?
A heart rate will.
because of pre-syncope, you are thinking of aortic stenosis. Why can't you explain it due to heart block? Because you are diagnosed heart block and advise oxypretinoline.
Can be explained with the presence of heart block also, sir. Because calcific aortic stenosis can present with complete heart block.
You mean rheumatic heart disease, metastasis, and calcific aortic disease, and
Yes,
heart
sir.
block secondary to aortic valve calcification.
Yes, sir.
The reduced heart rate, you said 30 per minute.
Yes,
What do you think could be due to anything else?
Sir, I asked him if he was started on any medications before, but he was not any rate
Which
control
medication?
medicines. Beta blockers, sir. Usually prescribed for severe MS.
What else do they receive usually? Valvular diseases, heart failure?
Digoxin, you know, what is digoxin?
Digoxin.
Yeah, should think of that.
He has no atrial fibrillation history, atrial fibrillation. 15 years of history of metastasis, and how old is he? 66.
66. Sir, if he does not give any history of regular palpitation, palpitations are slow.
Atrial fibrillation in the presence of heart block, complete heart block, what will happen?
In the presence of complete heart blocks, sir, atrial fibrillation would not be noticed, sir.
Huh? Irregular.
Regular, sir.
Then
Atrial fibrillation might not be elicitable from history, sir. In the presence
but you
of
can
complete.
presume, no? You can presume could do atrial fibrillation there also. Last 15 years history of atrial fibrillation, heart block won't have any irregular heart rate.
Yes, sir.
Coronary not there. Coronary.
Sir, he does not give any history of chest pain. And though he is diabetic, breathlessness can be considered as angina equivalent, but he's having long-standing history of breathlessness. And since between the 15 years and last 2.5 years, he has not consulted any doctor for that.
So how do you say metastasis? Why not it's aortic valve disease plain? Valve disease, you know, valve disease. So that's why I think metastasis.
So because of long-standing history of shortness of breath, and also patient gives a history of some heart failure and joint pains when he was small, when he was 10 years of age. We associated rheumatic.
And from your history, how do you give a history of LV dysfunction? Diagnosis of LV dysfunction.
So he was told to have reduced function of heart.
Yes, told.
We'll go to the examination, Dash.
Patient is conscious oriented. He is afebrile. His height is 169 centimeters. Weight is 60 kg. BMI is around 20.5 kg per meter square. Pulse is 36 per minute. It is regular, high volume, no radiofemoral delay. All the pulses are well felt except for both posterior tibial and dorsalis pedis. They are not felt. And both the carotids are equal and there is presence of carotids.
Pathological.
Bilaterally not present, but most likely pathological.
Dorsal pedis postal not there. Is there any ischemic changes in it?
He is having hyperpigmentation of the lower limb, sir.
Huh?
Diffuse hyperpigmentation of the ankle, around the ankle joint.
Reduce.
It is in hyperpigmentation of the around the ankle joint, sir.
That because of the you had edema, no?
Yes, sir. Edema.
Patient edema, the long-term edema, will hyperpigmentation will get.
Yes, but he gives history that it has started to increase since last 2.5 years. Before that, he was having subtle discoloration, which had disappeared after his varicose vein surgery. And it has increased again since the last 2.5 years.
Both sides, dorsalis pedis and posterior are not well felt, you said.
Yes, sir.
And did you go up or look at the popliteal, femoral?
Popliteal is well. Yes, sir.
Some varicose vein surgery, you said.
Yes, sir. Varicose vein surgery. There are rounded scar marks on the shin of the tibia. Blood pressure is 160 by 60 millimeters of mercury in the right upper limb. Yes, sir. 160 by 60. Respiratory rate is 20 per minute. There is grade 1 pedal edema present, and there is hyperpigmentation of both the lower limbs with onychomycosis of the lower limb nails. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. There are no peripheral signs of AR or infective endocarditis. The jugulovenous pressure is 5 centimeter above the sternal angle with normal respiratory variations, and there is presence of Canon A waves in the jugulovenous pressure.
Canon waves there.
Yes, sir.
Patient atrial fibrillation.
Canon A waves. Yes, sir.
Canon waves. Sir.
Yes, sir. Canon A waves.
A waves.
Yes, sir.
Because
Canon.
when you say
What
A,
is the difference between canon and giant wave?
The giant A wave is compared to the height of the V wave. It is around 2 to 3 times the height of V wave. Canon A wave usually occurs because of contraction of the.
No, I'm not asking the pathophysiology. How to distinguish canon and a giant wave?
So Canon A wave will be regular or irregular, but they will be abrupt and they will be seen.
Timing, what is timing? Timing canon waves and giant wave same time or no different time?
difference in timing between Canon, when you say Canon waves,
Giant
and
A waves.
about A waves or giant A waves.
Giant A waves will be regular, sir. They will be.
No, canon wave can get regular also. We can get canon regular. What are the constant get canon regular canon waves?
Irregular Canon.
No, regular canon waves.
Isorhythmic AV dissociation.
Then you could then what else?
Presence of
Okay, fine. So what is timing of the canon and giant? Or same time or different time?
giant A waves will be before the occurring along with the C.
You should not take so much time in a DM or DNB for canon and giant waves. You will get minus 20 here.
Yes.
1 second. Do you have a OSCE station for GVP in the exam, please? So you have, if you have an OSCE station, then you please position the patient. You should know how to position the patient because they will watch that, the examiners. So at what position will you say that the GVP is elevated?
We have to prop the patient up to 30 to 45 degrees, and from the sternal angle, we have to take the highest level of the JVP.
You can do that, but the simple thing would be just to make the patient sit with the bed legs dangling, and anything above the clavicle is an elevated GVP. That's enough. If you want to actually measure the pressures, then you'll have to put it in 45 degrees decubitus, and then measure the.
No, he can also, no, upright person can measure.
Yeah, upright only. Supposing the JVP goes up to the vault, cranial vault, like in constrictive pericarditis, you are not seeing the upper limit. Is there any method to estimate the central venous pressure? You know of any method which you can roughly estimate the CVP in case you can't see the JVP? JVP has gone into the neck, even on
Brain.
sitting position.
Brain. So giant wave is atrial contraction only, no?
Yes.
Atrium is contracting. Yeah, because RV compliance is less. Or there is trachea could be. Or right atrial myxoma, like that conditions. But your what is that? Canon is RV contracting when LV is contracting.
So it will be close.
So it is systolic. It is perisystolic.
So for the method called Gottner's method, identify a vein in the forearm, lift the hand above till it disappears and measures the vertical height from the sternal angle. It will give you a rough estimate of the DVP in case you are not able to see the upper limb.
So he has got giant wave or Canon waves now?
Canon.
Okay.
On inspection and palpation, trachea is central. Apex beat is in the sixth intercostal space in the mid-clavicular line. It is heaving with medial retraction.
Before we go to the cardiac examination, in general examination, you should always talk about the dental part.
So there are no signs of, no peripheral signs of
Did you talk
aortic
about-
regurgitation.
Dental,
Dental examination.
you should,
Yes.
particularly valvular disease, what is going to be intervention, surgery, you should all think of this.
No caries.
I think ladies and textbooks talk about that you should talk about the dental status.
The apex beat is in sixth intercostal space. It is in the mid-clavicular line. It is a well-sustained lift with medial retraction. And there is a grade 3 parasternal heave present. There are presence of epigastric pulsations and palpable P2 in the second intercostal space. No other palpable sounds or on percussion, the second intercostal space is dull. The right heart border is along the sternum. The left heart border is along the apex. The left seventh inter. Yes, left grade 3 parasternal. Second intercostal space is dull. The left heart border is along the apex. Left seventh intercostal space is resonant and the right fifth intercostal space is dull. Auscultation, the S1 is soft.
So you go to auscultation. Can you get some picture on what the patient is having? This is what they will ask. So can you see from the JVP, the pulse, the precordial examination, what the patient is likely to have? Pulse, of course, you've got a diagnosis. JVP also, but still other things.
There is presence of LV type of apex. So and it is a well sustained lift. There is presence of LV outflow obstruction, severe AS present, and there is also presence of severe pulmonary hypertension. There is diastolic shock and grade 3 parasternal lift, epigastric pulsation. That could be associated with the long-standing mitral stenosis.
What do you think? So you got complete heart block.
Yes.
Mention that side of that heart.
Complete.
And you got wide pulse.
Yes. 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 No thrills. There is a LV type of sustained apex.
Hi, yes, but bradycardia. Yes, bradycardia. There could be out.
And then-
Also, wide pulse, so you can expect some heart block.
Why do you say outer stenosis? I'm not busy. You gave first the outer stenosis, not able to audible? Thank you. How do you say give it outer stenosis without a thrill? Wide pulse pressure, 160 systolic, 60 diastolic, heart rate is 130, common waves. Can you give outer stenosis diagnosis? I don't think you can give it outer stenosis diagnosis.
There might.
Mitral stenosis, because?
There is a diastolic shock.
No, because of lung history and diastolic shock. What is diastolic shock?
P2 is palpable.
That's what. So you will summarize this when they ask on the basis that the JVP is showing cannon waves. So I suspect, and the heart rate is slow, so there is complete heart block. The apical impulse is of heaving type, and it is situated what? It is down and out, or it is in the same space?
It is mid-clavicular line, but sixth intercostal.
Sixth space. So that's an important point because the position of the apical impulse in combined valvular disease is the most important determinant of which is the dominant lesion or not. So that you have to say. You can't say now whether there is mitral stenosis or there is, the only thing you can say is that you've got some evidence of pulmonary arterial hypertension as evidenced by P2 palpable, diastolic shock, and epigastric pulsations which you have seen.
Yes.
So tricuspid regurgitation also you can't make out at the moment because you've not noticed anything on the JVP or on the liver pulsations.
So,
So that much is enough for the.
can we long-standing heart block can produce LV enlargement?
No.
What about heart block?
It causes, it can produce.
Won't produce a sustained apex.
Yes.
It produce sustained apex, won't produce sustained apex. So you are thinking there is some lateral pathology in terms of, valvular pathology,
Yeah.
because it is multiple disease, you think of some aortic pathology. So white pulse pressure could be aortic incompetence, or there could be some aortic stenosis, but I'm not getting pulpal thrill not there. Carotid?
Carotid thrill is present.
Carotid thrill there, but aortic thrill not there. How come carotid thrill there, but the no thrill here? You can get a carotid, murmur can get, how could you get carotid thrill without a thrill in aortic area? How to explain it? You mean there is additional carotid stenosis there?
Associated with the aortic.
Has got syncope, giddiness, could it be carotid stenosis, carotid disease there? You have to discuss these things. You have to.
So if you have got an OSCE on palpation of the apical impulse, put the patient on the left lateral position. Don't forget these things because the examiner is watching you. He's not going to sit nowadays in the DMB exam. This is an OSCE type. So put the patient on the left lateral position, try to feel the apical impulse, but localize it in the supine position. And sometimes you can make the patient sit up and auscultate, put your hand from the back and try to see the character of the pulse. And look for lateral retraction, look for medial. So the only things you have to say when you are in OSCE.
So that means certain nature of the apex, lateral position. Localization, position of the apex in the supine position.
Is it possible that the thrill of aortic stenosis may not be felt in patients who have emphysematous chest?
Yeah, but he has got loud P2, so probably may not.
That should be also felt.
May not be emphysematous.
On auscultation, the S1 is soft, A2 is inaudible,
S1 soft. Then
A2 is inaudible, and P2 is loud.
E2 not audible.
Not.
S1 soft.
Yes, sir.
Anything you have to specify on S1? What is this case?
Because of complete heart block.
No, then what do anything have to qualify some S1 here, or just S1 soft you would say?
No, because of complete heart blocks.
I don't know. You have to tell.
Long-standing MS can produce long-standing calcific MS. S1 can.
Or my S1. Complete heart block. How do you describe S1? S1 is constant. What is the diagnosis in atrial fibrillation? Complete heart block. Only told diagnosis. So S1 is uniform intensity, complete heart block. What is your diagnosis? And what should be S1 in complete heart block in sinus rhythm? Sinus rhythm, complete heart block, what should be S1? And uniform intensity S1, what is the diagnosis? So this is very simple question. This is
S1
the MD level question.
S1 will be soft, sir.
What's up?
In atrial fibrillation,
Complete
And-
heart block, what will be S1?
complete heart block.
S1 will be variable intensity. And S1 uniform intensity, complete heart block, which condition will get?
Sinus rhythm, sir.
At AFib.
Yeah.
You understood or not understood?
Uniform intensity of S1 will present in AFib, sir.
In complete heart block.
Complete heart, in complete heart.
In atrial fibrillation, what happens S1?
So without complete heart.
Obviously,
Sir, it will be loud, sir.
loud. Atrial fibrillation, S1 will loud in atrial fibrillation. Why loud?
Sir, S1 is dependent upon the gradient between the LA and
In
LB.
the absence of atrial stenosis, patient has a low atrial fibrillation. What will S1?
Variable, sir. S1 will be variable.
Okay.
No other sound.
We got a sustained apex, no, or nothing, no,
No, sir.
no history, no. history.
So A2 is soft. What about P2? P2 is
P2 is loud. Sir.
And it's also heard at the apex.
Yes, sir.
But you didn't feel, she didn't feel A2. A2 is absent told, but only pulmonary component is loud.
There is a grade 3 high-pitched blowing pan-systolic murmur at the apex, which is increasing on hand grip.
In the heart grip.
There is a mid-diastolic murmur at the apex, which is best heard with the bell of the stethoscope. It is radiating to the axilla, sir. Radiating to the axilla. There is a mid-diastolic murmur at the apex, which is best heard with the bell of the stethoscope, and it is increasing on expiration.
Yes, sir, this is my, sir, all the when I distinguished exams, sir. Does it require at DM level or a DNB level, the best heard in the bell stethoscope or diaphragm required? I don't think so it's required. MDM therefore is here a consultant to consultants. No, I'm just asking all the exams are yes, sir. I don't think so. MDM based on the bell stethoscope not required. I think so. In DM level, DNB level, okay, MBBS level, okay, MD level not required also.
Not be, but sometimes you know the fear of something, leaving out something and the examiner.
No.
pointing out.
What exam wants?
That is, that's
What exam
also.
wants?
Examiners don't mind. Examiners, in fact, nowadays there's hardly any time. So you better rush through the findings. You don't have to say bell everything.
No,
Similarly,
even if they're there also previous, I don't think it is not required. MD based on the bell stethoscope. That DM level, sir, what, sir? You are an expert now.
What conveys the severity of MS, you know?
Sir, the A2OS gap.
No. Wait, in this case, A2 is absent. A2 absent, you told. And then
So one is A2. Anything?
Presence of loud P2, sir. Presence of loud P2 and epigastric pulsations.
proper
Length
tail
of the murmur.
murmur length to tell. Murmur.
Length of it is mid to late diastolic, sir. Length of the murmur.
Mid to late diastolic is severe MS or mild MS?
Severe MS.
There is only a pre-systolic component of a mid diastolic murmur. It's severe MS or mild MS?
Severe MS, sir.
Why is it severe?
So you people are all echocardiography generation. So all these questions, you think of echocardiography. So what will be the trace like in mild MS and what will be the trace like in severe MS? Severe MS it will be like this, and mild MS it will be like this. It's very simple. So it's always all these questions, think of your echo. You must have seen hundreds of echoes.
A long mid diastolic murmur conveys more severe MS, is it?
remember that the mitral stenosis murmur, when there is considerable mitral stenosis, doesn't go up to the, it doesn't happen in peace. Starts very early because it's inability of the LA to empty. So actually it starts very early. Almost like, early diastolic murmur. It doesn't start in true mid diastole. The length of the murmur is important.
Yes.
Pre-systolic accentuation only tells you whether there is a in sinus rhythm. That's an important. And rhythm disturbances, when you have atrial fibrillation also, you have to relate it to the length of the previous diastoles and systoles. Persistence of the murmur up to end of diastole in long cycle lengths tells you that it's a severe MS. So like that you'll have to. Yeah, there is no problem.
In atrial fibrillation, the pre-circulation also has some thought to assess the severity. If you still hear the pre-circulation or murmur, means it is severe.
An interesting question. What is the name? It's a little old data, but the new Bromwell has brought it back. I don't know why. What is the name given to the mid-diastolic murmur in complete heart block?
Right hands murmur.
Right hands murmur. It is called right hands. It was given up. I don't know. They have again brought it back for some reason, but it can occur.
Yes, sir. Now, leave more clinical, sir. Or clinically they have new problem. Okay.
So is it severe MS?
Now, this time now.
Yes, sir. There is a grade 3 harsh mixed frequency crescendo decrescendo ejection systolic murmur with mid to late peaking, and it is decreasing on hand grip in the in the right second intercostal.
Is more for uniform intensity or varying intensity?
Uniform intensity.
Uniform intensity.
Other system examinations is unremarkable.
What about in the OTK you mentioned about the diastolic murmur? What about the other murmur? You talked
No.
about the
No other.
no. And this murmur is conducted to carotid.
This is conducted to the carotids.
Quality of the murmur.
Sorry.
Quality of the murmur.
It is a harsh mixed frequency murmur, crescendo decrescendo with mid to late peaking murmur. Yes.
Any features of rheumatic fever, fresh rheumatic activity, endocarditis?
No, sir. No rub heard, sir.
So
No.
finish give a diagnosis now.
Chronic rheumatic heart disease with severe MS, severe mitral stenosis with moderate to severe aortic stenosis with mild
What is aortic stenosis?
to moderate mitral regurgitation and severe severe pulmonary venous hypertension, severe pulmonary arterial hypertension with sinus rhythm with complete heart block with congestive heart failure, sir. No signs, no infective endocarditis.
Congested heart failure.
Yes, sir.
Why congested heart failure?
JVP was 5 centimeter above the sternal line and having a grade 1 pedal edema, sir.
Anybody put in a congested heart failure nowadays? Function class 3, class 4 tell
Function class 3. Function class 3. NYH function class 3.
What you told severe MS, it is anatomical diagnosis. What is pathology valve? It is calcified, non-calcified.
Calcific MS.
We didn't get open snap.
No, sir.
So calcific matter valve and calcific aortic valve also.
Yes, sir.
Why calcific aortic valve?
Sir, associated presence of complete heart.
No, why it calcified everything? Why could be?
A2 is soft.
It is soft, aortic stenosis also. Because rheumatic aortic A2 is soft.
The presence of complete heart block also, which is suggestive of calcification, could be because of calcification of aortic valve.
Calcific aortic, why the calcific aortic valve severe aortic stenosis? Then why moderate to severe? Should severe aortic stenosis. Are you getting that murmur in the apex is because aortic stenosis or mitral stenosis? Mitral
regurgitation, sir.
Why not?
It is increasing with hand grip, sir. Whereas aortic stenosis murmur is decreasing with hand.
Increase rheumatic mitral valve disease increasing in hand grip.
Mitral regurgitation murmurs.
Mitral annulus is not elastic here.
There's a
Rheumatic valve disease that is severe calcific mitral stenosis. Mitral annulus is elastic. You mean it will increase on hand grip? MR murmur. How to differentiate MR murmur in the apex and AS murmur in the apex? How to differentiate?
hand grip will decrease the murmur of AS in the apex as well, sir, along with the right second intercostal space.
Can you differentiate if suppose an ectopic and then you have
Post-ectopic, there will be increase in aortic stenosis murmur, whereas mitral regurgitation murmur remains the same, sir.
Don't have anything else, the best method is use an inching technique. Auscultate in the second right intercostal space, second left intercostal space, and inch the stethoscope down towards the apex. If you find that the rate of rise the crescendo decrescendo quality of the murmur is maintained, although Gallaudet phenomenon can occur, we are sure it is aortic stenosis heard at the apex, because aortic stenosis murmur can be heard at the
Yes, sir.
And as we asked if there is a thrill, almost certainly it is aortic. Otherwise, if the murmur shifts in its characteristic, then likely that we are dealing with. Always this problem is there between MR and AS. Multi.
So there is presence of heart failure, sir. Heart failure can explain the
Heart failure due to matrix stenosis, heart failure due to aortic stenosis.
aortic stenosis, sir.
Why?
Moderate to severe, sir. Severe.
Or then you're thinking associated MR can produce or what?
My MR grade could be mild to moderate, sir. And apex is heaving
How
type.
do assess MR severity in the presence of severe aortic stenosis? How to assess severity of MR clinically in the presence of severe aortic stenosis? Because MR more accentuated, even though it's mild MR also.
So there will be presence of LVS3 will be present, sir. Severe MR.
And one more objection is, can you say normal sinus rhythm with complete heart block?
Yes, sir. Sinus rhythm, not
Yes.
sinus.
So using sinus, heart block every node level. Yes, that can be done.
Sinus. Normal sinus rhythm we cannot be, sir. But sinus rhythm we can say because it is the property of the SN.
And without ECG, I don't think clinically we can make it out. Like,
He got Canon waves.
When you say heart failure, you mean LV dysfunction, right?
Sorry, sir.
When you say heart failure, you mean LV dysfunction.
Yes, sir. LV dysfunction.
Heart failure is a clinical syndrome.
Yes, sir.
So I think the term you need to use is left ventricular dysfunction.
Left ventricular dysfunction.
Yeah. Yeah, AS or bradycardia, complete heart block related, whatever. No, biventricular failure she can say. But
No, sir, heart failure, sir, class, heart failure, no need, patient need not have S3 or S4. Patient dyspnea is heart failure. Patient dyspnea is heart failure. Huh? Yes, heart action. Go to
ECG X-ray,
sorry.
ECG X-ray quickly.
One,
Finish. We are at
yeah, one is.
So this is a 12-lead surface ECG with a rhythm strip with a normal standardization. It's a heart rate of approximately 30 beats per minute with QRS axis of plus 30 degrees. There is presence of marching through P waves and the atrial rate is around 75 beats per minute. Yes, sir. Suggest of complete heart block, sir.
give your interpretation.
Complete heart block, sir. Complete. Yes, sir. Yes, sir. There is a presence of left ventricular hypertrophy as well, sir.
Atrial less and ventricular more. And one association there. Which constantly get? Ventricular rate more than atrial rate, but there is association there. Tell one concern, one
Ventricular
concern.
tachycardia.
Huh?
Ventricular tachycardia.
Huh?
Ventricular tachycardia.
Okay.
are you surprised with your diagnosis and this ECG?
No, sir.
No, no RVH.
RVH not.
So you-
But left ventricular hypertrophy.
so your primary diagnosis was severe MS
Yes,
and
sir.
severe pulmonary hypertension.
That to 18 years history.
Yes, sir.
How do you explain that? Clinical correlation with ECG. Do you mean patient has got significant traxal disease? You presume, can you presume that patient has significant traxal disease?
Tricuspid valve.
Yeah. So that we are not getting pictures of RVH in ECG.
Examination, tricuspid valve disease was not elicited.
Okay, so that's fine. X-ray? Ventricular physics science arrhythmia.
It is not ventricular physics.
What is that?
After in patients with complete heart block and digitalis
That is clinical diagnosis or ECG diagnosis?
ECG diagnosis.
Tell us.
ECG.
So PP encompassing the
Not
arrow.
exclusively in complete heart block, it can occur in movements type 2 below the His bundle. The PP interval enclosed by a QRS complex is shorter than the PP interval without the QRS. So there's an influence on the ventricular contraction on the
Janus node.
gate.
So, respirophasic and ventriculophasic. So this is chest X-ray PA view. Well centralized overexposed film with a cardiothoracic ratio of approximately 0.55. And there is the right heart border is found by there is the aorta and there is presence of RA enlargement. The left heart border is found by the dilated aorta and the apex is LV type of apex.
No, this is not what to read actually X-ray. X-ray you have to read like methodically. You told that is PA view, AP whatever. Then DCT ratio, the configuration of the contour.
LV type of apex.
Then go to right side.
Right atrial enlargement is seen, sir.
Then
Ascending aorta looks dilated, sir.
back down. Then
And the
if you congenital heart disease, what is right aortic arch, left aortic arch, then below aorta, pulmonary vein.
it's left-sided aortic arch, and there is apparent unfolding of the aorta, sir.
Hmm.
There is a presence of no, sir. Sir, the carinal angle is not splayed, sir. It is still acute, and there is no the left heart border is also not straightened. There is no atrial appendage enlargement. And
how to
double
explain
atrial shadow will also.
How
be
to explain that clinically? I mean, ECG there no, RBS not there, and X-ray also there is no alien enlargement. But you told severe MS, 18 years history or something else you told. So, do you think that he has got, it is congenital evok or acquired evok from ECG? Most probably? ECG.
ECG
Is from ECG congenital or acquired?
congenital, sir.
Huh?
Congenital.
Congenital. Do you think all the symptoms because of heart block now, patient develop aortic stenosis? No pain in no pain in orthopnea.
Yes.
So do you think that it's all symptoms because of congenital AV block? And now patient has got aortic valve disease and
Yes, sir. Yes,
possible?
it can be possible, sir.
It's not mitral valve at all. It looks more like aortic.
And if you actually get AV block secondary to aortic valve calcification, what is the clearest complex you'll get? Narrow or wide?
So degenerative will have a wide QRS complex. Sir.
Where to invade? Is invade into his or below his?
It will be infrahesion block, sir.
Interaction, what kind of complex will get? Narrow or wide?
Wide, sir. Wide.
Huh?
Infrahesion is a narrow, sir. Narrow.
Narrow. No, you have to talk like this. You have to sell yourself in exam.
Yes.
Your answer is totally defensive.
Yes.
Who is not? See, in our time, before that, no, you answer everything but defensive, you won't get mark. Even if you answer everything.
So do you find aortic root enlargement in rheumatic aortic stenosis?
Severe migration, do you get aortic enlargement? So aortic calcification, aortic enlargement is not a feature with the associated severe metastasis and aortic stenosis. Angina not a feature. So aorta unfolding, aorta mentioning, ascending aorta dilated. How to explain this?
Degenerative aortic stenosis can cause
Degenerative aortic stenosis, what is age?
66 years.
Okay. Would you all because of complete heart block, because of a large stroke volume,
Yes, sir.
chronically large stroke volume,
It is possible.
possible. I put 160 blood pressure, wide pulse pressure. Okay, sir. So what is echo diagnosis? Just to give you.
So this is the parasternal long axis view with color Doppler across the mitral valve and the aortic valve. There is presence of calcific mitral valve and calcific aortic valve. See, sir. This is the parasternal short axis view at the aorta level. It is showing calcific aortic. This is the apical four-chamber view with there is a presence of calcific mitral valve. Both the leaflets are calcified. So LV function looks normal, sir.
Function normal.
Yes. Up looks normal.
What is the positive staircase phenomena? What is trepe? What is negative staircase phenomena?
The trepe effect is there with the increase in the heart rate. There will be increase in the contractility because of increased calcium.
Nobody asking the pathophysiology. Is there negative staircase there or no? Sir will tell because you are also
Negative.
not there.
I don't.
You read it. Okay. Yes. Bowdy's effect. Bowdy's effect. So does it is that because of slow heart rate, LV dysfunctions? May cause.
Because decrease.
So cardiology is vast subject, you have to read everything. Is it, do you think degenerative or rheumatic it is?
Degenerative mitral.
No, the annulus is what? Annulus free or annulus calcified?
Annulus is also calcified.
Look at the subvalvular apparatus. Like.
Sorry.
It's a chronic, if it is a 70, 60, 55-year-old rheumatic, so look at the subvalvular apparatus. Apparatus is not thickened at all.
No, sir.
Extending on to the mitral. But of course, that is producing metal stenosis.
So could not make out because of calcium.
Calcium, because he told calcium, because calcium could not identify. So how to confirm it is rheumatic, non-rheumatic? Supposing it is, how can you confirm it? How to?
During surgery, can you confirm it?
So there will be presence of subvalve disease also associated with mitral.
Clinically, I don't think because early happen is not enlarged.
No.
No, clinically, and on X-rays, I am telling you, X-ray is very difficult to say rheumatic, early not enlarged, happen is not enlarged. No, happen enlargement occurs rheumatic pathology.
Yeah.
No, what Ramkrishna, no, I'm
So
correct.
basically, even in surgery also, it will be very, very difficult once at this stage,
Yes,
extensive
yes.
calcification. Possibly if you find McCallum patch or something in the LA, then you may think of rheumatic. But otherwise, exactly valve pathology may look the same because it will be extensively destroyed and calcific.
Yes, sir.
What will you do for this case? What is the plan? Last question, or maybe what could you plan for this case?
Sir, replacement of the mitral valve.
No. Pulmonary pressure, what is pulmonary pressure? RBS पे कितना लिखा है? हाँ?
97.
Okay, severe PhD there, is it? So what is next? What is your next plan?
Stenosis grade.
Huh?
Aortic stenosis gradient.
What is your plan? Management.
Replacement of mitral valve, tricuspid valve,
Angiogram.
aortic valve,
Coronary angiogram.
coronary angiogram
Hmm.
before the surgery.
And heartbreak?
After the valve, a permanent pacing, dual chamber permanent. After the heart, after the valve,
What will do? Heartbreak, what will do?
after the valve replacement,
What will do? What?
dual chamber pacemaker, dual chamber,
Okay. Single chamber will work.
dual chamber, sir.
Why not single chamber? What would put the pacemaker? LV dysfunction, the LV ejection fraction is 35-40% after surgery. What pacemaker implant?
ERT.
Huh?
Yeah.
Huh?
The LV function less than 35%. In the presence of complete heart block, it's advisable for CRTP.
D or
Sorry,
Said P.
CRTP, sir.
Why not do the left bundle? Dual chamber pacemaker, left bundle pacing.
Left patient is having narrow QRS, sir.
It doesn't matter, no. Narrow case, what is the purpose of doing the dual chamber? Why we in presence of narrow QRS? Because LV dysfunction there. It won't further aggravate LV dysfunctions. So that is putting by pacemaker, no? So left bundle with right atrial pacemaker, why not?
So actually this, if you say the dominance of the heart, the valve disease, if you say it's codominant, severe MS, severe AS, you have a phenomenon of backward masking and you have a phenomenon of forward masking. So a severe MS can mask the symptoms and signs of AS, and AS can mask the symptoms and signs of MS. So that's what probably has contributed to the signs not getting through too much. What is second stenosis?
In patients with long-standing MS, long-standing mitral stenosis, there is the thickening of the pulmonary artery.
So in this case, a severe pulmonary arterial hypertension.
Thickening pulmonary artery.
Arterioles, sir.
Arterioles could give rise to a stenosis there and could impede forward flowing
Yes,
and
sir.
could also dampen the effects of a mitral.
Yeah.
Okay. I think it was a good presentation. It was, maybe because of the long, things that you are presenting after a long time, but you must be having classes, that is sure. But still, you did well. Only a few points, like Sir pointed out about the history, make it clear, and present most of the findings in a short time so that the examiners are not stretched too much. Even if they interrupt you, from that time. That's otherwise it was quite good. And
Sir, history pen in your hand. What question you expect? Of course, it depends on your presentation. But history should be very lucid, and that will give a very good impact on examiners. If you present history very nicely, good language, without any cogwheel interruption. So. No, narrow complex, up to his pathology is narrow complex. The patient doesn't have impressive block, narrow complex. Either immuno block or his block, narrow complex. When his block, rate is low, little.
so seniors will tell you about the OSCE type, but as far as cardiology is concerned, OSCE is pulse, evaluation of pulse, evaluation of the precordium, evaluation of the GVP. I'm sorry, evaluation of the GVP and precordium, and of course auscultation last. So examiners will be watching while doing all the maneuvers. Here, auscultating for AR, please make the patient sit up, bend forward. All that has to be done. So we are going back to olden times, but still, OSCE is the new word for the olden type of exams.
So I want one question to the learned examiners here. So we can't hit so many examiners like this in the dais. Has the time come to leave some of the routines like percussion and dynamic auscultation in everybody? So those things I think we may stop like.
Actually, that's very correct. Dynamic auscultation and not necessary for many of these cases. Only it has roles in HOCM or things like that, mitral valve prolapse and HCM. So other things are all, well, you don't have to. And unless MR and or you want to differentiate something like Austin-Flynn murmur from mitral stenosis, like that.
And percussion, I think we can practically leave it except for looking for situs and other things, I think, practically.
Yes. But in congenital heart disease, I suppose.
Maybe for situs and all that's useful for. But I think, sir, I think that time has come to leave percussion totally, sir, like from our exam systems.
The thrill and delight you get by bedside clinical examination, and when you see the results, you'll be thrilled. Of course, you without seeing a patient, you can get a diagnosis nowadays. But
No,
they should not take away our time spent with the patient, because it will establish a clinical rapport also with the patient in planning further treatment. And I'm sure, I think, as you said, you can get diagnosis even before patient comes to you.
No, I'm not arguing for that. I'm just saying the only percussion part in adult cardiology.
As an examiner, you should not fail a subject or fail a candidate just because there's missed some small minor findings.
Such cases perhaps does not.
Many of them actually they don't do it. Like it's a kind of a routine. They say that.
Remember
okay,
now with 12 candidates per day or 14 candidates per day, please hurry up. I mean, your descriptions, doing things must be much faster. Obviously, the examiners will give you a lot of time to re-auscultate, to refine. Now, I don't think it's possible at all. They have to be very fast. It's more objectivity. Remember all the steps.
Thank you.
Thank you, Dr. Smriti, for that case. And I thank all the examiners. Dasa, can I just ask you to please welcome Patnaik, sir, who has just joined us from Hyderabad. Thank you, sir, for coming amidst this pandemic time as well. So we warmly welcome you again to Speed 2020. Thank you, sir. Has Gigi Shetty sir joined us? Has Dr. Padmanabh Kamath sir joined us? We'll have the next case now. This will be presented by Dr. Shambhavi from our hospital, Institute of High Medical Science. And I request Madan sir, I request Prabhavati ma'am, and I request Kiran sir to please moderate this session. We'll have the same format, 45 plus 50. So there is a small request from the students at the back, speak into the mic, sir, because they can't hear it. Thank you, sir. And everybody can please take part.
Good morning, respected teachers and my dear colleagues. Today I am going to present. She is 48 years old female, housewife by occupation. Informant is self and husband, and the informants are reliable. Chief complaints of shortness of breath since 3 years. Complaints of palpitation since 1 year. She gives history of shortness of breath since 3 years. It was insidious in onset, and she could walk 2 to 3 kilometers and climb up to 2 to 3 flights of stairs. Then she used to feel breathless on walking 2 to 3 kilometers and 2 to 3 flights of stairs. But she could perform all her daily activity. And this shortness of breath has gradually increased since 1 year, and she feels breathless on walking less than 1 kilometer and on climbing 1 flight of stairs. But she can continue to do her daily household activity. There is no history suggestive of PND or orthopnea.
Hello.
She also gives history of palpitation since 1 year, which is insidious in onset. And the palpitation increases on walking, and she feels palpitations on walking 1 kilometer and climbing 1 flight of stairs. And the nature of the palpitation is it is fast in nature. There is no postural variation, and there is the palpitation is completely relieved at rest, and it is not associated with syncope or pre-syncope. She also gives history of giddiness in 6 months. She says that she feels giddy on getting up from sitting position for a long time, like when she's cutting vegetables for a long time and she gets up, she feels little dizzy. Otherwise, there is no history suggestive of syncope or pre-syncope. There is no history of bluish discoloration of the fingers. There is no history of angina. There is no history of fatigue. There is no history of history suggestive of rheumatic fever in the past. There is no history of bleeding tendencies. There is no history of prolonged fever, and there is no history of PNT and ortho. 3 years back, because of her symptoms, she consulted a physician, and she was diagnosed to have problem in the heart, and she was advised for a procedure then. But she couldn't undergo it at that particular point of time. Past history, there is no history of hypertension, diabetes, or similar any procedures in the past. Personal history, the appetite is normal, diet is mixed, the bowel and bladder is normal, and she has no addictions. Obstetric history, she is menstruating with regular menstrual cycles. She's mother of 2 children, and both the deliveries were uneventful. Family history, she is second order by birth, and she belongs to lower middle socio-economic class by Kupuswamy classification. And there is no significant family history. There is no history of sudden cardiac death in the family. Drug history, she says that she is on 1 medication which she takes 1 in the morning and 1 in the night.
What is the grading of dyspnea? Yeah, okay.
NYHA function class to patients who are having heart
No, in
disease.
her,
In her, sir, from function class 1, it has progressed to function class 2.
what is class 1?
There is no limitation.
You're talking about NYHA, right? Yeah.
There is no limitation of daily routine.
What way does NYHA 1 differ from CCS 1 if you're talking of angina?
Sir, in CCS, there's one also. There is there is no limitation of daily activity. In NYHA functional class 2, they include the number of blocks and the number of pairs. There's more.
No, did you understand? It's a patient with angina. CCS 1 and NYHA 1, is there any difference in grading? See, in CCS 1, it says angina on, strenuous exertion, whereas that is left unstated in NYHA. It's one of the limitations. It just says ordinary physical activity doesn't have any symptoms. It's NYHA. So currently she is in which class?
NYHA functional class 2.
Class 2. Okay. Regarding palpitations, was it regular, irregular? Did she
Sir,
say that?
it
Did you
was,
ask for that?
It was regular in type as per the history. It is regular in type, and it is only on exertion, sir.
Did you ask for polyuria? Do you expect that in this patient?
Sir, it is only exertional palpitation she's having, sir, not paroxysmal.
Correct. Okay. And giddiness is in 6 months.
Sir,
And
it is suggestive of postural giddiness. She says that when she's working for a long time, when she's sitting and cutting the vegetables, and when she's sitting for a long time and she gets up, she feels mildly dizzy. Otherwise, there's no syncope or no exertional syncope.
can you mention some conditions, not necessarily in this patient, where you get a history of giddiness on standing up?
Sir, it could be orthostatic hypertension associated with autonomic nervous system dysfunction, or she could be on drugs, diuretics, or beta blockers,
Which antihypertensives are most likely to produce
alpha
this?
blockers.
Okay. So in this case, what do you think for the
She is
giddiness?
on one drug, sir. She actually
What do you think is the cause for the giddiness?
orthostatic. It is orthostatic, sir. She says that she even mentioned the name of the drug. She was on metoprolol. Because
Metoprolol is given to so many patients. I mean, why?
or it
So
could
just
be,
metoprolol alone,
or it
why
could
does she
be
have, does metoprolol produce orthostatic hypotension? Is it common? Beta
Not-
blockers in general?
not common, sir. But
Okay, so then why does she have giddiness on standing up?
sir, it could be low cardiac output also. She could be having an obstructive lesion such that when she gets up, she's not able to produce the enough cardiac output. That's why it is causing cerebral hypo.
Are beta blockers used to treat postural hypotension?
Sir, POTS, postural orthostatic tachycardia.
A drug known to cause. In fact, they are used to treat postural symptoms. Secondly, you mentioned about 2 childbirths. When was the last childbirth?
It was some 15 years back.
15 years. So she was asymptomatic.
Asymptomatic.
You mentioned POTS. Do you get orthostatic hypotension in POTS?
There's no hypotension. Sir.
Yeah.
You having giddiness or exertion?
No giddiness.
So can you just analyze your history a little more and tell us, one, whether it's a valvular disease or a myocardial disease or a hypertensive heart disease? What's your assessment of the whole thing, and tell us what are the pointers favoring them?
Sir, she is having shortness of breath since 3 years and exertional palpitation and orthostatic orthostatic giddiness since 6 months, and she was diagnosed to have a heart disease. So I would like
Forget
to
about what she was told. Forget about what she, by your history, which all parts of the cardiac system would you like to keep it as a differential?
considering her age, I would like to consider bicuspid valvular heart disease. Bicuspid aortic valve with shortness of breath and palpitation.
Presenting as dyspnea, postural hypertension.
Or it could be
No, so in bicuspid, you're thinking of aortic stenosis, aortic regurgitation, or
both
mixed?
aortic stenosis, and she has developed palpitations recently. So since 1 year, she has developed palpitation. So shortness of breath could be because of diastolic dysfunction, and she might have developed some mild to moderate ER.
So why did you think of aortic valve? Supposing I say mitral
Correct.
valve, what made you think of aortic valve here?
It is an L.
Why aortic valve disease? Why not mitral valve disease? What made you, home in onto the aortic valve and
Sir,
say this is,
the
and that was
history-
bicuspid aortic valve? What made you do that?
So the history is short, sir. She's having 3 years, and then there is no history of fatigue.
Of mitral valve disease or aortic valve?
Mitral stenosis because of 3 years history.
Can it be an ASD?
It can be an age because she's having a shortness of breath and palpitation. And her age, she might be having symptoms.
So at your end of history, you should keep the diagnosis as wide as possible. It could be an ASD, isn't it?
It could be an age.
Can it be constrictive pericarditis or pericardial effusion?
She's not having abdominal distension, pedal edema. Right heart failure symptoms.
Are not there. So as of now, what are the three DDs?
I would like
DDs.
the LVOT obstruction. AST.
Does the patient actually have aortic stenosis? Then why are you stuck on, we are giving you hints that it's likely to be mitral. You may change your findings later, but by this history, it's more of mitral than aortic valve disease.
No angina, right?
No angina.
Palpitation, you think, is arrhythmic or volume overload?
Could be volume overload because she tells that she feels the palpitation is only exertional. It is completely relieved on rest. But she's on medications also. She might not be perceived that irregularity and paroxysm. Heart rate could be controlled.
So she was advised some procedure 3 years ago. What do you think that could be? Or you're leaving that out for the moment?
The AST closure of 48 years old. Valve replacement, maybe there.
So you said procedure, not surgery. So I was assuming that it was some kind of cath procedure.
ATMs.
Okay.
What other procedures we advise?
Balloon dilatation, coarctation of iron, ATMs, and PVBD also. But this patient does. Yes, CRT also.
Yeah. So could this just be a cardiomyopathy, dilated cardiomyopathy?
It could be a dilated cardio, but not angina is not there, but it could be a dilated cardio.
Could it be peripartum cardiomyopathy?
Sir?
Peripartum.
No, sir. It's like
Why?
15 years post peripartum.
Pardon?
15 years post.
Yeah. So that's not possible. But you should ask for a history of abortion or stillbirth. Sometimes you just ask how many children, and they don't mention this. So that also should be checked. Okay, please you can continue. Please continue with the finding.
Examination is febrile. Our weight is 56 kg and height is 147. MI is 21. Pulse rate is 76 beats per minute. It is regular. Brisk in nature. It is of bisperience. The character is bisperience. There is no radial or radiofemoral delay. The upper limb BP is 130 by 80. The lower limb BP is 140 mm. The skull and spine examination is normal. JVP is 3 centimeter above the sternal angle. It is pulsatile with a prominent A wave with a normal X and Y descent. It has normal respiratory variation and epitojugular reflex is absent, and there are no peripheral signs of aortic regurgitation.
Any peripheral signs of infective endocarditis?
No, sir. No
Rheumatic
evidence.
fever?
No evidence of.
आजकल बोलते नहीं हैं बच्चे, they don't mention rheumatic fever and endocarditis.
There is no fever.
It's a part of the general examination.
JVP you said is normal or normal?
Sir, it is 3 centimeter, but there is a prominent A wave.
Prominent?
A wave.
A wave. Okay. So JVP3 is it normal?
It is not raised, sir.
Okay.
But there's a problem.
All right. And prominent A wave. So what are the causes of prominent A wave?
Prominent A wave in patients where there is reduced RV compliance like pulmonary hypertension, pulmonary stenosis, RV ischemia, pulmonary thromboembolism, or Cannon A waves. Can
you tell me what the X descent is due to?
Sir, X descent is due to ventricular contraction. So
X descent. I'm not talking of ACV. I'm talking X descent. What causes the X descent? And there are two components to that.
the initial part before the C wave, it is because of the filling of the. Sir,
Initial part
there
of
will be pulling of the.
Go ahead.
Relax, after relaxation, then pulling of the other one. After relaxation starts. Then tracts of that dome or tracts valve are pulled down. Ventral contraction. Then CU due to what? Why CU mentioned CU here?
It is because of the doming of the tricuspid valve, or because the carotid pulsation can also be transmitted. JVP.
Hepatojugular absent.
Hepatojugular.
Can you tell me how you do it?
Sir, we'll have to apply pressure over the abdomen for
I think it is a better term is abdominojugular reflux than the hepatojugular reflux. Better term. Abdominojugular reflux.
30 seconds. We'll have apply the
30 seconds. 30 seconds nowadays. 10 seconds. So these are I is asking in a very very important things. Simple things, important things. If you can't answer properly, negative scoring.
Then what happens?
We'll have to say the raise in the JVP, which should be persistent for at least 10 to 15 seconds. Persistent raise in the JVP for at least 10 to 15 seconds.
Suppose you do press here for half an hour, will you remain elevated for half an hour?
After releasing the pressure on top.
Is there any correlation with the pulmonary capillary wedge pressure? Positive hepatojugular.
Positive abdominal reflex. Pulmonary capillary wedge pressure is
More than
12.
15.
15.
Serious palpation and palpation. The trachea is central and the apex is in the
But pulmonary capillary pressure normal, possible. Hepatojugular reflex positive or it is raised, but pulmonary capillary pressure is normal. Normal capillary wedge pressure or normal LVDP, whatever. Not possible or all the time it is correlation, 100% correlation. Oh, because
So hepatojugular reflex is a sign of what? I mean, when you say that hepatojugular reflex is a sign of LV failure or RV failure, or both? So, why can you explain the mechanism behind the an abnormal hepatojugular reflex?
abdomen. When we apply pressure.
Mic.
When we apply pressure, there will be increased venous return to the heart. If there is a failing left ventricle, right ventricle, it should increase in the.
So if it's only RV failure, isolated RV problem, can it be abnormal?
It can be.
Okay, so I think that was one of the possibilities.
Pulmonary capillary wedge pressure can be normal.
Yeah, but in most cases, almost all cases, there is a biventricular failure. And so it really reflects that even the left ventricular, left-sided filling pressures are elevated.
Is there any correlation with the jugular venous pressure and pulmonary capillary wedge pressure?
The jugular venous
RA pressure with pulmonary capillary wedge.
if the JVP. The pulmonary capillary.
Actually, there are three important signs which you must all read because it is there for heart failure. One, of course, is the hepatojugular reflex called Pasteur-Rondeau manual. And second is the orthoedema. And third is bendopnea. These are the three signs which physiology and its clinical implications. You will be asked in theory as well as.
Pulmonary capillary wedge pressure will be more than 22 if the JVP is more than 12. RA pressure is more than.
Correct.
The apex is in fifth intercostal space, medial to mid-clavicular line. It is LV type, heaving in nature. There is no epigastric pulsation. There is no parasternal heave. There are no suprasternal pulsations. There is a palpable S4. S4, ma'am.
What does it indicate? What are the causes of palpable S4?
It could be diastolic dysfunction, acute MI, anything which is causing left ventricular hypertrophy like hypertension, aortic LVOT obstruction can cause S4 or acute mitral regurgitation.
Non-obstructive hypercardiomyopathy, you will get L4, non-obstructive.
Sorry,
SCM without any LVOT.
without LVOT, yes sir, we can get because of diastolic dysfunction.
And if you have these conditions and yet you don't have an S4,
Atrial fibrillation.
one more?
Aortic stenosis.
Mitral.
What are the prerequisites for S4?
So the mitral, there should be no obstruction between the atrial and the ventricle. MS should not. And there should be atrial contraction. There should be a good atrial contraction.
Then
And there should be a synchrony between the atrium and the ventricle.
ventricle, if non-compliant ventricle.
In a complete heart block, you make an intermittent S4. What is wrong there? Intermittent S4 can get in a complete heart block.
Intermittent.
Yeah. If there is LV diastolic there, a long pair interval there, S3 there, that become very much S4 there, very much audible. One pair is long.
Intermittently.
Fundamental requisite is a stiff LV, isn't it?
Yes.
And everything is secondary to that. And that's why the atrial contraction becomes more pronounced. Okay. And the LV apex is heaving.
Heaving type.
The apex is heaving and LV type. Why did you say it's LV type?
Sir, it has a medial retraction, sir.
Okay. So some conditions where you get a heaving apical impulse, apex. Conditions where you get a heaving apex.
Heaving type of we can get an aortic stenosis. In LVOT, any LVOT obstruction, we can get a heaving type. We can also get this in LV dysfunction also, but there will be no force. It is the duration will be prolonged, but
Can you get it in aortic regurgitation?
aortic regurgitation with the LV dysfunction can happen.
What?
LV dysfunction with associated LV dysfunction, sir. Aortic regurgitation.
Acute AR can get LV4.
Acute AR we cannot get LVS4.
Why?
There will be premature closure of LVDP will be higher than the pulmonary cap.
The chronic severe AR.
One thing I want to clarify, like whenever you are asked LV apex versus RV apex, a very fundamental thing in cardiology. So what are the points? You cannot stop with only retraction. What are the other points you should say?
Sir, there is no
This is for
other.
the benefit of everybody because this is a common question in the exam. It's very fundamental.
There is no other evidence of.
If you have to teach an undergraduate, what is the first point you will teach?
Sir, whether if it is the position of the apex, sir, if it is down and out, it is LV type, and if it's only out is RV type.
So what are other points?
RV type will be more diffuse in character, and then RV is more diffuse compared to an LV
And
type.
LV will be?
LV will be usually confined.
It is
One-
very localized. It's almost
localized.
described like a ping pong ball. Like it just comes and hits in between the two intercostal spaces. And one more point in your DM level should be,
No evidence of there is evidence of pulmonary hypertension like parasternal.
so if you have a parasternal impulse, which is RV, if it is an RV apex, it will be contiguous with that apex. So otherwise, it won't be contiguous. You will have a gap in between.
When the LV is contracting and becoming smaller, why do you get an outward impulse? So with the onset of systole, LV is getting smaller. Why do you get an outward impulse? You expect that when the LV is getting bigger, right? Answer
Myocardium
into
is
the mic.
not circular. It's like a tower.
So,
In contraction, right? But
Use the mic.
teacher, come here. Got it.
Listening. Here the apex moves outwards.
How will you identify biventricular hypertrophy?
And there is L type of apex with parasternal epigastric. RV type.
Congenital heart disease single ventricle, adolescent. You may get LV as well as partial lift. Yes.
Some books are mentioning about this biventricular hypertrophy. RV is, when RV is enlarged, you get lateral retraction. When LV is enlarged, you get medial retraction. When both ventricles enlarge, you get median retraction. That means you get a parasternal lift, you get a left heaving apical impulse and an area of retraction in between called median. But it's very difficult to appreciate. I agree.
Time.
Especially.
If you get epigastric impulse, in my view, epigastric impulse as well as LV apex, that is biventricular. In what I understand, epigastric impulse, LV won't come to epigastrium. It has to be RV.
Even
Epigastric-
parasternal heave with the LV apex will also suggest that biventricular.
No, that's fine. No, I'm asking only single ventricle. Person has single ventricle, you get partial lift as well as your LV apex.
Percussion, the left heart corresponds to the right heart border is retrosternal. The hepatic dullness is in the fifth intercostal space. The stomach tympani is in the fifth intercostal space. And the second left intercostal space is dull.
Is what?
Dull.
What does it indicate?
Space within axilla or parasternal area is mentioned, no? The parasternal area or axilla,
Parasternal.
mentioned that.
What does it indicate?
There is no PH. There is no pulmonary artery is not dilated.
Any other condition, parasternal area is dull, pulmonary not dilated, and some other congenital heart disease.
Transposition.
What transposition?
Anteriorly.
What transposition? Who is transposition?
Iota, sir. Iota
What
anterior.
transposition? L or usually L or D? What transposition will get?
D malpost. LTG also we can anterior iota or D malpost greater.
L malpost or L transposition can get.
Auscultation, sir. S1 is normal. S2, both A2 and P2 is audible. And there is a narrow split. There is an LVS4. There is no LVS3 or no audible clicks. Auscultation. There is a harsh ejection systolic murmur of grade 3/6 in intensity, which is crescendo decrescendo in nature, late peaking, best heard in the left lower sternal border. It increases on expiration and it increases on standing, and it is not radiating to the carotids. The murmur decreases on hand grip, squatting, and hand grip and squatting. There is another harsh blowing mid-systolic murmur of
Normal decrease on squatting.
decreases on squatting, increases on standing.
Okay.
There is a harsh blowing 3/6 mid-systolic murmur or mid-systolic murmur, which is best heard, and it is radiating to the axilla. The same murmur is increasing on standing as well as expiration, and it decreases on the hand grip and squatting. Only two murmurs are there. The other system examination is no.
So both these are mid-systolic murmurs, right?
Sir, first one is an ejection systolic murmur, sir. Starting after A2, it's a gap after. Ejection systolic murmur will be a mixed frequency murmur, and it starts with A2. Sir. It has to start
Starts with
with
A2.
slightly.
P2.
S1, and it can go up
It starts with S1.
S1.
What is, so now you are getting into deeper and deeper now. So tell us like, what is early systolic murmur? What is the ejection systolic murmur? And what is a pansystolic murmur? When do the murmurs start? This is basic physiology. That's why these are all repeatedly asked.
The pansystolic murmur starts with S1, and it ends at 8. It can go up A2 or P2, sir. Can even cross the A2 and can be present up to P2. Yes, sir.
The pansystolic murmur, yes. Yes.
S1. Early systolic murmur is a decrescendo murmur. It starts
In
with
this
S.
case, sorry, I'm just helping you. In this case, if you find the ejection peak, where the murmur will start?
The systole and this with S1 after S1 start.
So where will be the ejection click?
So after the ejection click, it will start. Sir. Systole is. It starts in the early systole, peaks in the mid or the late systole, depending. Sir, S1 will be heard in this early systolic and ejection systolic. But in pansystolic murmur, S1, it starts with S1. So S1 will be soft.
You have to understand the fundamental physiology, like what are we are asking, which are the murmurs that will start in the phase of isovolumetric contraction? Which are the murmurs which cannot start in the phase of isovolumetric contraction? So that is where when it will start with S1, it has to produce a murmur in the phase of isovolumetric contraction.
A pansystolic murmur start.
And
Yes.
What about early systolic?
Early systolic murmur.
the mid systolic murmurs don't start with S1. There is a gap. So your
Closing tasty or acute.
This is large artery muscular VHD. What is the timing of the murmur? Large VHD, what murmur will get? Large VHD, but
get-
still left right sound there.
Get an early.
Early systolic murmur. Why? Latter part of the gradient equalizes, murmur disappears. Mid systolic murmur will get in VHD.
Because of the contraction.
Muscular VHD, small muscular VHD murmur. Or small muscular VHD also early systolic murmur you may get. Okay, sir. Please carry on, sir. Please. Sorry.
You said about early systolic murmur is decrescendo, you said.
Ejection present.
Where do you get decrescendo murmur? Early systolic.
Possible or not possible? Early systolic murmur can decrescent possible or not possible? The pathophysiologists know, they know hemodynamics. Early systolic murmur can decrescent possible? Gradient will come down and disappears later part of the systole.
It can be a
Acute severe murmur? What do you get? What kind of murmur will you get?
early systolic murmur, which is decreasing.
Murmur can
low pressure TR.
low pressure TR.
QTR.
Similarly, large VHD, moderate large size VHD, you can get early systolic murmur
And the
decrescent.
same way muscular VSD which closes during systole, 8 phase process.
Yes.
So remember, for everybody's understanding, it's if you find a murmur that is during the isovolumetric contraction, it has to be from LV, not connected to the great vessel. You cannot get a murmur starting when the valve is not open.
Yes.
The aortic valve and pulmonary valves are not open at the time. So you can't get a murmur because of ejection or flow or anything. So the murmur has to be from the ventricle. So from the ventricle means it has to be either to RA or RV or LV and RV. So these are the possibilities. So that's all, very simple.
Acquired heart hypertrophic cardio with no pH, mild pH, NYHA functional class 2. In sinus rhythm, there is no evidence of congestive.
What are the two murmurs due to?
Just because it is because of could be an MR because of HOC non-coapting of the because of the drag or the Venturi effect.
No, see, you are completing yourself. He is asking murmur due to what? He's not asking the pathophysiology, no?
HOCM.
HOCM. Next question, why are you getting murmur? Yes.
Sir, both the murmurs on the dynamic auscultation, both the murmurs are increased on standing and duration. And both the murmurs are reduced.
They are the same murmurs or different murmurs, first of all?
Both are different murmurs, but etiology is
How are they different?
Pathology one. Yeah?
HOCM with anterior TAMS with systolic anterior motion. An elongated anterior mitral valve, which can cause both obstruction as well as non-coaptation of the mitral valve, which can cause a murmur which is radiating to the axilla, it's posteriorly directed.
So you're saying one is due to LVOT obstruction and one is coming from the mitral valve. Is that what you're saying?
No.
No.
Both
Well,
are-
it's the same murmur
Yeah.
heard in two places. What are you saying?
It is two different murmurs, same etiology.
So two different murmurs arising, like something like the Gallivardin phenomenon, which is the one pathology, you're hearing it in two places. Is that what you're saying, or is it two different?
LVOT obstruction is also there, mitral regurgitation is also.
Okay.
Why is it not pansystolic?
In HOC,
Murmur.
in HOC, there will be this the drag or Venturi effect happens in the mid system, mid to late system during the contraction. So there will be systolic anterior motion as well as effect in the coaptation. So it happens in the mid to late system.
You got a consistent on the apex.
Then we should think of associated mitral valve disorder with HOCM. They can have papillary muscle disorders also. HOCM.
What happens if suppose the patient has a multiple ectopics? What will happen to this MR murmur here? Suppose the patient has got multiple ectopics. I know that multiple ectopics won't affect the duration of murmur MR. Suppose the patient has multiple ectopics, what will happen to MR murmur here?
So the MR murmur will with ectopics, the MR murmur will post system.
MR murmur will?
Increase. The intensity of the murmur will increase, but the pulse pressure will.
It will vary or will be uniform? I'm asking. It will vary or will be uniform?
It will vary, sir. The intensity of the murmur will vary. Post ectopic, it will intensity of the murmur will increase.
How?
Sir, there is increased contraction. Post volume will be increased. Sir. Post EPC, because of an ineffective ventricular beat, there is increased volume in the L, and the gradient will.
Your answer very defensive answer. Answer very defensive. You are thinking and answering, like thinking and answering. Answer very defensive. So it will vary. It won't remain uniform like increasing MR murmur.
Yeah.
Case of mitral prolapse only. Only mitral prolapse, no HOCM.
In
This case.
Sir, in this patient, there is a heaving type of apical impulse. LVS.
You are getting S4 got here, S4.
S4 also.
S4 heaving
S4
apex,
is acute MR, not in.
S4 and heaving apex is not feature MVPMR, is it?
Well-lit surface excision. Normal standardization is the axis plus 30 and is slightly to left axis. And there is,
Conform to your diagnosis.
sir, there is evidence of LVH, sir, as per the Cornell's criteria. There is there is no evidence of left atrial hypertension, but there is left atrial attachment. There is evidence of left ventricular hypertrophy.
Other QAs,
There are deep waves in P5. There are from P to P. Patient, we can get pseudo infarct waves. LV.
Why not do it because MR it is MR volume overload, narrow Q, tall T.
I asked about the QA.
The left atrium is not enlarged, sir.
MR.
LA is not much enlarged.
Enlarge also HSM, no?
Slightly absent. Significant.
LA enlargement.
ST depression?
The diagnosis, did you give obstructive hepatocardiomyopathy? And what was the S2 you said?
S4.
S2. What was the S2 like?
The narrow
Is a normal split?
narrow
There is no paradoxical split?
parad-
What do you get in HSM?
We can get a paradoxical split. Severe plane. We can get a paradox.
You may get paradox, but usually close split, no? A2 is delayed. A2 is delayed.
A2 is delayed.
Yes.
Hypertrophic cardiomyopathy.
It's
Which is seen in so many conditions, but
Activation of which?
Because of the LVH, sir. They're
LVH is seen in many conditions, but these Q waves tend to be a little more prominent in hypertrophic cardiomyopathy.
QAs are due to what? Normal QAs in V5, V6.
Okay, speak in mic, I'm not able to hear you.
The initial vector is septal depolarization, isn't it? So those are septal Q waves. When there is septal hypertrophy, you get the Q waves become more prominent, right? So again, probably, it could be a lateral infarction, not in this case, but otherwise asymmetrical septal hypertrophy.
How often ECG is abnormal in hypertrophic cardiomyopathy?
in patients symptomatic in 90 to 100%. Just
You look at pre-excitation, what do you think of pre-excitation?
sir, pre-excitation possible with certain genetic abnormalities like PRP, PKG, and nano.
Okay.
This is chest X-ray PAV, which is a well-sensitized film. The site is all.
I don't think X-ray can think of, I don't think they have a cardiomyopathy X-ray.
There's no. Is in the
I see the X-ray, I
cardiac
don't think
acceleration.
cardiomyopathy. Do you think, sir? Yes, prominent, what is there, X-ray? What is against hepatic cardiomyopathy, tell me?
The pulmonary bay,
So much pulmonary large and LV is not rounded up apex. LV apex are not rounded up suggestive of pressure overload. I don't think it is a case of hepatic cardiomyopathy. And
but there,
I don't think so. It is, what is your pulse like here? Pulse is, pulse what? Jockey pulse.
Jockey.
It's not hypercardiac pulse.
jerk,
P is so much enlarged. First time seeing sir in hepatic cardiomyopathy, I might have seen some hundreds of hepatic cardiomyopathy. P enlargement, so much enlargement in hepatic cardiomyopathy. And patient is long-standing. That means patient long-standing hepatic cardiomyopathy, long-standing MR, long-standing LV diastolic dysfunction. Heart is very small. Patient would have developed heart failure at least.
What is the dominant abnormality here? And so now what do you think?
there is no cardio.
Okay.
LVOT
What
obstruction is the
abnormality?
dominant.
What is the dominant abnormality that you find here?
LVOT obstruction.
No, in this X-ray, what is anything abnormal at all in this X-ray? Or is it a normal X-ray?
Or is it because of the positional defect, they are left radical away from the sternum? Is it because of positional defect?
It's not well.
It's not symmetrical X-ray.
What happens when it is not well centered and actually rotated in this way?
This atrial abnormality, like we can have a falsely
Because that only, no?
enlarged.
Yeah, so the PA can be a little more prominent. But nevertheless, I think the only dominant thing is that the pulmonary artery seems prominent here.
So pulmonary artery.
Yeah, I think we don't have much information here. We should go to the echo.
So I think that because of what, sir, because of the position not correct, the page is looking like that or what? I don't think it looks like a hepatic cardiomyopathy X-ray. Huh? Rotation. It is all because of rotation. I think.
So this is parasternal long text. There is significant septal hypertrophy as well as wallet, and it is asymmetrical hypertrophy. The AML, there is a systolic anterior motion of the septal leaflet, which will have
Most
to come.
important, LA enlargement not mentioned.
LA is enlarged. Sir. There is mitral regurgitation, which is a posteriorly directed jet, sir.
So why is it important, direction of the jet?
Because tells the pathophysiology of mitral regurgitation in HOCM. If it is a posteriorly directed jet, it is related to SAM, and if it is an anteriorly directed jet, it is mitral abnormality.
What else are seeing? The septum looks like granular appearance there, no?
It's a four chamber, apical four chamber.
Okay, fine, just fine, that's okay. Why not a cardiac amyloidosis? I mean, we may not be confident. Why not?
One of the differential should amyloidosis.
Then tell me what do you expect here?
ECG, there is evidence of LVH that will not, and there's no pericardial effusion. This patient.
And internal septum.
IS also will be thickened in
Not thickened.
amyloidosis.
RV?
RV is it's not hypertrophic. RV is Sir, amyloidosis RV will be hypertrophic, sir, but in HOCM also we can get some variants, but predominantly if it is an RH suspect, amyloidosis.
I don't think you answered the question. You always listen to the examiner's question. Yes, is it a restrictive pathology that you get or is it an obstructive? I'm sure you know the answer. I'm just saying, always listen to the question and answer according.
Restrictive RCM.
Usually,
Fine.
they can have mild peric.
So pericardial lipogen, biventricular involvement, and intrathecal septum thickening. Okay. And static physiology. And this will go. 50% amyloidosis may not get low voltage complex. 50% get low voltage complex.
Will you cause a prominent A wave here?
Because of the septal hyper and because of the Barheim effect.
Because of?
Again, Barheim effect. Because of the shifting of the septal.
So RV compliance is less here, you know.
RV compliance because of left ventricular involvement.
How will you treat this?
Patient has a resting
Before
gradient
that,
of
can she give the complete diagnosis?
acquired heart disease, hypertrophic obstructive
Congenital heart disease. So my take is that just say structural heart disease. That's enough. Say structural heart disease, severe hypertrophic cardiomyopathy. That will be an ideal method. Otherwise, you can neither say congenital nor you can say acquired, nor you can say.
Do you think this was present at birth?
No.
Yeah. So that's the confusion here. It's not strictly speaking congenital and yet it's often genetic. How often is it? What is the inheritance if there is
There's an autosomal
dominant? In what percentage of patients do you find that?
0.5 per 1,000.
No. What percentage of patients have this autosomal dominant? Autosomal dominant means you go to the family, you'll find history, right? That's not always found. Roughly 50%. So your full diagnosis? Structural
heart, hypertrophic cardio with no pH, mild pulmonary
hypertrophic obstructive or non-obstructive?
obstructive.
Hypertrophic obstructive cardiomyopathy.
No evidence of pH, mild pH, NYHA functional class 2. The patient is in sinus rhythm, no evidence of heart failure. No
CHF. You said no
systolic
CHF.
dysfunction, no evidence of systolic.
Because class 2 patient, the Saros pointed out, it can be heart failure, like in the broader sense. Always in this, our clinical context say no congestive heart failure.
Yes. No. ECG.
Also give the risk of sudden cardiac. You got all the findings. What the family history, what the findings. What is the risk?
So what are the
Sudden cardiac-
predictors of sudden death in hypertrophic cardiomyopathy?
The gradient, sir, the resting gradient is more than 100. Then the posterior wall thickness more than 30 mm.
Posterior. With posterior wall thickness, right? Any wall thickness.
Wall thickness more than.
Then
There is an apical aneurysm.
but family history didn't tell no.
There is
Family history?
family history of sudden cardiac death.
What
There
family
is-
history? What? Family history means what?
The patient's age less 40 years.
Family history means what? Wife supposing sudden
Family
cardiac.
history of sudden cardiac death.
अरे फॅमिली मीच होता सबची वाईफ साठी कडे
Blood
First degree
relative,
or
first
second
degree
degree?
blood relative.
They will ask, do a dynamic maneuver. And in this condition, of course, you can't be doing Valsalva and proving. Do only a simple dynamic maneuver, and that is called stand, squat, stand. First, ask the patient to stand, demonstrate the murmur, what happens, squat, and stand. And you have to also stand, squat, and stand along with the patient.
So, what is HOCM score?
European ESC has a score, sir, low, intermediate and high, plus 5 is low risk.
What are the echo parameters in the score?
LV wall thickness, the LVOT gradient, the apical aneurysm. The LV mass they have used. So there is a logarithmic.
LA volume. LA volume is
LA.
there. So what is the, how the two guidelines are different in terms of risk stratification? ACC versus ESC. Because HOCM is a common disease. You are likely to encounter in each and every HOCM, you have to do this risk stratification.
So the new guidelines included history of recent unexplained syncope, family history of sudden cardiac death. The LV wall thickness, it is more than 30 for these score more
There is a fundamental difference between both of them. The ESC gives a score, and according to the score you are supposed to give. Whereas ACC says that the score is not very predictive. It is better to individually discuss the various risk factors and discuss with the patient, and physician takes a combined decision.
What about a history of NSVT or VT?
now, according to the ACC AHA guidelines, they have told that NSVT, it is in children, they have given more importance for NSVT in children. So it is a 2A indication in children, but in adults it is 2B indication, if there is an NSVT.
Sudden cardiac death is more common in younger or older patients with HCM?
Younger patients, less than 40.
Any more imaging method to increase your?
So I would like to do an MRI also, sir, for risk stratification. Apical LV aneurysm can be missed sometimes, and also the LG also we'll have to look into the LG. More than 15% is significant.
You didn't say it's an unexplained syncope.
Unexplained
The
syncope.
first thing you should start with a pre-resuscitated cardiac arrest. That's a class 1 indication. There is no doubt about it. Then you can.
secondary prophylaxis. Primary prophylaxis, other thing primary prophylaxis.
Yes, sir.
How do you treat her now?
Sir, sorry.
How do you treat her?
So this patient is in NYHA function class 2, sir, and she's having this might not be the gradient of LVOT. Based on the LVOT gradient, if the resting LVOT gradient is more than 100, it is a 2A indication. And if she's in NYHA functional class 2 or 3 or 4,
What is the indication like? 100?
100 it is a 2A indication, sir.
For what?
Sir, we can first we'll have to see whether we can do a septal ablation or septal reduction therapy, sir.
You want to try medicines first, beta blockers or calcium blockers, and then
First
look
we'll
at
have
the
to give
gradient?
non-vasodilating beta blockers, and maximally tolerated beta blockers. If they're
Check the
not,
gradient again, isn't it?
yes, sir.
Okay, and
You wait for 100 gradients to intervene.
More than
So if
30
the patient is in NYHA function class 3 or 4,
Which
it is a class 1 indication, sir.
No. But it is patient symptomatic not because of arrhythmia, it is because of heart failure.
No, that's okay. But we are asking about
More than 50, more than 50.
what are the indications?
More than 50 is the indication, sir.
Either it is or
Rest are provoked.
Yeah, is at rest or provocable more than.
What about the drugs? You mentioned only beta block. Any new?
So mavacamten has been,
not this, not
how does it work? How does
sir, it
mavacamten work?
normalizes the contraction, LV contraction by decreasing the actin myosin binding, the number of binding. Decreasing the actin myosin.
Decreasing, yeah.
Any drug used to increase it?
Omecamtil.
Zolcampton.
Yes, sir.
What you use in this? You use drugs to stimulate the adenosine.
Omecamtil.
Inhibition.
Mavacamten.
Mavacamten.
Mavacamtil decreases the
Activator. Where do you
ATP
use it?
activators.
Where do you use it? Heart failure with registration fraction. What is the danger of using Overcampton?
What is the study known as?
Sir, Maverick HCM, Explorer HCM, Pioneer HCM, Valor HCM is the new.
What are the limitations or what are the precautions?
So it can cause LV dysfunction in HOC.
Periodic echocardiogram.
Here the gradients are very high, so what will you do? Like, if he is not controlled on beta blockers, will you go for myomectomy or will you choose alka septal ablation?
Sir, there is no intrinsic mitral valve disease, sir. So we'll have to inject and see if there is an adequate septal perforator. So if there is a septal perforator, we can go ahead and do a PTSMS.
Yetel, how do you choose between myomectomy and alka septal ablation?
Is it different, sir?
How do you choose?
Sir, based on the age of the patient, sir, and ECG abnormalities, if there is an LBBB that can cause a complete heart block with PTSMA, and if there is any mitral valve associated intrinsic mitral valve disease is there, then the patient has to undergo surgery. And if it's then excessively long AML also sometimes, and the septal thickness also, sir, if it is more than 28, then it is indication for surgery.
Very good.
28, what happened to?
28, sir.
What happened?
It is not
effective.
not suitable for PTSM.
And should be minimum, how much should be minimum?
Minimum 16 it should be, sir. 16.
14 to 18. Should the collaterals also septal giving collaterals to other artery?
Yes, sir.
So many things also. Supposing patient has got genotyping positive, pheno negative, what will get echo? Genopositive, pheno negative.
So they can have diastolic dysfunction and mitral valve abnormal.
Abnormalities. Okay.
So you can summarize how she presented.
I think the presentation is good, a little too fast. Probably should slow down a little bit. Give time for the examiners to assimilate and ask questions. Slow down a little more when you want them to ask a question.
Yes.
There are something which you have read and you know well. Spend a little extra time there. You can actually play the system a little bit. Or if you say something little unusual, make sure that you know the answer to that.
Yes, sir.
And you can actually use it to your advantage sometimes. Okay, but overall, good presentation and well done.
Thank you, Dr. Shamvi. Thank you, teachers. We'll now break for tea. We'll have to regroup really fast. I request the faculty to join me on the right side. We have the faculty room here and the delegates on the left side here, just outside the hall. We'll regroup in 15 minutes if possible. We are going to squeeze in a third case in this session. So please join us back.
Mic testing, check, check, mic testing, check, 1, 2, 3. Mic testing, check, 1, 2, 3, mic testing, check, check, mic testing. Mic testing, check. Mic testing, check 1, 2, 3. Mic testing, check, check. Mic testing, check 1, 2, 3.
Check 1, 2, 3.
Hello, Saira. Is it audible? Audible? Om Shri Sairam, check 1, 2, 3. Mic testing, check 1, 2, 3.
राधिका जीवना राधिका जीवना राधिका जीवना राधिका जीवना कृष्ण जनार्दना
Mic testing, check 1, 2, 3. Om Shri Sairam, check 1, 2, 3. Mic testing, check. Mic testing, check 1, 2, 3.
राधे गोविंदा राधे गोपाला राधे गोविंदा राधे गोपाला राधे गोविंदा राधे गोपाला राधे गोविंदा राधे गोपाला देवकी नंदना देवकी देवकी नंदना देवकी नंदना
Hello, Saira.
नंदना हे गोपिका रंजना
Hello, check. Hello. Hello, hello.
नंदना हे गोपिका रंजना नंदना हे गोपिका रंजना मुरली मोहना मुरली मोहना मुरली मोहना मुरली मोहना श्री मधुसूदना श्री मधुसूदना कृष्ण कृष्ण श्री मधुसूदना
So really sorry for this. The other thing is we are going to have each case of 35 minutes from now. Each case of 35 minutes from now. Okay. We're going to have 3 cases which will be presented by Dr. Vaibhav from Institute of Biomedical Sciences, Preparatory, followed by Dr. Renish. Is he here? From Jaydeva. And Dr. Kavya. You're presenting in order. So you will have Dr. Vaibhav presenting first, correct? Yeah, Vaibhav, correct. Then Renish, then Kavya. So can we start with the third case? The moderators will be Patnaik sir. They're all joining. Just a second. Patnaik sir, C.V. Patil sir, and Ramakrishnan sir. Kushal? Prasad, can you just announce once? Yes, sir. Yes. Sir, can I have C.V. Patil sir, Ramakrishnan sir, and Patnaik sir? Patnaik sir? Sir, can you just join us? Dr. Renish presents the next one, and Dr. Kavya follows up with that. Dr. Ramakrishnan sir, can you just tell sir once? He's just starting. Another small announcement is that we have on the next Sunday, we have the advanced echocardiography course in our hospital, which we call as SPACE. We will show you the brochures in due course. So we'll have Rama sir, C.V. Patil sir, and Patnaik sir moderating the case of Dr. Vaibhav, who's presenting from Institute of High Medical Sciences, Puttaparthi. Thank you. We'll have 35 minutes, Vaibhav, for the next 3 cases. We'll try to go 25 plus 10 because we want to put in more cases. Thank you.
Good morning, respected teachers. Yes, sir. Sir, my patient, Tua Chaudhary, she is 5.5-year-old female child, resident of Hubli, West Bengal. She is a LKG student, sir. Sir, with the history, sir, presently, child is totally asymptomatic, sir. So I would like to go chronologically, sir, basically. Basically, she is a full-term child, born with a non-consanguineous marriage. She is second in birth order, has a one sibling who is 14-year-old, and her mother has no antenatal or intranatal any cardiac history, and mother is non-diabetic, sir. And she is born in a middle-class family. And at birth, intranatal, there was no intranatal event, sir. At 1 month, child developed an episode of LRTF, for which she was taken to a pediatrician who on clinical examination, she wasn't hospitalized, sir, basically. So on clinical examination, who diagnosed her to have a hole in heart, and he was advised her to have the consultation, sir. On consultation, she came to SSH IHMS, sir. And at that time, there was one medication, one syrup was started, which used to increase the urination, sir. And she was told to follow up yearly, sir. Then they had a yearly visit, and on the second visit, that medicine was stopped, sir. And then because of COVID, they couldn't come in between. And just a few months back, they visited their cardiologist elsewhere, where she was told that hole has reduced, but she has developed some other problem, and told to consult at the parent institute. That's why they came here, sir.
What age is that
Yes,
first time diagnosed?
Yes, sir. Yes, sir.
First diagnosed at what age?
At 1 month, sir.
1 month of age.
Yes, 1 month, I say. And sir, child has a history of recurrent respiratory tract infections in the childhood, sir, which were in frequency of around 8 to 10 episodes yearly, sir, earlier. But at present, she rarely gets any symptoms, sir. And she doesn't have a history of bluish discoloration. She doesn't have a history of forehead sweating, feeding difficulties, dyspnea, syncope, loss of consciousness, or she doesn't have a history of convulsions, seasonal variations of the symptom. There's no history of hemoptysis, abdominal distension, feet swelling, or sir, the prolonged history of fever, sir. Only occasionally she used to get the fever. There is no history of any prolonged fever or rash, sir. And yes, sir. And the personal history, sir, presently the sleep, bowel, bladder, appetite is normal, sir. And sir, yes, sir. I'll summarize this. My patient, 5.5-year-old female child, resident of Hubli. She is second in birth order, born of a non-consanguineous, and presented had a complaint of recurrent respiratory tract infections. Yes, sir. Sir, recurrent respiratory tract infections, sir, suggestive of some shunt lesions, sir, and no bluish discoloration. Cyanotic congenital DD is based on the history, sir.
Again, attempt at summarizing the history.
Yes, sir.
Summarize the history in a better way.
Yes, sir. Sir, this child is a 5.5-year-old female child, had a history of recurrent respiratory tract infections in the childhood, which started since the first month of age, diagnosed to have possibility of a hole in the heart, and presently her respiratory symptoms and the recurrence reduced.
Post-tricuspid stent?
Yes, sir.
Is it a pre-tricuspid stent or a post-tricuspid?
Sir, before that, let him clarify.
Yes,
So
sir.
you told recurrent respiratory infection, it could be upper respirator.
Yes, good wish.
And also you don't mention that at what age there is reduction in the rate of a respiratory infection. You didn't
Yes, sir.
mention this
Since last the 2 years, they are saying, sir, it has reduced in frequency, sir. Earlier, it was more, sir. At around 2 to 3 years, she used to get 8 to 10 episodes. Now they are saying it is very occasionally only she is, and she can play with her peers normally, sir.
What is low respiratory, upper respiratory?
Sir,
Couldn't you mention those things?
Is there any definition of a pre-respiratory infection of?
Sir, more than 3 episodes per month and more than 6 episodes per year, sir, of RT. Quarter. Year.
At any age or only in infancy or early infancy respiration?
Sir, in more than 12 in infancy and then later.
Well, anybody in the audience?
6. Sorry, sir. 6, sir.
What? Upper respiratory, lower respiratory, you need admission?
Yes, sir. Lower respiratory tract infections requiring the admission, antibiotic, and
So you
hospitalization or
wait for 6
nebulization.
episodes before you intervene for a moderate VSD in today's time.
Yes,
Will you wait for a moderate VSD which is getting hospitalized?
yes, sir.
So for after how many hospitalization you are supposed to operate? Like?
After the recurrent hospitalizations are between the 6 to 24 hours, 6 to 24 months of the age, sir. Sorry,
In today's time, moderate VSD with severe hospitalization requiring admission
As
for
early as
more than a
possible.
few days, definitely everybody will operate in
as early
today's
as
time.
possible.
So those eras have gone, like you wait for all the recurrent infections to come. So what is the definition of recurrent LRTI? Like there is an IAP definition that is there. You are way off target, like from the definition. Anybody wants to answer this?
Indian Academy of Pediatrics has recently redefined this, and it has been accepted by the pediatric cardiology. I think it is classified as less than 3 years and more than 3 years, and I think more than 6 or something like that. But there is a definition which has come out in
Three.
three only.
Leading hospital.
It doesn't now tell anything. It just gives you the number based on less than 3 and more than 3, and it is
It is no longer
It's,
validated.
published by the Indian Academy of
Oral
Pediatrics.
antibodies are available.
So what is your diagnosis in this? What are the possibilities?
Sir, by history, sir, child is symptomatic, sir. I would like to give the history of cyanotic congenital heart disease with shunt lesions, mostly post-tricuspid shunt, sir. VSD or PDA, sir, or ABCD also cannot be ruled out.
VSD or PDA?
VSD.
So generally at what age VSD will present with symptoms?
Sir, in infancy, they generally present with the
At what
cardiac
age they
failure,
present commonly?
sir.
Do they present at 1 week of life, VSD?
Yes.
Yes?
Yes, sir, below
You can
6
put the
months.
question.
Why this question like? If it is yes, I won't be asking this question. They don't develop symptoms at 1 week. Why?
Yes, sir, because the neonatal PVR is high, sir. So that shunt is limited by the high neonatal PVR, sir, which on regression, patient becomes symptomatic, sir, after 6 to 8 weeks when the neonatal
So
PVR.
why you didn't answer it first like? This is a question that was asked. Like generally they present at
Yes, sir.
generally 6 weeks.
Generally 6
Okay.
weeks.
So what out of this VSD and PDA, which one will you keep first?
First, PDA will be symptomatic first.
Why?
Sir. Because it's a continuous.
In this patient, which one will you keep first, like VSD or PDA?
In this patient, sir, I would like to keep VSD as the first, sir, because.
Why?
Sir, because her symptoms are reduced after recently, sir.
Even in PDA also it can get reduced.
Sir, in premature child, there is a rarely it closes after 3 months, sir, and in full-term babies, it rarely closes after 1 year, sir.
It may not close, but it may reduce in size and the patient may tolerate it better. But that is more likely in VSD.
Yes.
And anything else?
Or, sir, possibility.
Patient may not be put on medical follow-up if the patient was diagnosed with a PD at say 1 year or so. Everybody will close it.
Yes.
You consider AS,
Yes, sir.
didn't you consider AS?
ASD, sir, in ASD, sir, less likely, sir, because
Why?
at this age, natural
Why,
history
sir,
won't
why?
go against, sir.
Reason?
Reason, sir, because in ASD, it's a low pressure stent, so the resolution of the neonatal PVR is almost normal, and the child becomes, the patient becomes symptomatic in just to reappear in the later age, sir. At the
Because in a given case, ASD is there but early present. The person.
early possibility is, sir, if it is associated with PAPVC, sir, or if it is associated with the like scimitar syndrome, sir, the hypoplastic right lung, sir. And or, sir, if it is very large ASD amounting to single ventricle child, maybe cyanosed also, sir. Sorry, single atrium, sir.
So like
maybe cyanosed also.
in extension to the previous question, like which are the conditions that present with heart failure in first week of life? VSD won't present, we discussed, but what are the conditions that present to you in first week of life? Cyanotic with heart failure.
It is short lesion or obstructive lesion or regurgitant lesion? Congenital heart is short lesion, regurgitant lesion, obstructive lesion. Myocardial disease is different. You think of that.
Sir, large PDA can present.
Large PD also for the same reason doesn't present. Unless it's a preterm PD is a totally different thing.
Short
Or,
lesion.
sir, Gerbold defect can present first.
Gerbold.
Common things first, like go to the extreme things later.
Heart failure in first week of life. Non-cyanotic heart, cyanotic, no?
Cyanotic.
Cyanotic heart disease. What are the congenital cyanotic heart diseases? Classify congenital cyanotic heart diseases.
Shunt, sir,
Congenital cyanotic heart disease. One shunt lesion. Then second.
sir, then obstructive,
Then obstetric. Then
LV obstruction. Yes, sir.
what are the obstetric lesions? You know, obstetric lesions.
Obstructive lesions, sir. Pulmonary obstructive lesion like pulmonary stenosis, pulmonary severe critical PS, sir, or sir, PS associated with other lesions, sir. Or sir, the aortic obstructive diseases like aortic valvular stenosis, subvalvular stenosis, or supravalvular stenosis.
Coaptation.
Coaptation.
Obstetric lesion. Then
So
any other
ductal coaptation.
then inlet lesions.
Yes, sir.
Inlet.
Sir, AV seats.
Inlet. Inflow obstruction.
Mitral, congenital mitral valve diseases like supramitral thing, or sir, single papillary muscle, or
So tell them what are the diseases can produce heart failure in first week.
the obstructive lesions like sir, critical CoA, sir, or the duct dependent circulations like sir, where the interrupted aortic arch, sir, can present.
So to cut the time short, so the important things are most of the times the valvular obstructions and the valvular regurgitation lesion, that are the ones that are going to present to you with heart failure in early neonatal period. So coaptation, various obstructions, AS, PS, AR, TR, MR, TR, these are the ones that are going to present with heart failure. So what is the natural history of VSD? Suppose you find a 1-month-old child has come to you with VSD, what is going to happen to the child? What is the natural history of such VSD? A moderate VSD, not a very large VSD. So what is the natural history of that?
Sir, if it's inlet type, it will never close, sir. Or if it is a perimembranous type or muscular types, can reduce the size, sir. And sir, or the PSD patient may have an acquired RVOT obstruction, or we develop a prolapse of RCC causing AR, sir. Or there can be a case. There is 10% chance of progression to pulmonary irreversible PH, sir.
So this is moderate VSD, like moderate is how often it closes.
Sir.
So suppose you find a moderate VSD at 1 month, at 1 year, how often it will close?
%30.
More than.
Type of yes, not close.
Sir, inlet type PSD never.
Study.
Sir?
What are the other types which do not close? Subpulmonic.
Subpulmonic will.
So one more thing is at what age isomerization happens? Like you find a large VSD, at what age the patient will become inoperable, can become inoperable?
Generally in the second decade of. Sir.
So you will wait, suppose you find a large VSD asymptomatic child, so you wait till the second decade of life before you send for surgery?
No, sir. If large
This is another common mistake almost everybody does. There are two things. When the patient becomes inoperable, the answer is can be as early as 1 year or 2 years. The patient can become inoperable by 2 years in a large VSD. Whereas the patient present to you with symptoms of Eisenmenger in second decade of life. These are absolutely two different things. Any large VSD can become Eisenmengerase or become inoperable. Most of them become inoperable by 2 years of life. So which are the situations in which isomengerization or the process of isomengerization can happen earlier? In VSD, which are the situations the isomengerization process can happen earlier? Somebody may become inoperable by say 6 months also.
Subpulmonic VSD, sir, or the VSD without.
So subpulmonary VSD develops more ascending ray syndrome. That I don't think there is a data like that. Syndromic, which syndrome?
Yes, sir, syndromic and especially Down syndrome.
They can develop early PH, isn't it? Yeah. So in a large VST, the better time is 3 to 6 months. You should be able to find out whether operability. If you go on waiting, probably they are going to. Yeah.
So I have one request to all the students, like what is the difference between the exam remain the same. The exam remain the same, the presentation remain the same. Your understanding of the natural history and the understanding of the hemodynamics is what matters. So all of you should be aware of all the common conditions where long case, short case are possible. You should know the natural history. For example, natural history of tetralogy, natural history of VSD, natural history of bicuspid aortic valve, MS, MR, AS, AR, all these things, data is there. And they're all written in good textbooks also. So you just have to read them. They're all, you don't have to read more than two paragraphs like in all of them. You should know that before you go to the exam.
You are not mentioned about AP window. How does it present? It has differential diagnosis.
First month. With it will present with CCF, sir. It will present with cardiac failure, sir.
Early failure. Early development of
Early
failures. Yeah, the cases are missed.
Early. Like a PDA, why do you develop early Eisenhower?
Sir, because there is a deficiency of aortopulmonary septum, sir. So the shunt is continuous even in systole as well as in diastole. So amounting to the higher volume pulmonary vasculature, sir.
So there is no length also. Like length produces some obstruction. Like for example, 1 millimeter a tube produces more obstruction than compared to 1 millimeter window. So for same amount of level, same amount of size, there could be length that gives you obstruction. But it is, for example, I think a window type duct should be the same like an AP window.
How a symptomatic VST can become asymptomatic by itself?
Sir,
What is the mechanism?
yes, sir. That mechanism, sir. Either, sir, there will be the prolapse of RCC causing a closure, but it might be associated with AR also. Or there can be a aneurysm of membranous IVS, sir. Or there can be a prolapse of the septal tricuspid leaflet, sir. Or there can be a acquired RVUT obstruction like visualization, sir.
Isomerization also can make them asymptomatic for some time.
Eisenhower can due to symptoms?
Because of increasing here, sir, if venous return will reduce, sir. And sir, with the obstructive changes in the pulmonary vasculature, sir, the frequency of RTI will also. Sir.
Increase. RR pressure increase.
RV pressure will increase, sir. But pulmonary blood flow will reduce, sir.
Okay, go to examination.
One very simple question, like why do VSDs have recurrent respiratory infection?
Because of high output states are causing
Is it a high output state? So your measure the cardiac output will be high.
left right shunt are causing pulmonary bleeding. Basically, these weight lungs will be more prone to the infection, sir. Child will more.
Wet lungs is a very non-technical term.
There, the pH will be high, so cardiac failure.
Is there PVH like? In a VSD, common ground VSD, will there be pulmonary venous hypertension?
Mind, sir, because of increased pulmonary venous returns, sir, there.
No. Anyway, it's a homework for everyone. Quickly give the examination point.
Sir, my patient is conscious, oriented, cooperative. She is febrile. Height is 110 centimeters, sir. Weight is 14.9. Upper lower segment ratio is 1, sir. No dysmorphic features, sir. Dental and throat examination is normal, sir. SpO2 is 98% in all 4 limbs, sir. Pulse is 98, regular, collapsing type, sir. There's no radial or radiofemoral delay, sir. All peripheral pulses are well felt, sir. And sir, GVP is normal, sir. And BP is
No, like, no DM exam, you can say that JVP is normal and move on.
Yes.
It is not possible, like.
So, JVP is normal, sir, not raised, and A wave more than V wave, sir.
What you have to say, one is venous, height of the venous column
Yes, sir.
and wave pattern, both you should.
So you say that JVP is not elevated
Yes, sir, it's
and
just,
all the waveforms are normal and there's no hepatojugular reflex, respiratory variation. These are the things that you should say in a DM exam.
uh, 102/42, sir. And in right upper limb, in left upper limb, it is 100/40, sir. And lower limb, it is 170 systolic, sir. Wide pulse and sinus. Systemic examination, sir. On inspection,
Why do you get collapsing pulse?
sir, because of diastolic runoff.
So this is another common problem. Like, is it a systolic event or a diastolic event? Pulse. So you have a diastolic runoff, but pulse is a systolic event. So then how can diastolic runoff produce collapsing pulse?
Sir, it's because of high systolic and low diastolic pressure, sir. Of reflex, baroreceptor reflex activation, sir, causing a reduction in SVR, sir.
So basically, primarily there's a large volume of blood that is collected to get a rapid ejection, then there's a vasodilatation that is producing the rapid fall. So what is the health sign here?
Sign is
68,
70, sir.
70.
BP is 100/40 system.
So what is the latest controversy about hill sign? What is the
Say
problem with
it's,
hill sign?
Mercury, spigmomanum.
What is the controversy about hill sign? It has come in now, Brownwald also. Is there any controversy?
Say it's a auscultate. Might not, auscultatory illusion might not.
Might not be like what
Intra-arterial pressure differences might
Intra-arterial pressures are not different,
not.
significantly different. It's a peripheral phenomenon.
should you still use it? Like, basically it is still useful. If you go to the English literature, it's quite a good. This is one area where I think sensitivity specificity have been taken out, and hill sign is a decently sensitive and specific AR investigation. Those studies are published in Annals of Internal Medicine, so they're still good. But it may not be a true phenomenon.
At this stage, what is your differential diagnosis? We are stopped here, what is the differential?
Sir, differential diagnosis with child VSD progressing with restrictive VSD with AR, sir, or even PDA
Or
possibility.
it was PDA? None of them.
Or even the, but at this age, sir, less possible, but RSOV. Right.
Does VOD predispose to RSOV?
Yes, sir.
Based associated RSV. PhD patient who? PD possible here?
Yes, sir.
PD not possible.
Sir, actually, PDAs are possible, sir, because wide pulse pressure is
No.
sir, but
Because you told what patient now. The PD
yes, sir, but
associated
symptoms are
with
reduced, sir. That is going in against the history, sir. System.
Carry on.
Sir. Inspection, sir. Chest is symmetrical. Trachea is central, sir. Precordial pulsations are seen, sir. Suprasternal and neck pulsations are also visible, sir. There is no dilated scars or epigastric pimples is not visible, sir. On palpation, sir, trachea is found to be central, sir. Apex beat is left sixth intercostal space, lateral to mid clavicle line. There is a palpable in left.
What about apex? Like anything more?
Yes,
What
sir.
character, LV or RV?
Yes, sir. It's a LV type. It's a sixth intercostal lateral hyperdynamic LV type with medial retraction, sir. And sir, it is palpable. There is a palpable pill in the left third intercostal space. Sir. Parasternal heave not palpable.
One small point is that thrill is always a palpable thing, so I don't have to say palpable thrill. So thrill is there, you can.
You have to say whether it's systolic or diastolic.
You tell timing of thrill, systolic or diastolic?
Sir, the thrill is systolic, sir.
The diastolic thrill,
Sir, eight-
systolic thrill.
Yes, sir. It is a systolic, sir. Percussion, sir, left heart border correspond to apex, sir, and right heart border is sternal. Stomach tympani is on the left side and liver dullness is on the right side, sir. Left second intercostal space is dull, sir. On auscultation, sir, S1 is normal. S is, sir, normal in intensity, sir, single and not loud, sir. Probably it's just beat. And sir, S3, S4, I couldn't appreciate, sir. It is expected, sir, but I couldn't appreciate, sir. Click is not. And there is a grade 4 harsh pansystolic murmur loud and is heard around the left sternal border, most prominent in the left third and fourth intercostal space, sir. And sir, there is a
Picture the murmur, lot of things you haven't said.
it's a high pitch, sir. Is it?
What character, any specific character is there?
Sir. High pitch grade 4 harsh pansystolic murmur crescendo decrescendo and is loud. And
Crescendo, you expect a pansystolic murmur to be crescendo, decrescendo?
No, sir, no, sir, it's a pansystolic murmur, uniform murmur from 1 to S1 to S2.
Go on.
Sir, there is a long diastolic murmur, sir, of long early diastolic murmur, grade 3, fixed frequency, sir. It is heard along the right second intercostal and left third intercostal.
Which frequency? We're getting lot of things mixed now.
High pitch frequency. Harsh
Harsh
murmur?
high frequency.
High frequency.
They don't go to.
What is the character of normal simple AR murmur of idiom? What is the character like?
Sir, decrescent.
Decrescendo, but what is the pitch and what is the
Decrescendo and sir, acute and in acute and chronic mild it is short.
not a chronic severe AR, classical AR that you get in round the mill case in your exams? What is the typical description?
Sir, long
Long will depend on the duration, will depend on severity of AR. But what is the character, typical character? How do you describe an AR murmur? High pitch or low pitch or mixed frequency?
high pitch.
High pitch. So what is the character, typical character of an AR murmur?
Then high pitch of blowing.
Sir, high pitch, yes, sir. So high pitch, soft, glowing,
Soft
and
glowing.
decrescendo
Is
and
it
long.
like this
diastolic.
here or it's not, it's different? Huh?
Like this
Then
one.
why did you say it is mixed frequency and all those things?
And sir, there is
No,
a-
this is very important. Well, because tomorrow will be teacher for the undergraduate postgraduate students. Understood.
sir, there is a ejection systolic murmur in the same, sir. So,
Describe full in detail. Like these areas, you should not give the examiner any opportunity to ask questions. Like you should be full thorough in the description of murmur and all. Description of murmur, JVP, pulse. The examiner should not open the mouth.
ejection systolic murmur is great. It is soft in left, right second and left third intercostal space, sir.
So what is the
And it
most
is-
important character of a ejection systolic murmur you are looking at? Like for example, you describe duration of the murmur. You said long
Loudness.
duration in idiom. What is the most important character you are looking at in ejection systolic murmur?
And sir,
Duration
loudness,
and peaking of the murmur.
peaking,
So
sir.
where is it peaking here?
Sir, early peaking, sir.
So you should say that. Why are you allowing us to ask these questions? You say early peaking, you would have come to diagnosis by now.
Separate.
ESM, he say third and fourth intercostal space.
Yes, sir.
Where is the pansystolic murmur?
Would be a restrictive ASD, sir.
Where it is? Yes.
Sir,
Place of murmur.
sir.
This pansystolic murmur, where is it heard?
is in left third and fourth.
So you are describing three murmurs.
And ejection murmur?
Ejection murmur, ma'am, in aortic area, ma'am, right, left, right second and
Right or left?
right second also.
Acha. Hmm.
Three murmurs. Or two.
Grade 3.
One diastolic murmur and one systolic.
One
Or two systolic
one
murmurs.
diastolic.
No, don't say yes to everything. You just decide what you want to present.
This pansystolic murmur uniform intensity or there is mesosystolic accentuation there? Uniform intensity. Okay.
Is there any carotid thrill? Carotid. Huh? Carotid thrill is also. Carotid.
Pulsations are seen, sir.
Are you thrill? No thrill. Okay. Hmm.
Very important. You have to decide if there any alveolar obstruction there.
No.
Not there. Why systolic component you are giving so much importance?
Second, just split.
Single, sir.
Which one had here?
Sir, it is P2 is heard here, sir.
Huh?
P2 is heard, sir.
P2 absent.
P2 is heard. A2 is absent because of severe AR.
Apex what are you getting? Apex, how many sounds?
Apex only one sound. So apex only S1 and murmur.
So normally engulfing A2 or it is A2 soft?
Maybe it may be engulfing or A2 is very soft and inaudible, sir. Inaudible.
Okay. Hmm.
Where is the murmur best heard? The VSD murmur, whatever is the PSM, where is it best heard?
Sir, so perimembranous.
No, in this case.
Area.
Left third and sir.
Or higher up, like.
Higher
What
up,
is the
is,
importance, like?
higher up is ejection systolic.
No, right side. Right side is this. Left system. Left also.
Where do you find the loudest murmur in this patient?
Sir, loudest murmur is in the left third interval.
What is the, whether it is third, fourth or second, what is the importance?
Sir, in case of PSD, sir, more likely the perimembranous if is heard in left third and sir, subpulmonic will have a lower, it will be heard in further lower spaces like
the lower space,
fourth or
pulmonic. Where is the pulmonary valve?
Sir,
It's
Which one higher? Pulmonary valve higher or outer valve higher? Then?
In
in
fact,
second.
the subpulmonic murmur is taken for a PS. The confusion by way of character as well as.
So, what is your diagnosis?
Side, so sleevocardia, sir, a congenital heart disease, left to right shunt with restrictive VSD, sir, with severe AR, sir, no signs of infection. Patient is in sinus rhythm.
I think, to many due respect to chairpersons, whatever thing that beyond your situation, if you are getting a thrill, grade for a 6, you can add. Provisionally, there could be elevated obstruction because based natural history, patient may develop solid membrane, may not be very severe. And third, you may add arbitrary obstruction also, because this patient may develop arbitrary obstruction also.
Sir, could be because
Could
of
be.
that
I'm not
RCC
sure,
prolapse
could be.
itself could
If you are
be.
getting a thrill.
So, what is one finding that is against your diagnosis, whatever you described? Ejection systolic murmur can be that. So, where is the AR murmur best heard in this patient? Right side or left side?
Sir.
In this patient, it's heard in the aortic area or neo-aortic area?
Aortic.
It's more heard in the aortic area than the neo-aortic area. So there your high flow may be there, you can get an ESM. ESM is not against your diagnosis. One thing is absolutely against your diagnosis, which is the heart of auscultation.
No, sir.
So why you have a single S2?
Sir, because of absent or very soft inaudible A2, sir, because of AR, sir. Yeah, value.
Does it happen like in VSDR?
Sir. Slightly, sir.
What do you expect in a VSD, simple common garden VSD, or what do you expect the S2 to be?
Soft.
The split of the S2, will it be single or
Without pH, it will be normal, sir.
in VSDR, you don't expect pH. By and large, in VSDR, you don't expect pH.
No, sir.
So what will be the split of the S2 will be?
S2 will be normally split, sir, and A2 will be soft and as compared to P2, sir. Because of
Say that B2 may be louder.
why is the A2 soft, sir? Sir, because of prolapse of one of the cusps, sir, that apposition of the valve will not be.
Correct, sir. Prolapse.
Yes, sir. Or could be
Once you have depends upon the severity, air is more, certain
sir,
air is more.
actually, and then
Air is moderate severe air, VSD,
Yes.
long-standing VSD air, what will get A2, S2?
Then the other questions will come like, did you auscultate while lying down, standing for the split? How do you look for normal split like?
Sir, in sitting, sir, in sitting or standing, sir, we'll look for the splitting, sir, properly. Because that respiratory variation will be accentuated, so we can better appreciate it, sir.
So suppose if this is single,
Yes, sir.
so can you keep a possibility of a pink top with air? If it is truly single,
How do we check it off with air? Sir, but in that case, first thing is that RV will be hypertrophied, so I should get a parasternal heave and RV impulse.
Top you won't get
That I-
any RV. Well,
in top you don't get like a parasternal heave.
Sir,
Because top is there.
At least epigastric.
So generally
And
top pink,
apex will be RV type, sir. Here apex is type and down and out, sir.
generally pink tetralogy means good pulmonary blood flow. That means pulmonary annual size will be reasonably good. So they generally don't develop AR. Very rare. Comparatively, it will be lesser in, and then at this age, top developing AR is extremely unusual.
Is it RSV?
Sir, at this age, unlikely, sir.
Age ಮಾಡಬಹುದು, age ಸರ್. RSV clinically RSV?
VSD as such can lead to RSOV, sir, but there will be signs of, there should be signs of CC.
And so what?
better answer.
If it is ruptured sinus, sir, there should be an acute history of acute
No, no,
or
sometimes it
acute
can be present
decompensation.
chronic. The best answer will be cannot be ruled out. But to get a to and from
Any other differential diagnosis you can keep like, can it be subaortic membrane with ASAR?
Could it absent pulmonary valve? Absent pulmonary valve.
Doubt and
Loud?
doubt and flow murmurs, sir, with the RV is not, sir, here. And sir, that apex is typically LV type and down and out, sir. That is going against, sir.
What is the murmur in PR, low pressure PR murmur?
More definitive thing will be
There will be a
presence of
typical
peripheral signs.
cease
You have
of
presence of
murmur and
peripheral signs of
peripheral
AR are there. That's very important.
Peripheral signs of ear and hill sign also, sir, is coming.
Okay, let us look at ECG.
Sir, can I stand that side?
Yeah. Is it in favor of VSDAR?
Hold it that way, sir. No, I'll hold it that way.
Sir, 12-lead surface ECG of a 5-year-old female child, sir, with showing a sinus rhythm, sir, heart rate of approximately 100 per minute, sir, with a QRS excess of around 60 plus 60, sir. And sir, there is a left atrial anomaly is present, sir. There is LVH is present, sir. And sir, in mid-precordial lead, sir, both RV and LV waves, catch watchel phenomenon is present, sir. And RVH is also present, sir. Biventricular hypertrophy is there.
No, why do you say catch-watchel? Where is catch-watchel?
In a moderately or sir in large VS.
Ecuphagic 30-30, no? Above 30, below 30, R 30 is 30. Ecuphagic, so not there. RBs there overlapping each other, difficult to say.
And sir, there are deep QRs in V4, V5, V6 showing a volume overloaded LV, sir. It's
Is the RV there?
sir.
RV is there or not?
Yes, sir. V1 is more than 7 mm, sir. RVs.
What is axis now?
Almost 80 degrees, sir. Left.
So LBH with the right axis possible.
What is the axis? Yeah, what is the axis like?
Here, sir, it's almost around 80 degrees, sir. So along the
Always tell axis in the multiples of 15. I don't know how do you calculate 80?
Sir.
Multiples of 30 is also fine.
60 degrees, sir. Actually,
Towards 80, 80 20, yeah.
yes, sir. Actually, sir, they are.
So what are the chambers enlarged here?
Sir, there is RVH, there is LVH, and there is LA abnormalities also there. Sir.
Okay, show X-ray.
This is a the chest X-ray PA view of a 5-year-old female child, sir. It's a showing a well exposed but not well centralized, sir. The EP chest X-ray PA view, sir. It is not well centralized, sir, and showing that stomach double is on the left side, sir. Right side dome is high, sir. Pulmonary parenchymal appears to be normal, sir. There is a right heart border is formed by the sir RA appears to be as per X-ray, sir. It is covering more than 3, sir. It looks at that, sir. LV type of apex, sir. No cardio, no water, no cardio.
Sir is asking question.
Now, clinically, you said there is down and out.
Yes, sir.
Not
Yes, sir. Maybe because of rotation, sir. So that child is tilted to one side, sir, in X-ray, sir.
good defense. The pulmonary blood flow line.
Sir, there is a pulmonary PV, the MPA and RPA are dilated, sir.
Why not because of rotation?
Sir?
MPS because of rotation, Euclid rotation, no child deformity chest wall. There is little bit of narrowing of the left intercostal space, so there could be some kyphosis.
But
Why this shape enlargement? It is all because of positional.
there's Simon is yes, sir. Yes, sir. Yes, sir. It can. There can be a.
Pulmonary plethora not there, no. Pulmonary vascular not increase.
Pulmonary vascularity is.
Yes.
Expect a small VSD or large.
CG.
This X-ray is against subaortic membrane that the professors asked you. Subaortic membrane, yes, sir. Is it against or in favor?
AR we can say, sir, because of that aortic knuckle is prominent, sir.
Subaortic membrane outer ascending out want to dilate it.
Oh, sir, ascending aorta in
And a severe AR is not a feature of subaortic membrane. Severe is feature of subaortic membrane. Unless patient has got valvular endocarditis and valve destruction.
Let us look at echo. Not giving much information.
So X-ray is both diagnosis put together. What is the diagnosis?
So that is the aortic arch right sided or left side?
Yes, sir.
Aortic arch.
Aortic arch is on the left side, sir. That.
How do you say that?
That notch on the trachea appears on the left side, sir. indentation on the trachea is on the left side, sir. The parasternal long axis, sir. Parasternal long axis with color Doppler, sir, showing a yes, sir. Sir, parasternal long axis, sir, with color Doppler, sir, showing a VSD jet and sir, I'd like to see in a short axis, sir, about the RCC.
So you
sir,
want to see other views?
RCC prolapse, sir. Yes, sir. There is fluttering of AML was present.
Where is the VSD?
Sir, this is a short axis at aortic wall level, sir, showing a RCC prolapse or causing a AR. Sir.
Is it close to the pulmonary wall or away from?
It's more close to the.
In echo, how will you localize the VSD?
Sir,
This
in this view, sir, subpulmonic will be at around 1 o'clock, sir, position, sir. And sir, perimembranous will be between 11 or 12 o'clock. Here it's at perimembranous.
It is 12 o'clock here.
Sir, 11 o'clock.
In this it is at 12 o'clock. Yeah, there are, yeah. There are two jets. Are you able
Two
to see
jets. Sir, that two jets are confusing, sir. It could be that prolapse.
Yeah.
That RCC.
You can summarize the echo diagnosis and say. Summarize whatever you've seen.
The
Want to say any more views? We'll show.
A comment on AR also.
Sir, there is
Subpulmonic VSD with ARs.
Subpulmonic. See, that is the location for pulmonary. It's more common with subpulmonic or subaortic?
Subpulmonic, sir. More.
What will you do for this case? That is the question.
Sir, VSD closure with.
Symptomatic, why you want to send her for surgery? The LBs are not too dilated, like you have AR cutoffs. You want to do surgery. What are the in adults? What are the cutoffs for sending somebody with asymptomatic AR for surgery?
End systolic volume more than 65, or sir, end diastolic volume more than 45.
And systolic diastolic सही बोल रहे हो कि? Follow.
55.
45.
55.
Pure AR, like pure chronic AR.
Yes, sir.
So what are the cutoffs?
More than end systolic volume more than 25 ml per meter square.
ML per meter square, the absolute cutoff. So these are something that you cannot come without reading. Like these are something that everybody should know. So she has not reached the dimension. So why operate now?
What are the challenges to the surgeon?
Sir, in case valve is irreparable, sir, in case where she is that valve.
What is the concern that if you don't operate now, what will happen over 3-4 years down the line?
Sir, chances of going her in LV dysfunction, sir.
Most importantly, she will need an AVR. Now, if you don't, possibly you will get away with just the repairs. Just the VSD closure will most often solve the whole issue of prolapse.
Repair. VSD closure with repair.
With repairs.
Not always consistent results are.
So could I just interject, sir? There is one question from the audience. If you have a single S2, how do you know it's A2 or P2? Somebody is asking. Differentiate between A2. Call it.
So, this one most important thing is the clinical context, the overall clinical context of the case. That determines whether it is S2 or A2 or P2. And clinically, if you look at it, like where is it best heard? If you have something which is palpable here, only one sound is heard, it has to be P2. This is no rocket science. If it is heard very well at the apex or in this aortic area, it has to be A2. If it is very well heard in the pulmonary area or palpable, it's P2. But more important that those things you may not find in all cases. But most important thing is the clinical context. If you are looking at a tetralogy physiology, you know what it is going to be. So the clinical context is more important. Anything else?
I just wanted to tell you that for the natural history with Dr. Ramakrishna asked, especially for AR, MR, you read the essentials of postgraduate. It's still valid. It's a very good book. To exam going, you can finish off the chapters. For the other natural history of congenital heart disease, there is a book called Freedom. It is called as a natural history of congenital heart disease. A little old book, not really available in the market, but not to be mentioned. You can download it from LibGen if you want. Okay.
There is very famous natural history study of children, PSD, PS and AS, 3 conditions, and it is over long period. That if you can get that article, everyone should have that. About your performance, there are a lot of hiccups. The symptoms should analyze properly. At every step, how will you come to the differential diagnosis? You should make up your mind as to how you are going to present and defend. You should not think in front of the examiner. Before coming to the examiner only, you should make up your mind. This is how I will defend my finding. If any odd finding is there, you ready in the mind. If you take long time to answer, you will be drawn to a different substance.
But overall, you have done very well. So give him a big round of applause.
Sir. Since we are short of time, we'll go to the next case. I request Rama sir to just stay back. Balchandar sir and Barua sir, please join us for the next case. Dr. Renish, you are ready? So he's from Jaydeva and he'll present the next case. Go for 35 minutes.
History is by a 8-year-old child studying in 3rd standard, coming from socio-economical class, presented with history of
Boy or girl? Relax, take first. 8-year-old boy or girl?
girl child.
Girl child.
Presented with history of bluish discoloration of skin and lip at the age of 1 month. Dyspnea on exertion since last 3 months. Exertional fatigue since last 3 months. History of presenting illness. 2.5-year-old girl birth via vaginal delivery, institute delivery. No any complication at the time of delivery. Any uneventful maternal history. Parents noted cyanosis of the neck, cyanosis of the lip and finger at the age of 1 month, which was increased while crying and feeding. So they visited pediatrician. They asked to visit cardiologist for further evaluation. During further evaluation, found out that patient required surgery, but for that we have to wait. After that, patient lost to follow up. Now recently, for 3 months, patient developed fever, which was followed by increase in dyspnea on exertion, which was NYHA class 3, not associated with orthopnea, not associated with PND. Same symptoms, patient having a fatigue on exertion since last 3 months.
But how long was the fever? How was the fever? Was he hospitalized for fever? Was it COVID?
Yes, fever lasted for 4 days. Patient required hospital admission for that. After 4 days, patient discharged. Patient not told to take a long-term antibiotics injection. Now coming to the negative history, no history of recurrent LITI in the infancy. no history of hemoptysis, no history of chest pain, palpitation, no history of syncope, no history of blurring of vision, headache, no history of any syncope. Coming to the personal milestone, milestone is normal, achieve all milestone, now studying in the 3rd standard, intelligence is okay. Coming to the sibling history, having a 2 siblings, one is 3-year-old male child, second is 5-year-old girl child, both are normal, evaluated, not evaluated, but having no symptoms. No any family history, no any family history of congenital heart disease. Past history, 2 admission till now, with now taking patient syrup for some heart disease. Okay. Birth via non-consensuous marriage. So summarizing the history, patient having a fluid discoloration of skin and nail at the age of 1 month, which was initially increased with crying and while feeding, but after that parents noticed fixed cyanosis. Patient limited activity up to the 5 to 6 years. After that, patient since last 3 months noticed increase on dyspnea on exertion and increased fatigue since last 3 months, which was NYHA class 3, which was precipitated initially by fever. After that, patient referred here for further evaluation.
To avoid one thing, like commonly, many people have this habit of telling something in the summary only. So those things don't feature in the history. This just suddenly come up in the summary. So those things should be avoided. So you had 3 major complaints. One is cyanosis, dyspnea, and fatigue. So what happened to the cyanosis? You never elaborated what happened to the cyanosis. She was diagnosed at 1 month of age. Now she's at 8 years. Did the cyanosis progress? Were there any cyanotic spell? Were there history of squatting?
Yes, sir. Cyanosis is initially, sir, only occasionally while sweating, while feeding and crying, which was
That you told.
Yeah.
What happened to that later on?
Yeah.
Like when the patient
sir,
was last to
no cyanotic spell. After since last 3 months, patient taking the position when patient got exertional fatigue, patient will sit in the chair with leg holding sideways down.
There's a history of squatting.
No history of squatting. Sir.
Squatting equivalent, no?
Squatting equivalent like sitting in the chair with leg holding down.
And you didn't elaborate so much about the dyspnea and fatigue also. Like you mentioned in the presenting illness, but you didn't elaborate them on the thing. And the fever did not appear in your. If the fever was so significant, you said that fever worsened the dyspnea and the fatigue, but the fever didn't appear in your summary. 4-day fever. How can 4-day fever worsen a cardiac condition when the patient was discharged after 4 days?
Due to fever, patient develop a vasodilatation. So shunt, if any shunt is there,
even acutely it can worsen. But you said that after 4 days of fever, the patient started developing dyspnea and fatigue. So that kind of history tells us possibly a patient had infected endocarditis or something, but something has happened.
During fever episode only patient worsen, so patient advice admission hospital 4 days admission.
No, this is cyanotic congenital heart disease. No,
Yes, sir.
present. So as you mentioned that you have to mention squatting, cyanotic spell, and history suggestive of hyperphysical syndrome. You are not mention those things. You are not mention syncope, no chest pain. You are not mention those things. Any palpitation.
No palpitation.
SBT. We think of some other thing. So those things are included. History very important.
Palpitation.
Yeah, you are not mention those things. The history lacking.
In the history, I think you have to mention about the mother's illness. During the
Paternal history didn't
pregnancy.
mention.
Always
We told one sibling only, 1, 2, normal, all are normal siblings.
So why does cyanosis not get detected in tetralogy of Fallot at birth?
Sir, at birth, PDA is there, so blood flow from the aorta to the pulmonary artery will be there, and activity of the child is less. Fetal hemoglobin is more.
Fetal hemoglobin is probably a good answer. And aorta also, PDA may be there. So at 1 month of age, what would be the probabilities that this patient, what are the causes of cyanosis appearing or detected at 1 month of age?
Sir, closure of the PDA, physiological changes of
Apart from tetralogy,
at birth also.
1 month. Suppose cyanosis appearing at 1 month, what are the differential diagnosis?
The tetralogy of palate, large TGA, sir, initially with a pictures of failure and then doing a cyanosis. Then rarely Alkapa is around 1 to 2 months.
So Alkapa cyanosis.
Cyanosis.
So this is what happens when you come near the exams. Alkapa starts producing cyanosis.
AGS.
Any other conditions?
So let us start, just to expand the question for the sake of everybody. So what are the causes of cyanosis in day 1 of life?
Sir, top, TAPVC.
First one, first most common, 1 day,
TGA.
PGA, then
TGA, TAPVC, hypoplastic left heart syndrome. Top also. Then
which form of VSD RUT obstruction more likely to present with cyanosis in day 1 of life? Pulmonary atresia or PS?
Pulmonary atresia, sir.
So pulmonary atresia, all forms of pulmonary atresia. So the 3 most common causes of cyanosis at day 1 of life will be PGA, pulmonary atresia physiology and obstructed TAPVC. Then 1 week, 1 month.
Epstein anomaly.
Yeah, Epstein is also day 1 also it can present. 1 week is also Epstein, very good.
Top.
Again same TGA, all of them can present.
Hypoplastic left heart, top. Trunk.
Okay, you mentioned abstain. Why did I get cyanosis in first day?
Sir, pulmonary artery pressure is more so during to ASD. Shunting is from
No, without ASD, can you get cyanosis? Abstain without cyanosis. I mean, without ASD. Possible? Not possible. What about functional pulmonary atresia? In neonatal period, they can have a functional pulmonary atresia, no?
You know what is functional pulmonary atresia?
Sir,
functional pulmonary atresia.
Valve is there, but flow is reduced due to neonatal pulmonary hypertension.
What are the causes like? So coming to 1 month old.
Now we are at 1 month.
1 month now.
Again, you said tetralogy of then
You said TG also be accepted.
Tricuspid atresia, sir. Tricuspid atresia.
So top and top like physiology.
all that conditions which resemble a top physiology. And anything else? We usually say that below 2 years of age, we have above 2 years, you can get cerebral abscess. Why is the difference? Years around below 2 years of age, you can get CVAs, you can get, in above 2 years, you get the complication of cerebral abscess. Why is that difference is there around 2 years?
Sir, for cerebral abscess, there is bypass of the lung. So filter mechanism of lung will be not, and maturation of the respiratory center. No, see,
Infection has to go from somewhere.
Yeah.
It can, common cause of infection is from the oral cavity. So what happens?
dental.
Because of dentition, you can get an infection which can go into that. So that is one of the reasons. Now, squatting equivalent also. So this was, what is a squatting equivalent?
Squatting equivalent like, sir, sitting in the chair with leg hanging behind, standing with cross legged leg, child kept in the mother position with flexed.
Which is the most important thing to do when the patient becomes very blue?
Prone
The
up position, sir.
mother itself knows what to do.
Prone position also, sir.
Before that, prone position,
Yeah,
which position, what is that known as?
What is that position called?
holding the child
First
with,
thing, suppose somebody comes with cyanotic spell, what is the first thing that you do?
holding the child with a leg flex. Niches position.
So what is the possibilities you are considering here?
Sir, cyanotic heart disease with decreased pulmonary blood flow. Most common, sir, tetralogy of Fallot, like physiology.
But why can't it be increased physiology?
Sir,
Increased PP?
no episode of recurrent
You need to
LRT.
say that in the history.
No episode.
No heart failure, no
No
symptoms of
heart
heart failure, no. So which are out of this top or top like physiology is more likely in this case?
Sir, top like physiology stopper and DORV with PSD PS. Less likely, sir, TGA VSD. Because mortality will.
So like we were discussing about squatting equivalence, how squatting relieves cyanosis?
Sir, squatting, while doing squatting, there is a increased pressure on the femoral artery. So we are increasing the systemic vascular resistance. We are increasing the systemic vascular resistance, so shunt from right to left decrease. Then second mechanism is, sir, during sweating, overwhelming deoxygenated blood will not achieve the systemic venous circulation. Third is splanchnic circulation. So these three.
Both the pulmonary atresia patient also got relief by squatting. What the explanation? BHD pulmonary atresia, RBU is totally, there is close. So which component is important here?
Sir, hyperapnea and metabolic acidosis will lead to the increase.
No. The squatting.
Which component? Splanchnic vasodilatation.
Blood.
Dripping the blood.
What is the difference between pink top and blue top?
Sir, pink top will not have cyanosis, good flow from.
Why some people are pink? The first question is why some people are pink and some people are blue.
Depend on the, sir, SVR and PVR relation between when.
No, you can't use the word PVR because PVR will be low in all.
Pulmonary stenosis.
Like the RUT resistance.
I got you.
No, do they have less severe PS?
No, sir. Every top having a severe PS.
So the pulmonary blood flow is what determines the degree of cyanosis.
Yes, sir.
This is a common trap that he has not fallen in, but majority of you will fall in. Like majority will say that it's a less severe PS, but it may be slightly lesser than in a, suppose you do 100, it may be slightly lesser, but then both of them will be in the severe range. Severe PS is mandatory for a tetralogy physiology because the systemic pressure is going to be 120 in all of them or 100, whatever will be systolic pressure, RV pressure, and PA pressure will be always normal pressure. It has to be severe, all of them, pink versus this. So the determinant will be the degree of resistance offered by the RVOT compared to the SVR. We go to the examination on sir comes back, then by the time you tell me when do the patients develop cyanotic spells?
By doing, sir, exertion.
Now, what is the age commonly develop
After,
cyanotic spells?
So once child started getting 3 to 6 months, sir.
3 to 6 months. Why don't they develop it later on? Like later on, they generally by 2 years, it just generally people don't get cyanotic spells. Why?
Sir, child also know that limit activity and maturation of respiratory factor also given.
And they get into other positions. They know which positions to avoid, and they get into other positions.
And they used to have various squatting positions. Coming to the general examination, child is conscious, cooperative, well oriented to time, place, and person. Coming to the vitals, Pulse is 80 per minute, regular in rhythm. No radio radial, no radio femoral delay. All peripheral pulse felt. No central runoff. Coming to the blood pressure is 100 by all peripheral. Blood pressure is 100 by 60 in right upper limb. Blood pressure in left upper limb is 104 by 60. In left lower limb is 110 by 60. JVP, no raised in JVP with normal wave pattern. No normal hepatojugular reflux. Respiratory system 16 per minute. Thoraco-abdominal type. SpO2 is 74% in right upper limb, 76% in left upper limb. Lower limb SpO2 is not able to measure due to nail polish.
Can't you measure if somebody is wearing a nail polish? Can't you measure SpO2?
Can,
So you said no, you cannot measure.
but not capturing, sir.
Because otherwise, it will be very difficult during COVID times.
Clubbing.
Oximeter was put in the ear.
Yeah.
So while on this topic, so you say differential cyanosis, not in this case. But how do you establish differential cyanosis? By oximetry. You can see, of course, clubbing is there. Or supposing you want to be sure about differential cyanosis.
If not visible, then we can ask for exertion 6-minute walk test, and we can.
No, you use an oximeter.
Oximeter.
What
We can use a tail.
No, you have to use differential cyanosis between upper limb and lower limb using an oximeter.
Yeah.
What difference? What is the difference?
Three. Difference in 3%, sir.
So the method to do it is, what is the method? Use two oximeters. Don't use with one. Use two oximeters, measure simultaneously. Then reverse the oximeters, so that the error due to the instrument gets about. So, check out. You can reverse it so that the difference is maintained. And this is actually, routinely neonatal and they do this, they do the pulse oximeter for the PDA to close or not to be there. They will do that.
Regarding nail polish, so I think some colors of polish are known to lower the saturation, like black or something, black, blue. Nail polishes can lower the saturation, but I don't think they cannot measure it. Like maybe they didn't get it, that's okay.
Can you apply it in the fold, the Achilles tendon, that area, in the skin fold? Or wash off the nail polish?
So no icterus, no pallor, cyanosis, central cyanosis present in the neck, present in the nail, skin and lips. Clubbing, graded 2 clubbing, pan-digital clubbing present. No any sign of infective endocarditis. No any scoliosis, kyphosis. No bone and spine deformity. Coming to the sir, CVS examination, inspection and palpation. Chest is bilaterally symmetrical. Apical impulse is in fourth intercostal space, diffuse, RV type of apex. No palpable S3, S4, no palpable sound, no thrill, no heave. Coming to the percussion, right side border under retrosternal, left side border corresponding to apex. Liver dullness is seen in the fifth intercostal space. Under tympani is the right.
Left side or right side? Liver?
Right side, sorry sir, right side. Liver is in the right side and tympani, under tympani is in the left side. And the left second intercostal space is resonant. Coming to the auscultation, S1 is normal, S2 single and A2 component, grade 3/6 ejection systolic murmur, mixed frequency, loud intensity, hard all over the precardium with maximum intensity in the left third intercostal space. Continuous murmur is hard over the bilateral left upper and middle scapular region. With the continuous murmur means prominent systolic and diastolic can make out due to breathing respiratory sound.
Other systems are normal.
Other systems.
So diagnosis?
The diagnosis is congenital heart disease, congenital cyanotic heart disease with decreased pulmonary blood flow, with tetralogy of throat-like physiology, with normal pulmonary artery pressure, no PVH, NYHA class 3, sinus rhythm, no sign of infective endocarditis,
Heart failure also.
no heart failure.
You may not say, I think PVH and pH, if you are saying tetralogy, doesn't make much context. So we not say that, but if the examiner wants to.
In this child, you have to say anything about rheumatic fever. Understand? Continuous murmur, yes, sir. So actually, if continuous murmur in cough with cough-like physiology, if simple cough is there, then it's bronchial collateral, will not produce continuous murmur. In cough, like we will get continuous murmur due to either PDA or other collateral like pulmonary atresia and collateral. For other cough-like physiology, will produce other collateral. Here, sir, might be some other cough-like physiology and producing continuous murmur. So collateral.
Like, what are the other causes of continuous murmur in cyanotic congenital heart disease?
Sir, cough with PDA, cough with pulmonary atresia with collaterals, then either any procedure done like BT shunt, then pulmonary AV fistula, then
Rarely confined.
peripheral PS. Yes, sir, other URV with VSD with PS and
Why continuous murmur?
those are collateral.
So collateral, everything you have to bring in collateral. So that for that you don't have to bring in other physiology. It is not that other physiology have more collateral than tetralogy. So the collateral will be a function of cyanosis and the duration of illness.
Flow is good.
Yes, sir.
So do you get such a extensive collateral murmur when RV outward?
We should not.
What will be the signs if there are extensive collateral? Additional signs, if there are.
Sir, pulse is like higher volume, collapsing pulse with a decrease, less cyanosis. If a Kafkas is more, then cyanosis will be less. Higher pulse pressure.
Next. What else is lot of collateral there? What do you get on precordial examination? What do you get?
I will.
What
So
will be-
silent precordium. The RVOT murmur will not be that.
No, there are a lot of collaterals. Everything is coming into the LA and it's coming into the LV. So what will be?
LA volume overload.
No. LV apex will be there sometimes. No, you can feel a prominent apex. Sometimes you can feel. Then, in addition to that, anything else you can see on auscultation?
Murmur of RVOT will be decreased, will be less.
Yeah, that is there. That is why you have got a lot of collaterals. But sometimes if you have extensive collaterals, you can get a mid-diastolic murmur across the mitral valve.
Sir.
Occasionally, you can get an opening snap across the mitral valve. So these are some of the things which it can alter. Same thing can affect after BT shunt also.
Is it associated with right pulmonary stenosis? Transpulmonary.
Peripheral PS, yes, sir. So, yeah, cough is associated with peripheral PS.
Can continuous murmur be because of that? That's the first question.
Yes.
Like, can this continuous murmur be because of peripheral PS in tetralogy? Suppose patient has LPS stenosis along with tetralogy.
Sir, then if peripheral PS is there, then murmur at the RVOT will not be so prominent because distal proximal PS,
But RPA is unobstructed. The whole blood will be going into RPA.
distal, yes, sir.
You won't get such a prominent continuous murmur. Why?
But that you won't get any.
If in
But, sir,
tetralogy,
it is present in sir bilateral side. If
if in tetralogy, if you find an associated LPA narrowing, the MPA pressure is going to be low. MPA pressure is going to be low. The gradient across MPA to LPA is going to be lower. Once you correct the surgery, then the gradient will suddenly appear. But initially, if you do a cath also, the RPA pressure will be so 20, 25. The LPA pressure is going to be say 15, 18. The gradient is going to be only 10. You can't auscultate such a loud murmur if there is associated LP narrowing.
So it may only isolated transcontinental you may get a murmur, but any top you
You have a
because gradient
situation-
very less.
You have a situation and you have a mild fallow, then you have a little moderate fallow, and then you have a severe cyanosis, I mean. So what will be the RV systolic pressure in mild and PA systolic pressure, that is RV and PA,
Systolic
reading
pressure will be-
mild, moderate and severe.
Systolic pressure will be same in mild, moderate and severe.
Okay, PA pressure?
PA pressure will be also same because PA is not attached with the stenosis will be there, so PA pressure will be also normal in it.
Whether it's mild, moderate or severe. Then what causes the cyanosis to be more or less?
Sir, the relationship between the yes.
Answer that. Did you answer it again, sir?
So relationship between the SVR and the RVOT obstruction. If a SVR is low, then shunt will be more from right to left, so more desaturation. If you increase the SVR, then shunt, whatever shunt are happening, it's less, so more blood will go to the pulmonary.
SPR not important here, right? Sir earlier told you, no? It is the resistance pulmonary outflow tract.
Yeah, outflow tract was balance.
RBOT resistance important here.
Valve morphology and tetralogy. What is it normally? Is it semilunar valve morphology normally in tetralogy of fallow? And what has been recently reported?
Bicuspid valve.
Bicuspid valve. And what is the problem with the bicuspid valve pulmonary physiology in tetralogy of fallow?
It is very much doming mobile or it is very thick immobile. What is this?
Doming and mobile.
What is the aortic pathology in tetralogy? Tetralogy of fallow has got an aortopathy or not?
Yes, sir. So medial abnormality in the aortic wall, we get AR due to aortic pathology.
And is it syndromic? Is there a syndrome associated with that?
Yes, sir. Symptom
What is it called?
associated triduch 22 deletion.
Catch 22.
And trisomy 18 also associated. Then golden hair. Then oculovertebral.
All right, you can get midline syndromes also, but usually it is catch 22 or the other abnormalities associated with that catch 22.
Sir, thymic hypoplasia, hypocalcemia, choanal atresia.
Previously, when we were asking this question, it was just evolving. Now it has evolved completely.
This is a classic short question, short answer notes like second heart field. Related to cardiology only, heart is there. Something to do with embryology. Anybody wants to answer?
You're answering all the questions. We have to ask something which
Something
you
more.
are not answering.
What is second heart field? It's a classic short notes in your first paper, like basic science paper.
Yeah, actually, normally the first heart field is from the mesodermal cardiac jelly. Second heart field comes from the pharyngeal pouch. And that contributes to the development of the outflow tract, the right ventricle and the left ventricle.
That has contribution from other cells, neural cells and others coming.
Can you tell me when do you think of syndromic trough?
Patient having either a sibling history first, and we will see the morphological facial features like having a cleft lip, cleft palate, low micrognathia, hairline, narrow palpebral fissure.
Are you doing DM cardiology or DM pediatric cardiology?
DM
cardiology. Pediatric cardiology.
Patient has got deeply cyanotic, but they are getting grade 3 murmur, no? Deep cyanosis,
Yes, sir.
grade 3 murmur RVT. How to account for?
Sir, in DORV with VSD, PS, in spite of
No,
cyanosis,
this case, this is, what is your diagnosis? Tetanus fellow?
look like physiology, yes, means
Achha.
any look like
Not classical tetralogy.
so chest X-ray PA view, normal rotation, well exposure with I can't comment on RV and LV type of effects, but with narrow pedicle, with RA dilatation, no cardiomegaly, pulmonary
Aorta, what is aorta? Aorta.
narrow pedicle, sir.
Aorta, what is that vessel? You mean that pulmonary, you mean? This patient has a tetanus follow physiology, you get pulmonary like that? Has to out only. Then tell us what is that? Aorta dilated or not dilated?
Aorta dilated, sir.
Which aortic arch, right or left?
Left aortic arch, sir. Indetention on the left bronchus.
Pulmonary you are not able to see?
No pulmonary.
And what about that hump there? The hump.
Yes, sir. LA enlargement.
They won't come there. Where is alien heart? Where is left atrium heart?
Not but
Okay, pulmonary vascularity will reduce or increase or
reduce.
so what are the possibilities next? I want to see ECG to go over it.
Sir, transposition, narrow pedicle. And sir, no.
Okay, fine. Is the correct?
ECG,
ECG?
tetralogy or tetralogy others like
Others like
X-ray.
other tetralogy like
What do you find in classic tetralogy ECG?
the right axis deviation with right ventricular hypertrophy with clockwise looping in except DORV, we will get counterclockwise looping. Then if ventricle blood is
Tetralogy, classical like. One more thing you have to say. One you said is right axis deviation, right ventricular hypertrophy and
count early transition, sir, because V2 either due to window effect, transition will be in V2 only.
Why is that transition?
Sir, there are two concepts like due to VSD large no monoventricular large VSD, malaligned VSD, we are seeing the posterior wall of the LV, so we get early transition window due to window effect.
Yeah, that is what we all think. But VSD alone, it doesn't give you transition, no?
Yeah, yes, sir.
So really, we don't know it.
Sir, 12 lead ECG with normal rhythm with a rate around 80 per minute with axis
It was some arrhythmia there, not rhythm, not regular.
yes,
EPR not regular.
sinus arrhythmia, sir. Axis around, sir, one is negative, one is right axis deviation around 130 to 130 to 120 to 1, in between 120 to 150 with well-preserved R wave in the V5, V6 suggestive of a good blood in the LV.
Well-preserved R wave in the?
R wave in the V5, V6 well-preserved. V6 is small, but V5 is good.
There is no Q, no?
Looping is, sir, clockwise looping because no Q wave in 1 and AVL, sir.
D2 some phase. D2 is more positive. AVR of course. Beyond 120.
135.
130.
He told like that. No.
RVH?
Yes, sir.
Valid
RVH is
transmission?
there. RVH is there, sir. In V1, RVH is around 20.
And early transition is there.
Early transition to, yes, sir.
Very classic. Why are you taking so much time? It's so classic. Go to the
Yes, sir. Tetralogy of fellow like physiology.
Tetralogy of fellow using ECG because the axis is a little too much rightwards for a tetralogy of fellow, isn't it?
Yes, sir. In DORV and TGA, axis will be more than 150 usually.
Why did he go in the T inverse lead one? T inverse lead one, Professor you say think of LTJ. And the Q of V5. So don't get Q in V5, V1, then it literally because RE pressure is systemic, not suprasystemic. Isn't?
Yes, sir.
Why the T inverse in lead one? It should have taken right side ECG to see the Qs. And then no Q in V5 is of course literally V5 V6. But whether Q in V1, Q or tiny R there. Q. Q. So RE pressure or suprasystemic and tetralogy, you won't get Q. Pure pattern there. So it is L ventricle. And T inverse in lead one. T inverse lead one. You don't get T inverse lead one, no?
Yeah.
T inverse lead one. And V1 T upright. 50% cases you get T inverse in pathology. T upright in T1, V1. And Q and T inverse in your lead one. Q in V1. So it's not a classical tetralogy.
Okay.
Let us go to
In a cyanotic heart disease, what conditions will go through your mind? And it is absent in V5.
cyanotic heart disease, Q or in V1, RVH, Q or in V1.
Sir, CCTGA, sir.
What else? Suprasystemic RE pressure cyanosis, which condition get?
Eisenmenger with,
Suprasystemic Eisenmenger cannot occur.
sorry, intact ventricular septum with ASD. ASD with Eisenmenger.
Which Eisenmenger? Okay, fine, sorry. Which Eisenmenger, fine.
Severe MS, sir.
Pulmonary
Severe MS with PH.
No, cyanosis, no? Cyanotic heart disease.
Idiopathic,
Right.
sir. Idiopathic pulmonary arterial hypertension.
You get pulmonary, you get RVH will get.
MPH will get, but in no,
Nothing
sir,
will get.
I am giving, sir.
Nothing will get in ECG. Normal ECG will get.
TR also you can get. TR. Actually,
Pulmonary dilatation talking.
Yeah, hypertension.
Sorry, pulmonary hypertension. Pulmonary
As I said,
stenosis, pulmonary stenosis, right left across HD.
Yeah.
HD Eisenmenger may get. Fine, correct.
whether it's TR you'll get. That's why it is said, when right looks like left, it is insufficiently right. That means when the right-sided lead V1 looks like a left-sided V5, V6, it is due to insufficiency of the right side.
So
That's what Shamrock.
echo the curve. So
So as we get the echo ready, there are two questions. So one is, can you explain the clockwise and counterclockwise rotation, the steno students? The other one is, sir, why is there a window effect in? Like, why do you have a sudden transition in? Sure, sir. Sure, sir. Class. We'll have a lecture by sir in the afternoon. Cyanotic heart.
Other case, somebody can summarize the echo findings. Whoever is done. To save time, we want to do one more case, na?
Yes, sir.
So then you can summarize the echo findings. Somebody can read out the echo report.
So this is actually a patient with a single ventricle with a RV dominance, the smaller LV. It's presented actually for the sake of natural history because she has survived till this as a single ventricle RV physiology.
So the L malposition get at risk?
L post J.
Single ventricle
with RV.
with L malposition get at risk.
So what do you want to do for her now?
Sir, single ventricle is there, so we can't do corrective surgery. We can do, sir, first I look for PA anatomy. PA anatomy is.
Can you show the fourth chamber view? Let's see. Fourth chamber view. That is. No, there is LV, but it functions single ventricle.
Oh, yes, sir.
But it's not anatomy single ventricle. It functions single ventricle.
The diagnosis is a hypoplastic left heart, sir.
And outer getting origin from the RV. No, one more time, please go. Please, one more time. Fourth chamber. See, the left aval is little higher than your right aval.
Then it's
So it is LTJ type. Yes. And
What's the
RV,
next one?
the RV left side is small. And yes.
So it's a single ventricle LV physiology, sir.
DILV.
Cross section देखा कहाँ से?
Smoother ventricle.
हैं?
The smoother ventricle is that side, sir. So the more trabeculated side.
So the valve on the left
more upper
side
pulse,
is like attachment to the septal attachment.
Yeah, there is, I think, straddling or something that.
There is some straddling also there.
Straddling of the aval.
So practically, in terms of management, we are going to plan a single ventricle pathway. So what will you do for her?
Sir, double ventricular repair is not possible, so we will plan for single ventricular repair. For that, I need PA anatomy, PA pressure. If suitable, then I will do plane. Directly, we can do Fontan also.
Will you do a CT angio or will you do a
CT angio, sir.
Even for primary Fontan, you are okay with the CT angio?
Primary Fontan, sir, we will do for death to look for additional VSD if any there. And
No, why additional VSD should matter?
No, in this, I am not talking.
This it won't matter.
In this,
If you are planning for a primary Fontan, you should go for a cath. Otherwise, you can do it on a CT angiogram.
Yeah, yes, sir. If you are planning for Fontan, sir, then we have to see for MAPCAS and PA anatomy and continue.
Condition member has to be seen, and then the child may need a coil embolization followed by. So what are the outcomes of Fontan?
Outcomes?
Outcomes of Fontan, long-term outcomes of Fontan.
Sir, long-term outcomes are good, sir. 5-year mortality is 90. 5-year event-free survival is 94%. 10-year event-free survival is 90%. 15-year event-free survival is 85%, sir. Due to modified lateral out Fontan.
What are the long-term complications of Fontan?
Sir, Fontan patient develop pulmonary AV malformation.
So Fontan patients develop pulmonary malformation.
They develop, sir, venous collateral. Then Fontan patient
Plastic bronchitis,
plastic bronchitis will be there, liver, damage to the liver will be there,
arrhythmia,
arrhythmia,
And late fontan failure, like. What causes that fontan failure? Early and late.
early means
We just read about that. You've been answering well, that's why we are asking all this question.
Current thinking of the 10 commandments. You have to follow 10
no, sir,
commandments?
no,
or,
only
one
we have to
commandment is
follow
enough?
2 commands, sir. Other 8 is we can leave it like
That is because nobody follows commandments today, sir.
if you want to BD claim this case, what will do? BD claim, what is your
So you said collateral.
collateral? If you want to BD claim, what is your advice to surgeons?
for PDG.
BD claim, yeah.
You're doing a BD glen, what is the advice to surgeons? That's the.
I think that's only septectomy to do. Septectomy. Internal septum looks intact.
Septectomy.
Yeah.
Same.
Okay, good answer.
So it summarizes the case, sir. How is it done?
I think, of course, excellent presentation. And you answered most of the questions. In fact, we had to think of questions so that you could not answer. So it was quite good.
Thank you, sir. Thank you, sir.
Thank you. Sorry, we have to rush. We have one more case before lunch. Can I have Dr. Kavya here? She's here. Dr. Kavya? Yeah. You are ready with your case? Das sir, Kiran sir and ma'am. Das sir, Prabhavati ma'am and Kiran sir. Sir? Sir, will you please moderate this session? Sir, please, sir. Aina, sir. Aina, sir, please. Sir, this is the 5th case of the day, right? We'll make it 30 minutes, if you don't mind. Thank you.
Good afternoon. I'm Dr. Kavya from Sunshine Hospital, Hyderabad. I'm presenting a case of a 49-year-old patient from West Bengal who used to work in the Navy, but then is now a farmer by occupation. He presented with the chief complaints of palpitation since 3 months. The patient's history dates back 2002 when he was 29 years of age. He had developed shortness of breath, which was insidious in onset and progress. And initially he had shortness of breath while walking more than a few kilometers and was suggested NYHA functional class 2. And it later progressed to breathlessness while showering and while dressing himself, suggestive of New York Heart Association functional class 3. He did not have, he consulted the doctor at that time and he had undergone, in his words, a balloon procedure from his right leg. And this was in 2004. He had relief, right drawing. He had relief of symptoms for a few months, but then again he developed the similar symptoms and he underwent a similar procedure in 2006 after 2 years. Again, he had relief of symptoms for a couple of years, but in 2009 he underwent a surgery which was performed to the left side of his chest. Since that surgery, which was performed in 2009, he was symptomatic.
From left side of the chest.
Left side of the chest. Since his surgery in 2009, he was feeling symptomatically better up until 3 months ago when he developed palpitations. The palpitations were insidious in onset and progressive. They were exertional and it occurred when he was performing heavy field work. It was suggestive of New York Heart Association functional class 2. And the palpitations would last for around 3 to 5 seconds and they were regular and it was relieved on rest. And he also said that he had these palpitations in the night time during sleep. He did not have loss of consciousness or giddiness. He did not have breathlessness this time around or chest pain. There is no history of fever or rash or joint pains. There was no complaints of orthopnea. History suggests of orthopnea, PNB or limb swelling and reduced urine output. The
The past history. Okay. Relevant past history of the surgical procedures. Yes. That's a 50-year-old male patient who, at the age of around 30 years, had undergone a balloon procedure from the right groin because of breathlessness, and he had undergone that procedure 2 times, the span of 2 years. And then after around 3 years, he had undergone a surgery from the left side of his chest. And he was symptom free until 3 months ago when he has now presented with palpitation.
Did he improve after the surgery?
He improved after the surgery in 2009, ma'am, and he was symptom free. But since the last 3 months, he has presented with palpitations.
So what happened that surgery was?
So the surgery was probably a balloon angioplasty for coarctation of, the first 2 procedures were probably a balloon angioplasty for coarctation of aorta. And the surgical procedure was probably a corrective repair, maybe an end-to-end anastomosis.
What are the other surgeries done from a left thoracotomy?
So other surgeries are a ligation of patent ductus arteriosus and palliative surgeries such as the PT shunt or a Watterson's shunt are also performed.
Watterson's shunt from? Watterson's shunt from?
The Potts shunt, sir. I'm sorry. Potts shunt.
Watterson, what they do from left? They do Potts left from left thoracotomy.
Left thoracotomy.
What palpitation here? Arrhythmic or it is something else?
Sorry, sir?
What is here palpitation? Palpitation, no? Palpitation.
He is present with palpitations.
What did you do what?
That maybe now he has presented with aortic regurgitation causing exertional palpitation.
Why not it is SBT or BT?
Sir, it is on exertion and it's more exertional and he has a coarctation of aorta and male patient, so maybe he has a bicuspid aortic valve and that's why he has developed aortic regurgitation.
You have AVRT maybe, AVRT or AVRT, you don't know, after tachycardia. Why not? Chemistry.
Exertional, one is that it's an exertional palpitation and it was, and he also has nocturnal palpitations.
Nocturnal, but you mention those things. Just you not mention.
I mentioned.
Nocturnal.
What's your objection if I say the first 2 procedures were mitral commissurotomy and then underwent a mitral valve?
CMV.
CMV, not, yeah. So CMV, yeah.
So one is the gender, the male patient, so I would consider coarctation of aorta over.
Between coarctation and mitral stenosis, which is more common?
Sorry?
Between coarctation and mitral stenosis, which is more common? Far more common mitral stenosis, yeah. So that argument may not hold. Is there anything else? Any other objection to my diagnosis?
What is your history? Patient's history?
The presentation that time was breathlessness, but now he presented with.
Yeah, so breathlessness fits in, and then he had a procedure, he got better, then he had restenosis, he had another PTMC, which also didn't work, then he went for a closed mitral commissurotomy, closed mitral valvotomy, whatever, CMV or whatever you want to call it. So why not that? And now he's got atrial fibrillation.
Third time, it is okay for PTMC because we elect probably we have for CMV.
Possible.
What made you think of coarctation of aorta?
Because it was lateral, I thought it was a.
Anterolateral or posterolateral thoracotomy?
It was a posterolateral.
Generally, which is better, PTMC or CMC? Closed mitral or CMV?
PTM.
So, and why?
They would have, they would have tried a PTMC again. We developed team.
So, I think in the current era, it's difficult to find a surgeon who can do a closed mitral commissurotomy because it's PTMC has completely, taken away that procedure.
It's suitable for CME, they could do BMAs.
Precisely, yeah. So I basically agree with your story, except for the palpitation, which is a little unusual.
Also possibility of the history.
Is it because you told backstudy well, initially first phases, it was done out of valvotomy alone, now coarctation?
Sorry, can you repeat the question?
First and second procedure out of valvotomy alone, now coach surgery.
So because it is from the left side, it's probably coarct. And his age was, he was around 30 years. And it's bicuspid.
No, being not very much gradient maybe,
But it was
not much gradient.
Okay. So he was only around 30 years at the first.
Now because of the second dilatation alone, so patient might develop AR. Over the years, AR has in progress. Now palpitation due to that, and then did coach surgery.
In bicuspid aortic valve, the aortic stenosis occurs around 4th to 5th decade, 5th to 6th decade.
What?
Aortic stenosis in bicuspid aortic valves are presents around 5th to 6th decade.
No.
But he was
They
around
can present earlier also.
Sir, has done so many cases of backstudy well in
around
less than
40
10
years.
years.
They can present earlier also.
I have done one less than 6 months. Out of valvotomy, balloon valvotomy.
Was he detected to have hypertension?
Yes,
You have not mentioned that.
I had
Important history. That is very important.
I'm sorry, was in past history he has history of hypertension which was detected on the first.
For the first procedure, he was detected to have hypertension.
Yes, ma'am. I mean, in the patient.
She didn't.
were-
What's the indication for balloon valvotomy in aortic stenosis in an adult? Or do you think it's
In a pediatric age, what is indicated? Or what age done first balloon procedure? What age? What the?
He was 29 years of age.
Okay. So what could the indication for balloon out of valvotomy?
He had symptomatic severe aortic
How to define severe?
like
so you
How to define
prefer
severe?
a balloon procedure or surgery in a 29-year-old?
What is the indication of a balloon valvotomy, the aortic valve, 29 years of age, a female patient, no?
the male patient. Male patient.
Okay, irrespective of age, okay, tell me, in a female patient, what is the indication of doing valvotomy at 29 years?
So,
Female patient, 29 years age.
mitral balloon.
Aortic balloon. Because this case straightforward, no, straightforward case. Sorry?
They're trying for pregnancy.
Adult patient, I'll send for such AV replacement.
Is trying for pregnancy.
Not pregnancy.
Pregnant.
Or pregnant lady? Patient is pregnant, now later diagnosed of aortic stenosis, and the balloon.
Yes.
And tell answer, indication of valvotomy, balloon valvotomy of aortic stenosis.
The bike.
Patient has
Sir.
severe aortic, severe LV
Severe.
dysfunction, young patient. LV ejection fraction 20-25%, but aortic stenosis is there.
Present value.
All not very much calcified. What to do?
Balloon. Presence of L.
Sometimes it's a bridge to surgery, can be done. Yeah, please continue.
General examination. Patient was coherent and well-oriented time-based person. His height was 164 centimeters. Weight is 55 kgs. BMI was 21.1. Upper segment 76 centimeters. Lower segment 88 centimeters. And arm span of 169 centimeters.
The pulse rate was 72 beats per minute, regular, high volume, bispherence pulse, with no radial or radiofemoral delays, and all the peripheral pulses were equally palpable. Sorry, the left femoral and the left popliteal were feeble, but the left dorsalis pedis was all right. The blood pressure in the right upper limb was 130 by 40 millimeter mercury. Left upper limb was 110 by 40 millimeter mercury. Right lower limb was 200 by 110 millimeter mercury. Left lower limb was around 150 by 100 millimeter mercury.
You check lower limb blood pressure?
Sorry, ma'am?
How did you check lower limb blood pressure?
I put the patient in the prone position and I used the same arm cuff and checked it at the popliteal artery. Yes. But ideally, we should check it at the calf because
Was the
of the
left
size of the
femoral
calf.
also feeble?
Sir,
Was the left femoral pulse
the
feeble?
left femoral
And popliteal
yes,
feeble?
yes.
Okay. Why doesn't blood flow from the leg to the hand when it is 200 in the leg and 110 in the hand?
So that could be because of the aortic regurgitation.
So even then, if the BP is high, blood flows down a gradient, isn't it? So from 200 to 100, so blood should be flowing in the opposite direction.
Yes, sir.
Does it?
No.
Why not?
Because of
I
peripheral.
think we covered that earlier, because a question was asked. If you measure the intra-aortic pressure, intravascular pressure, do you really find such a big difference? You don't, right? So this is partly artifactual due to the fact that you've used an undersized cuff. And partly there's a little peripheral augmentation of the systolic pressure, which is seen as you go from the central to the aortic. So it's actually artifactual. You don't have intravascular pressure is not so high. Despite that, as a hill sign, it is still valid.
The jugular venous pressure was elevated and measured around 5 centimeters above the angular fluid, 30 degrees. There were normal waveforms and normal respiratory variation. The respiratory rate was 16 breaths per minute. The temperature was, he was afebrile. There was no cyanosis, clubbing, pedal edema, lymphadenopathy. This spine was normal, dental hygiene was normal, and thyroid. There were signs of peripheral runoff. Now coming to cardiovascular system examination on inspection and palpation.
You want to say what those signs were?
Yes, sir. He had dancing carotids were present, and he also had collapsing pulse, and he had the Traub sign was also positive on the right side.
Did you look for the others?
Yes, I checked for
Which one?
a few more. I checked for Landolfi sign. And
What is Landolfi?
So Landolfi sign alternating constriction and dilatation of the pupil.
Uroses? Did you look for uroses?
Uroses I checked, sir, but I
Not there. Okay, so you found some
a
peripheral
few
signs.
peripheral signs.
Okay.
Disappearance.
It was around 20 to 40 degrees. There was muffling of the Korotskov sounds. So,
You had mentioned upper segment, lower segment, all those measurements. Did you take the ratio? And what's the normal ratio? When would you say it's abnormal?
sir, upper segment to lower segment more than 1.1. I'm not too sure. Sorry. Normal. So 0.82. Coming to inspection and palpation of the cardiovascular system, trachea was central, apex was localized to the was in the 6th intercostal space in the anterior axillary line. It was hyperdynamic in nature and it was occupying 2 intercostal spaces. There was no parasternal heave, no epigastric pulsations, and no palpable sounds. A scar was present in the left posterolateral location, and it was healthy. On percussion, the liver dermis is in the right 5th intercostal space. Right heart border corresponded to the sternum, left heart border corresponded to the apex. The right and left 2nd intercostal spaces were resonant. On auscultation, the first heart sound was soft. The second heart sound was normally split.
There were no third or fourth heart sounds. So, normally split, sir, and A2 was soft. The so P2 was normal, sir. Yes. There were no additional sounds. A holodiastolic murmur was audible in the left third intercostal space, which was high frequency, best heard with the diaphragm of the stethoscope in sitting and leaning forward position. It was radiating to the apex as well as the back, and it reduced on passive leg raising as well as on hand grip. And the ejection systolic murmur was audible in the right second intercostal space, which was grade 2/6. It was localized and it was early peaking in nature. And there was a mid-diastolic murmur heard audible in the apex, which was low pitched, and there was no presystolic accentuation of the murmur. The other system examinations were normal.
One question, the holodiastolic and heterodiastolic murmur.
Yes.
Holodiastolic
It was a
murmur.
Means holodiastolic means what?
Sir,
Holodiastolic means what?
Diastolic term, do you apply clinically?
it was a long diastolic.
Long diastolic means what? Mid diastolic or early diastolic?
No, so it was a long mid-diastolic murmur.
Long mid diastolic.
Sorry, sir. It was a long early diastolic murmur.
Early diastolic.
Yeah, better to say that. Early diastolic murmur, it was long.
Yes.
Right? And why is the S1 soft?
Sir,
What are the causes of, some causes also after that?
Sir, the S1 can be soft in severe aortic regurgitation, or severe mitral regurgitation, or in the presence of a long PR interval.
What happens in acute aortic regurgitation?
Acute aortic regurgitation also it's soft.
Soft.
Anything unusual in the way you describe the murmur, like anything unusual in your patients? You are surprised?
Sir, I thought because of
Any finding that is in auscultation murmur wise, anything is unusual?
sir, he could have had he would have had an aortic stenosis.
No.
More,
Like, do you find an idiom of AR auscultable in the back?
yeah, radiating to the apex and also audible at the back.
So it's radiating to the apex and radiating to the back. Is it common thing?
No,
Like
sir.
AR murmur radiating to back and radiating to apex?
No, sir.
Where is generally the AR murmur will be?
AR is in the third left intercostal
Generally it is very
space.
localized murmur like.
Yes, sir.
But sometimes we really can come apex goes.
Apex can be, but back will be very unusual, sir. Like
Back.
Apex itself is in the anterior axillary line. So it's highly dilated.
Possibly because of the dilatation.
For the other murmur you mentioned, mitral murmur.
No, sir.
Cole Cecil or Cecil Cole AR or murmur.
Yes, sir. So due to perforation of the aortic cusp. Sorry. Yes. Good.
Yeah, you mentioned another murmur, right?
Yes, I mentioned a mid-diastolic murmur at the apex.
What is it?
So it's possibly an Austin Flint murmur.
Why do you say that?
You differentiate it.
Because
from-
there was no presystolic accentuation and there was no associated opening snap.
No, it is a
And
congenital
patient-
macular disease it can have no in coarctation aorta. Congenital macular anomaly can get due to MS, congenital MS.
Yes, the mid-diastolic murmur, sir.
Huh?
So I'm asking about the mid-diastolic murmur.
No, no, get mid-diastolic murmur in apex. Could be congenital metastasis. Congenital macular disease is associated with coarctation aorta, isn't it?
Yes.
So there could be. Why not congenital metastasis murmur? Why do you say it Austin murmur?
So one is the absence of presystolic.
It depends upon degree of metastasis.
The patient is in sinus rhythm is in favor of Austin Flint over mitral stenosis. Sorry, sir.
that argument cannot be held like because many patients with MS can be in sinus rhythm.
Yes.
But other argument could be okay. If patient is in IAF, then you can think of MS.
Then
What What is the congenital matter anomaly present in coarctation aorta?
So they can have a supravalvular mitral ring.
You might get a pre-shift abscessation. Then what else? Congenital metal apparatus anomalies. What else?
Then that is
What about location of the papillary muscles? Sometimes do you get that? You get them closer together sometimes.
yes.
Interpapillary, that distance will be less. Okay, so do you want to tell me a diagnosis now?
So diagnosis is acyanotic congenital heart disease, situs solitis levocardia with coarctation, a repaired coarctation of aorta with severe aortic regurgitation, possibly due to bicuspid aortic valve in sinus rhythm and functional class 2 in failure and no signs of pulmonary venous or arterial hypertension and no signs of infective endocarditis or active rheumatic fever.
Do you think the JVP is elevated and pulmonary venous hypertension will not be there? What's the cause for the right? Is the right, are we feeling pressures high?
The
You put
JVP was elevated.
Obviously it is high.
It is high.
What's the cause for
It
that?
is JVP or it is carotid pulse? Are you
No,
sure?
It was the JVP. Sir.
Jugular venous pulse or carotid pulsation?
It was the JVP, sir. It was more lateral. And could
So
see
then
the waveforms.
You told there are no
Waveform.
PS, no.
What are the other points that you use to distinguish
So
arterial and JVP?
the waveforms, there are two descents and two ascents in the JVP.
Yes.
And the carotid, it's more of a single brisk heaving nature.
Other
And you can
points?
compress, on compression, the JVP can disappear. There is variation with position of the JVP.
Position, respiration,
And
the dominant pulsation is inward in venous and outward in arterial. So you must probably sometimes use all these and make sure that it is venous because the diagnosis makes a lot of difference. So why is the RV feeling pressure high?
So maybe he
Because all the
has,
lesions are left-sided
yes.
Without RV.
without
dysfunction.
pulmonary venous hypertension.
Maybe due to the left side.
Some severe aortic regurgitation with.
How does
maybe
that
heart
produce
failure.
RV
We can-
dysfunction?
Central venous pulse raise or age abnormally raised? Central venous pulse means central venous pulse raise, no raise.
Yes, sir. The
Not
waveforms.
pulmonary A.
No, sir.
Not pulmonary A, there is expansion for that. Suppose the pulmonary A there, the expansion for that, because LV is there, can you explain? But central venous pulse raised in the presence of a moderate to severe AR, how to explain?
If they are in, they've developed LV dysfunction and they
And,
have,
and what? Tell me,
and.
all the steps, how does
diastolic
LV dysfunction
then
translate
diastolic
in?
dysfunction and pulmonary arterial hypertension and then.
Before arterial
Sorry, venous
hypertension, you need
hypertension
venous
and the arterial
hypertension.
hypertension.
Okay.
and
Any other
renal
ways?
dysfunction.
We mentioned that today also,
Hy-
yeah, so you have the Burnham effect,
No, only A,
only A.
not central venous pressure.
Yeah.
That I'm asking you, if central venous pressure raised, so pulmonary capillary raise as well as central venous pressure raise in AR.
Yes,
Understand? If burning only A only.
okay.
There
Only
is,
which wave is more prominent?
The A wave is more prominent.
Why?
Because
Septum is a part of right ventricle, RB is hypertrophied, center is hypertrophied, so RB components is less.
So extension to this question, like what are the left heart conditions that can predominantly present with right heart failure?
so mitral stenosis.
what else?
Yes.
Early right heart, predominantly right heart or early right heart failure.
Then
First symptom is, for example, pedal edema, liver and the JVP elevated are the first findings. Patient has a predominantly left heart disease.
so restrictive.
Anybody?
Restrictive.
RSOV and Gutenberger syndrome. Gutenberger is something that MS is severe, but the patient presents with predominantly right heart symptom.
My question was different in the sense if you see.
So you don't believe
pressure-
that, I think that sign is not correct maybe. JP not raised. It is pyramid carotid one pulse.
My question was another
Whole
thing.
carotid pulse.
You measure pressures right atrium and left atrium. What are the differences between the two?
So in the right atrium, the A and the B wave are around 3 mmHg and 5 mmHg.
So is there a difference between A and V in the right atrium and left atrium?
Yes.
And why? That's basically the question.
Yes, sir. The left atrial pressures are higher than the right atrial pressures.
Yeah, so we're talking about the waveform, not the absolute. Yes, absolute, I agree. LA pressures are generally higher on the left atrium rather than right atrium. When we're talking about waveforms, you said in JVP, which is basically the right atrium, A is bigger than V.
Yes.
What about left atrium?
Oh, yeah, the V is more prominent than the A wave
In which case, why?
because the pressures are. I'm not sure. sir. Compliance.
Yeah, 1%. Put up your hand, 1%. Then you'll find nobody else. Yeah, there.
Because the compliance of LA is lesser than the RA because our LA is bounded posteriorly, sir.
RE decompresses
By the
into the
pulmonary veins.
By the
So
pulmonary
that has a slight restrictive activity. Or in other words, what the others said that RA compliance is more than LA. You said the same thing. That is less.
LA shows the same, B greater than A.
So different.
Then it should. Then the A wave will be more prominent. In the left A.
What will be the RA pressure, LA pressure and TAPVC?
The RA pressure, sir, it will. Then the V wave will
Do you
be
get
more
restrictive
prominent.
ASD or non-restrictive usually? ASD.
It'll be non-restrictive ASD.
Answer, because ASD is
It's
there.
decompressed.
Yeah. So it's you get an obligatory ASD there and it has usually non-restrictive. And usually the pressures are identical.
Go to the ECG.
This is a 4-channel 12-lead ECG in sinus rhythm with a rate of.
When will you say sinus rhythm? What should be fulfilled? We had a small discussion, so leave that aside. When do you say sinus rhythm?
So when the P wave is upright in lead 2 and inverted in
AVR.
AVR.
So basically, that is what has to be there. Just because P is followed by QRS, don't automatically say sinus rhythm. It's could be an aging rhythm. So you need to differentiate. So the P wave axis should be normal. Basically upright in one and inverted in AVR. Okay, please proceed.
So there is a left axis deviation of the axis is around minus, so beyond minus 30. And so there are signs of the left atrial abnormality as well as
In what form?
so there is a prominent negative terminal in V1. Sorry, broad.
Does that have a name?
Yes. So Morris index.
Okay.
And beyond minus 30.
So because of, because it's more, it's not biphasic in D2. Yes. Yes.
So if it goes beyond, you just said beyond minus 30,
Yes.
let's say if it's beyond minus 60, then what will you find? How do you localize that?
So if it's beyond minus 60, then the biphasic complex would be at around lead 2. And it will be,
No, lead 2 will be negative. It is, if lead 2 is negative, it's beyond minus 30. Okay, now I'm saying, when you say beyond minus 30, could be even 160, 170.
then
whatever.
AVR,
Minus- yeah.
AVR is negative.
Yeah, so AVR is negative.
Then there are features of LV, volume overload.
Did you say LVH first of all? Did you say LVH?
Yes,
Let's
the
say
features of
LVH.
LVH.
Okay. LVH based on which criteria?
Sir,
Any criteria you want, I think.
Cornell or Sokolov-Leon.
Tell me Sokolov-Leon.
Sokolov-Leon, so the S wave in V5 and the
S wave.
So the R wave in V5 and S wave in V1, the sum is more than 35 millimeters.
Systolic overload, diastolic. What kind of volume overload or pressure overload? LV.
So there is also volume overload.
Why do you say that?
So because of the Q waves. Actually, there is no Q waves.
Are you seeing Q waves there?
No, sir.
So?
The T inversion. The T inversion.
So
which
basically,
happen.
what kind of pattern is it? Is it a systolic volume, a systolic overload pattern or a diastolic overload pattern?
It's diastolic overload. That'll be volume, so systolic overload. No pressure.
Does this fit in with your diagnosis then? You're saying
No.
if this is an LVH with strain, systolic overload pattern, and then you're saying aortic regurgitation, is that inconsistent?
Yes.
Or can you explain
Could
it?
be an associated aortic stenosis.
You said it's an early peaking murmur.
LV systolic pressure, what do you estimate it as? That's the question.
Okay. I'm not sure.
In the absence of aortic stenosis, or are you talking of in the presence of aortic? Are you saying there is aortic stenosis or there is no aortic stenosis? Only AR.
Sorry, because if there is systolic decapitation, there is presence of aortic stenosis associated. I'm not sure. So, yes,
No, I think your confusion is because you are saying with aortic stenosis, is it? Or without aortic
so
stenosis?
the systolic pressure was aortic.
Let's say there is no aortic stenosis. What is the LV systolic pressure in this patient? You should be able to say it exactly. It's not at all difficult.
Take care.
The blood
Yes,
pressure, right?
yeah,
It's exactly the same as the systolic.
Yes, 130 millimeter mercury. Yes, sir. That was 110. Yes, sir. No, sir.
Obstruction.
No, sir.
Okay. So if you severe AR, so you got severe AR with LV recent inversion, what do you think of? Severe AR and you are getting systolic pattern in ECG. LV dysfunction. LV dysfunction, that indication of surgery. Aortic valve replacement.
Now, is it possible that, the placing of the leads by taking ECG, there will be apex, right? 7 space,
Anterior.
T-rex, line.
But whatever may be,
The pace.
if you put somewhere else, definitely ST depression T inversion will get it.
Oh, fine.
That you
might
can't,
get it
that
two
can't
ways.
be operated at
Go
all.
more lateral, you might be able to detect.
It's a T kind of upright, sir. If you put even version apex also, T kind of upright.
One in AVL, T is upright and small Q waves are there. So position of the lead because that's V6 is always put in the same position irrespective of the apex, right? And if the apex in the anterior axillary line, the true V6 picture you will get.
And that too, sir, you are not getting Q in V5, V6.
One AVL it is there.
No, that is there, sir.
That is, yeah.
One AVL.
And the T is upright there, so.
No, sir, that's a fine, sir, but with the new Q.
My question is.
Hollywood Q not there, septal fibrosis because of the long-standing endometriosis, sir. Hi.
Dr.
that is
Dash,
heart failure.
Dash, my
Sir?
question is, to take put the leads beyond V5, V6, say V7, V8 you take, you'll be able to get a Q wave there, since we have one in AVL. I mean, you can do it and
But T inversions, sir, how do T inversions won't be upright, sir.
Bottom line is, this is what successful examinees do. They end up creating discussion among examiners and they get away.
This is how the
Patient
law.
on antihypertensive drug?
He was treated initially with antihypertensives, but then after his procedure, it was discontinued.
You yourself said that he underwent. Right?
Yes.
Probably there is systolic overload also here. Mention all that.
Yes.
And then diastolic overload. Even in diastolic overload, when they go into heart failure, when they dilate and go into heart failure, LV dysfunction, then again you can get STT changes.
Does LVH regress
But
when
only
you
thing is
treat
that-
hypertension? Does LVH regress when you treat hypertension?
No. Sir.
The drugs which produce LV,
Oh, yes.
are some drugs, right?
Yeah, remodeling is the LV remodeling.
So if a hypertensive patient has LVH and you treat it, that LVH is permanent, is it? No, it isn't. You can regress it with very strict blood pressure control.
So what happens? Suppose we have been discussing about coarctation, we have forgotten coarctation. Somebody has coarctation that has been repaired. Can he remain have LVH, like pressure overload LVH?
He can develop restenosis.
Huh? If he develops AR, there can be that LVH may not regress ever. If you have a coarc repaired,
And
that could be
residual.
another reason. Like, so sir's suggestion that it can develop later. Only problem is that when somebody develops AR, develops LV dysfunction, and then ST depression starts, generally the QRS becomes wider also.
Okay.
Here the QRS is also narrow.
So, chest X-ray PA view. There is cardiomegaly, and there is. So there is the aortic root appears dilate.
Little louder, please. See, one clue in the exam is talk loudly, you appear confident. You give the impression of being confident. And if you say it very confidently, I might say, I might start thinking, oh, maybe I'm wrong. She's been reading recently, my knowledge is old, maybe you're right and I'm wrong. So always present confidently. And for that, whatever you feel inside, talk loudly. Don't whisper and mumble to yourself.
Here you can commit mistakes, not in the exam.
Yes.
So here, talk loud.
So there is cardiomegaly, and the.
Do you think this is an AP or a PA film?
It is a PA film.
Okay, ECG electrodes are there.
Oh.
So you think it's AP? How else do you make out?
So depending upon the scapulae.
Based on that?
So based on that, it is a PA view.
What's the importance? I asked it when you said cardiomegaly, that's at that point I asked you, what's the importance?
So in
What happens to cardiomegaly or the CT ratio in AP versus PA?
yes, in the AP view, you cannot comment on the cardiomegaly because
Why?
it's closer to the chest wall.
closer to the chest,
The-
closer to chest wall, whichever.
I mean
way.
the,
To the film.
the film
So
is
it's
closer to
closer in
the-
which one?
in PA.
PA view. And the other one, it's, so the magnification is greater in the AP view, so they can get a little apparent cardiomegaly due to that. And very often in the CCU, they don't take a deep inspiration also. So you can get little cardiomegaly, but this looks like a PA film. So cardiomegaly is there. What else?
And the aortic root appears dilated. Yes. And there is signs of pulmonary venous hypertension. Hilar, very high.
Why do you say pulmonary venous hypertension? What abnormality have you seen to suggest that?
So there is cephalization and
So
very high.
what do you mean by cephalization?
So the upper 1/3 of the film.
That is outer one third. Upper is what?
Sorry.
Upper lobe
Upper
veins
veins.
become,
Prominent.
or upper lobe vessels are more prominent than the lower. Are they?
Not.
Yeah. Huh?
Lower lobes
Yeah,
are prominent
yeah,
usually. So because of the pulmonary venous hypertension causes the
Does anyone in the audience know the answer to that? Cephalization. Why you get cephalization? And I mean, not where you get it. Yes, it's a sign of pulmonary venous hypertension.
Yeah, please give the mic.
Why do you get that? After all, due to gravity, the lower lobe vessels should be more prominent. Why do the upper lobe vessels become more prominent than the lower lobe vessels?
Sir, because of the gravity, there will be pulmonary edema in the basal part, and there will be hypoxia setting in the basal part and not in the apical part. So there will be vasoconstriction in the basal part, and apical will be more visible than the basal.
Correct. So there is a reflex vasoconstriction and the redistribution of the blood to the upper lobe. There seems to be some shadow beyond the aortic shadow to the left of it. I don't know if that's some kind of.
What are the?
Yeah, exactly. Yes. I would have also definitely thought of dissection or something.
Patient?
Yes.
Can you see that?
Patient is
Yes.
a
I thought it's a root.
Give the mic to sir.
But calcium sign, you should get the calcific, that is not there. There is, what are the other radiological signs in coarctation?
Come.
Is it there?
What are other signs you look for in coarctation aorta?
Yeah, she said watching.
X-ray. Fine, and so.
Fine.
There'll be rib notching between the third to ninth ribs. Third to ninth ribs.
Anteriorly or posteriorly?
It is posterior
Why posteriorly?
because the collaterals are more posterior. The thyrocervical and the intercostal.
No. Notching is
Intercostal.
intercostal. Then why not anterior?
Oh,
Anteriorly, the intercostals are not in that groove. Only posteriorly they are in the groove. That's why you get notching posteriorly. Now can you tell me why you don't get in the first two ribs?
they're not a part of the collateral circulation.
Where do they get the supply from? You mentioned that artery. Thyrocervical.
Thyrocervical.
Okay. Actually, costocervical, not thyrocervical.
The lateral view, sir, they be reverse,
Hmm.
reverse 3 sign. I'm not sure.
The collateral occurs between the IMA and intercostal arteries.
Yes.
So lateral view say IMA creating notching. Where do you get it?
Where does it run? Tell ma'am there.
Posterior. Posterior.
No, this thing should read, guys. It's very basic.
Oh, yes.
They tell you, draw the diagram. Oh, they were straightforward, yes, no. They know this. Draw diagram, learn it, remember it.
There was no delays. 130 to 110.
So the question is there a radial delay in this patient? We have 140 and
There's a
150.
there's a difference in pressure of 20 millimeters between the right and the left upper limb.
So, but the
Left
delay,
being lower.
the delay is because of the delay in the arrival of the pulse, not because of the amplitude. The radial delay.
Normally what is?
No, I'm not asking you the cause for the delay. There is a difference in, I accept your saying, but that was not the question.
Yes.
The question is, why is there a 20 millimeter difference in the pulse on the BP, systolic BP, between right upper limb, left upper limb, with the left upper limb being lower?
Left upper limb lower, right upper limb lower. Which one lower? Normally?
Left, no.
No, he
So the
would say, which one lower? Normally, suppose I take my pressure, which arm pressure is so lower?
right side.
That I'm saying, you should know that is not clear.
Yes, sir.
No, if it is normally examined, sir is asking which is lower.
The left.
Left is lower, so that's what sir is asking.
Are you sure left lower?
Yes.
Why?
So, I'm very.
Then this, go next step.
A difference of 10 between the two sides is acceptable, but more than that is not acceptable, right? So in a patient with coarctation, can you explain that?
If the coarctation is present, then he can have a lower blood pressure in the
You
left.
don't know.
So distal to the left.
Let's say there's a patient with coarctation and you find that the left
If
upper,
it is proximal to the left subclavian, then then there can be a
what kind of
discrepancy.
coarctation is that called generally?
Preductal
No,
coarctation.
the preductal term is gone now. The
Then juxtapose.
aberrant origin, suppose you subclinical get aberrant origin in
Aberrant
descending
origin.
aorta, below coarctation, look at it. Is it?
The other explanation is you're not measure the pressure simultaneous.
Yes.
Measure one arm, then you go to the other arm, so many things. If you measure simultaneously, then of course more variables. There's a difference.
So can we just wind up this case sir, so that we can go for lunch? So you can tell her how she's done.
Good presentation. Just questions was a little probably.
So the actual diagnosis, just to complete, is post-COE, as she said, BAV with severe AR with the left subclavian coming off the repat segment. The left subclavian is actually coming off that repat segment, sir.
Of the?
Of the repat segment of the previous years.
Okay.
And over time, probably as cicatrized, that's how
So some
amount of
stenosis
stenosis has happened.
Okay. And severe AR and no.
Severe AR, no yes.
mitral loss.
No, yes. Bicuspid valve. And the root is 44, ma'am, at that point. 44 mm. 38, 44, and.
Wonder what that shadow is. There seems to be a shadow.
It's aortic arch dilatation only they have reported. So CT was done. There was no other anomaly. So what is the management is, what is the question?
So he is symptomatic and aortic valve replacement. The Bental, if he has, the root is more than 4.5 centimeters in bicuspid
44.
aortic valve. Sir?
This 44.
4.5.
Thank you, Dr. Kavya. Thank you so much. Thank you all teachers. We'll now break for lunch. Thank you so much. It is already later than what we thought, but then we'll reassemble by 2:45 if we can. We have 3 more cases after this. 5 more actually, but we'll try to squeeze in 3. And we have Ramasas and Patnaik sir's talks. So please join us by 2:45 latest. All the delegates can go to the right side at canteen. You can go exit from here and then go in front of the emergency where you have the ramp. We have the canteen there. And faculty can join us in the faculty room. Can my team just help the delegates how to go out, please? Thank you so much, Saram.
this combination is quite useful. Then coronary imaging, its importance is increasing day by day. And Minoka, all of you know what is Minoka. There is no obstructive disease, but there is a presentation like MI, where conventional angiogram will not show a important lesion, but if you do OCT or cardiac MRI, it can show significant lesions. So that is an important finding in heart Minoka study. And discharge trial has shown that both CT or conventional angiogram both are useful in giving similar results on follow-up. So in a chronic stable subset, you can use either of them. Then this has come in the recent theory exam, HOPE 3 trial. Any student who has written correctly can tell? Okay, it says that for convenience of community use, without much testing, you can give a pill containing statins, BP reduction together, and of that, only the statins are beneficial. But the blood pressure reduction without properly examining the pre-administration blood pressure levels is not very useful. That is the message of this one. So HOPE 3 polypill may be used in community heart care, but it's not for clinical usage, I think. That's what I believe. Then acute coronary interventions, there are too many. Paradise MI is very important trial. Anyone can give the message of Paradise MI? It's very, any volunteer? Yeah, ARNI is not so useful as chronic heart failure of non-acute MI situation. So why it is that like that? There are some editorials and comments on that. Please read those things. Colchicine can be used in acute coronary, after coronary events within 30 days. Then pacemaker MI is a use of alirocumab in addition to high dose statins. So it is again proving that inflammation may be an important factor that has to be addressed in acute coronary syndromes. Then remote monitoring by devices, implantable device after MI were not giving any improvement in the benefit. Then treatment of anemia need not be too aggressive by giving blood transfusions. It has to be maintained at 8.5 grams. That is the message of reality trial. Then vascular access, whether you do conventional radial puncture or distal puncture, it doesn't matter much. The events, the benefit is same, the harm is same. Then about antiplatelet therapies, that aim was to reduce the duration of DAPT as low as possible. Now the tendency is to give 6 months or even less if there is higher bleeding risk. There are criteria, DAPT criteria and bleeding criteria, these are there. There are too many details, so I'm not going into those details. But even 1 month DAPT followed by monotherapy is still good in the latest generation of DES. And host reduce has been in favor of using lesser dose of prasugrel in Asians. Then FS trial again favors clopidogrel over ticagrelor or prasugrel. Then Taylor study, genetic testing is of no value in a routine practice to give clopidogrel. Then Taylor's AMI is initially used for 1 month, you give ticagrelor with aspirin, but later you can come down to clopidogrel if you want to. That is the message. Now we have a reverse IT has shown that there is a reversal agent for ticagrelor. So I am only giving the names, a list of the names which are there for reducing the duration of DAPT. Please go through them. All are very important. Then about other trials, Noble and Excel trial, 5-year result have been discussed. There are some controversies about it. Definition 2 is left main stenting, where in non-left main situation, provisional stenting is the best strategy. But for distal left main, the opposite. If you primarily take 2 stents and go with a plan, that is much better than doing a provisional stenting at distal left main bifurcation. That's the message from definition 2. Then there are important trials, erosion 3, which has come in the exams, RIPCARD 2, IFR, all these things talk about the role of FFR. I will tell details of one or two. Yeah, about the Noble and Excel trial, these are left main trials where PCI is given, but in both the trials or the follow-up results, it is shown that they don't match CABG. In spite of the tendency for Excel to, the two curves are merging in Excel, but there is some criticism about the way the statistics were used in Excel group. And in fact, there are a lot of non-technical things also, like BBC has leaked out an information that the secondary outcomes were not properly analyzed in the follow-up. That was the criticism. If you look at the various NEJM articles, you can see editorials have written how they are analyzed and what are the, and one of the surgeon members has left the panel in anger. All those things are there. So this may not be important for the students, but practicing cardiologists should know it. Erosion 3, it is definitely important trial, because if you are, nowadays all the systems are having OCT as an integral component, we can do OCT during primary PCI itself, and we can reduce the usage of stents by 15%. And also the angiographic result which comes out of it is much better than not using OCT. So OCT can be an integral part of your primary PCI because it is proven to be useful. Then RIPCARD, is it useful to do an FFR of all the lesions at the time of diagnostic angio itself? No, it has proven that it is not so good to do that. It's an extra cost and waste of time as well. So because it's not associated with any difference in the quality of life or angina status at 1 year by doing that. Then FAME3 is FFR versus angiographic guided multivessel management, either by DES or CABG, and it was useful to do FFR for multivessel disease and decided. But here also CABG continues to be superior to even FFR guided DES of latest generation. The results were equal. Slightly, CABG was slightly better. Flavor MI is when you are doing primary PCI for non-culprit lesion, is it a good idea to do FFR? This trial says it's not a good idea, don't have to do it. Then Flavor trial is this year's trial, where FFR guided versus IVS guided PCI is done for intermediate artery stenosis. In non-left main situations, either modality can be used. So you can use either this or that. So it is equally beneficial to use this or that. Disrupt CAD3. This is nothing but intravascular lithotripsy. Its usefulness, everything has been highlighted in this trial. And with respect to hypertension, renal denervation therapy had its ups and downs. Simplicity 3 was a little disappointment, but subsequently there are 3 important trials which have favored again. In this spiral medicine off and medicines on, 2 trials were there which were in favor of doing RDN. And Radiance Trio has used a different system. That is the system which the diagram is showing. There is a water cooling system around in a balloon-like device, and it is a very positive trial. So in especially refractory hypertension, this has been tried. Then there are trials about use of thiazide-like diuretics as the first line, that is Legend trial. Then Quartet, half dose of 4 molecules in single pill, that is Quartet trial. Then CHAP trial says during pregnancy if there is hypertension, previously there was a concept that up to 160/90 should not give any medicine, but that concept is not correct as per this trial. So we have to treat even those moderate hypertension patients with a goal of 140/90. And with respect to dyslipidemia, there are 4 important trials or group of trials which have studied especially for the statin intolerant or statin resistant cases. That is Inclisiran, Orion 10 and 11 studies, Eclipse study, then CLEAR studies. CLEAR is very important and relevant to us because already the molecule is in the market. So CLEAR studies, there are 4. That is Clear Harmony, Clear Wisdom, where they are used add-on to statins, and in statin intolerant patients, Clear Serenity and Clear Tranquility. So 180 milligrams of this molecule, several companies are now coming with this medicine, so we can use it in statin resistant or statin intolerant cases. With heart failure, the trials are too many. Impulse trial says use of empagliflozin in acute situation, acute decompensated heart failure. Sodium heart failure says whether you do very strict low sodium diet or normal diet, the events are not different, so need not be so aggressive in reducing the sodium. Then guide HF, the diagram below you see, that is, what diagram is that? Cardiomemis. It is a PA, it is put in the pulmonary artery and patient is allowed to go home and you can monitor remotely the PA pressures. And this guide HF and Embrace HF. FM trial is use of iron therapy for iron deficiency. Then ARNI, in very advanced heart failure, ARNI is not useful. That is the message of it. And SGLT inhibitors are the talk of the world. That is, we have got important 5 molecules now: canagliflozin, EMPA, DAPA, F2, and sotagliflozin. Sotagliflozin is both SGLT1 and 2 inhibitor, unlike other 4 which are SGLT2 inhibitors. So in SGLT2 inhibitors, there are a number of trials. Even the examiners will be very happy to ask all these questions. So you should be ready for Viva. This is a very important Viva question. They may ask you about a role of SGLT2 in heart failure with preserved ejection fraction, reduced ejection fraction. In fact, initial trials were just to prove that they are not having any cardiovascular or harmful effects. As a result of actually rosiglitazone episode, FDA has made it mandatory that any molecule that comes to market should prove that it is cardiovascular safety is there. So that was the initial aim. But a pleasant surprise was that it is in fact reducing the cardiovascular events than just proving that it's not non-inferior. So that has given us a lot of confidence to use in heart failure with reduced ejection fraction as proven in Emperor reduced, then DAPA heart failure trials, then pooled data of Solist and scored. I'm just skipping because of the time factor. And now it has reached a stage where it is there in the guidelines as class 1 indication and level of evidence is A. So now it is reaching a level of ARNI actually. So class 1 indication and level A. So irrespective of the diabetic status. So these are important points. Then the 4 pillars for foundational therapy, you can call them as foundational therapy for heart failure with reduced ejection fraction. The 4th pillar is the SGLT2 inhibitors. Then iron deficiency, how do you define? Ferritin less than 100 micrograms per liter, TSAT less than 20%. FARM trial has shown that usage of intravenous ferric carboxymaltase is very important. It's quite common. Actually, iron deficiency is quite common. You should not go by hemoglobin percentage. Okay, you should do iron studies in all the heart failure patients. And now it is given the 5th pillar, status of 5th pillar in India at least. Then sodium heart failure, I already told. Then there are some novel drugs. In the morning, during the case discussion, we were talking about mavasentem. It is a myosin inhibitor. It is studied in several trials, Maverick and Explorer HCM, Valor HCM. Then even valsartan has been tried in HCM. in a small trial, it has shown some benefit. And Victoria trial has studied Vericiguat. Now it is important accepted drug. FDA has approved it. Then Galactic trial is the omnicomtive. It is a positive trial. And there is another trial also, Meteoric trial. So there are number of trials in heart failure are too many. Some are small, some are big, but some of them are interesting because of the novelty, that is dream heart failure. Here, allogenic mesenchymal precursor cells have been injected endocardially, and it is again a positive trial, small trial. Then atrial flow regulator. There are some trials with that, several devices are available. Then heart failure with preserved ejection fraction. More and more cases we are seeing clinically also after this concept has come. There is a scoring system to identify this entity. Now SGLT inhibitors are indicated, though the recommendation is not as strong as for reduced ejection fraction, but in absence of any other better drugs, probably it is correct to use them. Then respond heart failure is about pacing in heart failure with ejection fraction, preserved ejection fraction. Then there are trials with phenylalanine, which is a non-steroidal MRA. Then with respect to valvular heart disease, Avatar is, if there is asymptomatic AS, it is better to do either surgical or TAVR, some way of correction earlier than what it was. Previously, we used to leave them for long without addressing them, but now it says that better intervene earlier. Then most important discussion about TAVR is what important anticoagulation we have to use. You look at this particular chart, there are a number of trials of them. Some of them are very latest, like Atlantis. Whether you have to give anticoagulation or only antiplatelets will do, or a combination has to be given, or we have to go with warfarin. This issue is not fully settled so far, but there are trials. Why all this concept has come? You know that various CVA incidents, either with surgical AVR or TAVR, is about 1 to 11%. Various reports are giving various reports. But if you do for the CT, there are subclinical events. There is something known as HALT, that is hypoattenuated leaflet thickening. Okay, that has been shown, and subclinical leaflet thrombosis. These are, it's important. What is the exact clinical importance of this is not yet known. What is known is by giving oral anticoagulants, it will reduce the subclinical leaflet thrombosis, but whether it will result in reducing the cerebral thromboembolism, stroke or TIA is not yet proven. So whether to give or not, the final say has not come, but it is very interesting observation. You see these pictures, halt, no halt, halt less than 25%, 26%, 50%, that is 75%. So the recent trial is there, that is known as ADOPT TAVR trial, which has shown that the overall incidence of leaflet thrombosis was about 8.5%, and whether this will affect the future CV events or not, CNA events or not, is not yet proven. Then quickly about other valves, TriClip and TriSend study has shown that the devices for tricuspid valve are now coming up in a bigger way. The pilot trials and feasibility trials are already over. Then atrial fibrillation is again very big chapter. There are a number of trials which talk about rhythm control is better and should be attempted at least in the new onset atrial fibrillation or paroxysmal atrial fibrillation or intermittent atrial fibrillation. And ablation, if you do earlier, to correct the arrhythmia is better than rate control. Then there are good registries on LAVO, that is left atrial appendage occlusion does better than NOACs or any anticoagulation. Then there is NCDR registry which talks about Watchman device registry, a new device that is Emulate IDE. It uses 2 discs, you see there, there's 2 discs here. This is a new device. This particular trial has tried that, and they propose that it is better than using a single device like Watchman device. This is a lariat system where the left atrial appendage is ligated. Then with respect to pediatric cardiology, there are a few trials. Panorama is with ARNI in children. Hauser RCT is evolocumab in familial dyslipidemias. Rivaroxaban usage in Universe trial and dabigatran. Then there are ICDs for pediatric and miscellaneous trials. I think I'll stop here because of the shortage. They have 5, 6 more, but I think you can share from the organizers. I can share this PPT with them. Thank you.
So we sincerely thank you for running through all those trials. As Sir said, it is just a prelude. You will have to go into each trial and read the essence of it. Krishnan sir, we'll have the 2 talks now. So we'll have one talk, we'll have a case, then we'll give you some rest, sir. So we'll have a talk on the cyanotic coronary heart disease. I'll give.
So, good afternoon. So, how many of you think that the last cyanotic case that you are going to see in your final exam is going to be your last case of cyanotic heart disease that you are going to see? Nobody is raising hands. So, at least I will help you to get rid of that last case. So, it's not that, like if we are in South India, so things are very different. So, if you look at North India, like, can you guess like how many pediatric adults will be Bihar and UP? Guess, any guess? Total number of pediatric adolescents in UP and Bihar, where I think quite a large number of children will be born for the next few decades. Any guess? 5. Actually 5. So our country has to go a long way, and I think you may find a lot of pediatric adolescents in Bangalore and Hyderabad, but that is not true for the interiors of the country, where some of you may go and practice. So I think basic recognition is a must. So I think basic understanding and basic recognition is a must in a country like ours. That's why I think adult with congenital heart disease still remains important thing, where I think you should have the basic knowledge and basic approach to that. And unfortunately, if you start asking coronaries to you also, you won't answer and you won't pass. I get you, I guarantee you. So I think this is at least easier to learn and easier to pass. Maybe 1 or 2 classes and 1 or 2 lectures is good enough to pass. But coronary, you have to read a lot, quite a lot. If coronary case becomes long case, I think you just have to sit and read, go through all your guidelines. That is better for you all, better for the country maybe. So what are the diseases that you are likely to encounter? It's not changing here. Okay. So you have the common condition that are going to find is nothing major. There are likely to be only 3. Your job is to make which one of the 3. So it's going to be either TOF or TOF-like physiologies, Eisenmenger syndrome, and rarely it can be Epstein's, and nothing beyond that. So it's very simple. I'm going to let you one case out for you all. If you find an adult with cyanotic congenital heart disease, either it's going to be some form of tetralogy physiology or Eisenmenger or Epstein. And why are people so fussed about that? It's hardly anything. So it's going to be any one out of that. So before that, just a basic determinants of cyanosis. So the cyanosis will depend on a lot of things, the hemoglobin level and type, and obviously the experience of the examiner. And most important thing is excise desaturation is a must now. So saturation is another, probe is another vital. So everybody should take it in the exam. And if the saturation is borderline or you think that it's a cyanotic patient but you are not finding it, you must take excise into saturation provided the patient is not in class 4 heart failure. The simplest thing you can do is ask them to walk for 6 minutes in a corridor and check the saturation. And this is another important thing that you all know in an MCQ format, but when you're asked in the exam, you don't answer. So cyanosis detected with the reduced hemoglobin is greater than 3 grams. So the amount of saturation at which the cyanosis will get detected will vary upon the total number. So coming to, there will be various other causes of saturation, which I won't be going to the details, like heart failure can produce peripheral saturation. Arterial desaturation will be only the 3 that I told you in adults. You can find many other reasons, many other conditions uncommonly. So you'll try to find a common approach to all these conditions. So basic understanding is very important of the hemodynamics, as I told you, like when you are asked about hemodynamics, you should be able to answer what is happening, why the patient is blue, you should be able to answer. So normal heart is very simple. The systemic venous return directly goes into the artery. There is no problem. Everything goes, the QP is equal to QUP, that is effective pulmonary blood flow, which is equivalent to the QS, that is systemic blood flow, and that is equivalent to the QES. But in top physiology, so this is what is the problem. So there is some problem starts now. So some amount of right to left shunt starts to happen at the VST level or the great arterial level. So what is going to happen here? QP is equal to effective blood flow. That will be systemic venous return minus the right to left shunt. It's very simple. If you go through the chart, it's very simple. This is what is going to go to the lungs. That is the systemic venous return minus whatever has gone to the right side, right to left shunt that has gone. Then the body, what is going to happen? The pulmonary venous return plus the right to left shunt. So the amount of right to left shunt is going to determine what is going to go to the body. But coming to the admixture physiology. So admixture physiology, fundamental understanding is whichever chamber beyond the admixture happenings, all the saturation will be same. So you put sambar, rasam and everything into one mix, you can't make out which is sambar, which is rasam later on. So after that, everything is same. So this is what is going to happen. So, but in TGA physiology, what is the crux of TGA physiology? If you have to tell your junior guy, what is the TGA physiology? One word answer is pulmonary artery saturation is more than aortic saturation. The pulmonary artery saturation will be more than aortic saturation. So I think rest of the things are anatomical, left to right, right to left, all those things. I don't think DM cardiology also will stop asking now. So anatomical right to left, anatomical left to right, physiological right to left, physiological right to left. I think if you have to fail somebody, then you can ask all this. So then this is enough. If you know this much, that's good enough. But fundamental understanding is somebody is blue, there can be 3 physiologies at work. One, right to left shunting can be one big physiology, out of which there are 2 pathways. Right to left shunt can be happening because of either pulmonary arterial hypertension or because of some PS. These are the 2 fundamental classifications. Or there can be an admixture physiology happening. Or there can be a transposition physiology happening. So these are the fundamental basic hemodynamics behind all these tetralogy physiologies. So classical thing is, in top physiology and Eisenmenger, there will be step down happening at ventricle to aortic level. Whereas in transposition physiology, the pulmonary artery saturation is more than the aortic saturation. And in admixture physiology, every chamber beyond the chamber of mixing is going to have the same saturation. So for example, common atrium means from common atrium, LV, aorta, everything will be the same saturation. In a TAPVC, if it's a supracardiac TAPVC, even that SPC part beyond the connection where the joint, everything is mixing, from there everything will be the same. If you go beyond that where that SPC is connecting, then the saturation will be different. You may be able to show a step up. So this is just a fundamental aspect about hemodynamics. So So as I told you, like I'm going to concentrate on two things, natural history and hemodynamics. Rest of things, clinical finding will tell you some tips. But natural history of CCHD in adults. So this is what commonly asked, like, so transposition of great arteries, look at the incidence at birth. It is 0.34 per 1,000 live births. But look at the 1 year survival is only 20%, 80% die. Next comes the hypoplastic left heart, then tetralogy of Fallot. Actually, tetralogy of Fallot is actually number 3 when it comes to cyanosis at birth. But overall, look at the survival. Because of survival, 70% are going to survive till 1 year. That is why after maybe a few months, the most common cyanotic engine heart disease becomes tetralogy of Fallot. So in a simpler fashion, this could be a very simple chart where common disease with expected survival, they are only tetralogy, Eisenmenger, and uncommon defects with expected survival, they are Epstein's anomaly, and very rarely you have PS with intact septum with ASD or a PFO shunting right to left. So these are the 4 conditions extrapolated that you can get. But rest of them, uncommon conditions like total anomalous pulmonary venous connection, double outlet right ventricle, transposition, univentricular heart, truncus arteriosus, tricuspid atresia, they're all very rare. But since you are in an academic institution, we are such a large country, you still keep on getting all these patients. For example, unoperated tetralogy physiology, in the whole of UK, you won't find more than 20 odd survivors. That is what it is. The whole of UK has around 200 Eisenmengers. And out of which they make 200 papers. Really, it's reality. What I'm saying is real because every Eisenmenger is referred to one clinic and they have all the data from their birth. So that is how they make real science out of it. So we find all this because we are having quite a lot of them. But still, despite all this, these are the various survivors in adulthood. Like, look at the survival rates. Unoperated survivors, you can have a CCTG at 9 to 1 years also. These are all may not be, I have not updated the slide, maybe some more could have been reported. But no longer people will be reporting adult survivor alone in today's time. So but these are the well-documented survivors, maybe some more could have been come. So natural history of tetralogy. So survival is roughly around 75 to 65% at 1 year, and it's 50% at 5 years, like half, 1/4 at 10 years, and only 4% at 15 years. Even if you find 20-year-old tetralogy, he's actually naturally selected guy who has gone through the whole thing. And the top-leg physiologists, the other top-leg physiologists have a further poorer outcomes compared to tetralogy. So whatever be it, even if a pink tetralogy comes to you at whatever age, generally if your surgeons are good and your operative mortality is decent, all of them should be operated. So history of cyanosis, generally in tetralogy, this has been what we are discussing, like generally at rest it can be there, and initially it can be at crying or activity. So that is why exercise-induced desaturation is very important. So simple numbers, 25% are cyanotic at birth, and 75% are cyanotic by 1 year of age. So it's easy to remember, like. So 25% are cyanotic at birth, and 75% are cyanotic at 1 year of age. So this we have already discussed, like why late appearance of cyanosis is related to progressive increase in oxygen demand of the growing child, increasing PS because of muscle hypertrophy and fibrosis, and after birth there is a slow change from hemoglobin F to hemoglobin A, and then there is a reduction of blood flow that can happen because of acquired narrowing in PD and MAP cause because of pulmonary atresia-like situation. But more importantly, in general, without excluding those syndromic associations, generally tetralogy means quite good growth. So if you carefully look at a lot of children, where you find a lot of these VSD will be tiny little babies with failure to thrive and lower weight, most of these tetralogy will be chubby babies. So they have normal growth and normal weight gain in general. So the age at which the spells occur is generally 6 to 2 years, but generally it can start from around 2 months to 2 years. It can start from 2 months actually. It is generally 6 months to 2 years. So various theories have been said. So most importantly, we say what is the most important theory of spell is infundibular spasm. The immediate response from the examiner, so do pulmonary atresia develop spell or not? Yes, you will say yes. Then what are the mechanisms? So if you are asked, then you say that this is what it is. So then immediately once you start 3 sentences, we know that you know the answer, then we move on to the next question. So just it's very simple. Like there are various theories nobody knows. So if you look at many other things in medicine, that we don't know the real crux of the things. Like so even cyanotic space, we don't know the real reason. So these are the various theories. And squatting we have discussed enough. One of the important thing is like 3 to 10%. Indian series have reported around 3 to 10% of Eisenmengers also can report squatting, because it's a mechanism by which right to left shunt reduces. So technically it should be there. So these are the various squatting equivalent that I think we had quite a big discussion today. So the mechanisms also we discussed in the morning. So with this background about natural history, how are you going to approach an adult with CSUSD? So, like first and foremost question, we have to answer only 3 questions. That's all. First and foremost question, it is TOF, Eisenmenger or something else. Second question, if it is TOF, is it going to be TOF or TOF-like variants? So, third is, if it is Eisenmenger, which Eisenmenger? So, there is no rocket science in any of them. It's very easy if you follow a systematic plan. So the $1 million question in the cyanotic engine heart disease is going to be the TOF or Eisenmenger. So in the morning presentation also, you were not emphasizing on all these 3 points because you were not aware that these are the 3 points you are looking at history. So what are the 3 important points that we are looking at a history and differentiating between TOF and Eisenmenger is the quantum of cyanosis, the onset of cyanosis, and how the cyanosis has progressed. This is what we are looking at in the history from cyanosis point of view, and history of spells and squatting. So this is what is going to help you in differentiating between from history stage, because every short case, you are going to be stopped at the history stage and asked what are the possibilities. So for that, you are going to put your money on these 3 based on these 3 points. So if it is spell is there, 100% it is going to be some TOF or TOF-like physiology. So if the cyanosis is generally mild in Eisenmenger syndrome, and cyanosis is generally deeper and gets deeper and deeper in a tetralogy-like physiology, whereas cyanosis is generally mild in most of the Eisenmenger syndromes. And squatting generally indicates tetralogy-like physiology, but as I told you, 3 to 10% of Eisenmenger syndrome may have squatting also. So just because of squatting is there, you cannot exclude Eisenmenger syndrome in our country. So I don't think any other point is there to differentiate based on your history. But you have to analyze your history and present your history in such a fashion that you understand all this and bring the best out of your history. So digging a bit more detail, so some of the important thing is approach from history is age at which the cyanosis appeared, and age at which the patient was told to have a heart disease, and when did the patient have heart failure, and if at all he had heart failure symptoms, when did he first notice heart failure, and what happened to the heart failure later on, and then failure to thrive. So when do a TOF like a cyanotic engine heart disease have failure to thrive as an important symptom? That means recurrent respiratory tract infections and poor weight gain. They are going to have it when they have some things due to increased pulmonary blood flow, like for example TGA that has gone into Eisenmenger syndrome, or a VSD which started with VSD and then later on developed a PS like narrowing, or something like this. So initially increased QP-like syndromes. Or one thing that can produce this is TOF with absent pulmonary valve. So TOF with absent pulmonary valve classically has failure to thrive and has recurrent respiratory tract infections and admissions during infantile period. So hemoptysis, hemoptysis can be there in both tetralogy and Eisenmenger syndrome. Both can have hemoptysis. And this is another important thing. If somebody has tachycardia-like palpitations, so what are the possibilities you should consider? The common possibilities are Epstein's anomaly, AV canal defect, CCTGA, and heterotaxy syndromes. All of them are associated to have bypass tracts. And if you have syncope, syncope can be structural syncope. So PS, intact septum is likely to associate with syncope, and rarely Eisenmenger syndrome can have syncope, rarely in advanced stages. But if the AV block is a predominant thing, again the same things like AVSD, CCTGA, and heterotaxy syndromes are the ones that are likely to have the blocks. So TOF physiology, so the classical TOF physiology has these 3 things like unrestricted VSD, you have pulmonary stenosis, and that will lead on to central cyanosis. So, what are the physical findings in tetralogy? Very easy to remember. It's not difficult at all. Nothing. Nothing is the most common physical finding. You don't find anything in JVP. You don't find nothing in pulse, nothing in blood pressure. Everything is normal. So, what is the only finding you can get in JVP? Is there can be in adults, you can have a wave can be prominent. So that is the only finding in JVP. Parasternal heave, no parasternal heave. Apical impulse, arbitrary apical impulse, no cardiomegaly. Finding wise, literally nothing. One single S2, not even two sounds, only one sound is there. One murmur. The cyanosis becomes more, that murmur also disappears. So best thing to remember is tetralogy or auscultatory physical finding is nothing. If you find something, think about something else. So systolic thrill is uncommon. So when do you find systolic thrill in tetralogy? Very rarely, being tetralogy, you can find a systolic thrill in the pulmonary area. So ejection systolic murmur, we all know that murmur is inversely proportional to cyanosis, and there are no diastolic sounds. Everything is clear. So this is how it is. Like why do you get a single S2 in tetralogy? So the P2 can be soft, inaudible, or delayed. So P2 is delayed due to prolonged RV hangout interval. P2 is soft due to thick and tethered abnormal pulmonary valve. High viscosity blood also may contribute. So you may be asked why the second sound is P2 is absent, and P2 may be still heard and can be widely split also if you can find pulmonary blood flow is very good. So P2 is absolutely absent in pulmonary atresia. It's quite obvious. So the ejection systolic murmur is generally in the ROT region. So there is a large VSD and there is a PS. Which produces murmur? I heard VSD producing murmur as the answer in some of the exams also. So VSD cannot produce a murmur because both the pressures are equal. So the murmur that is going to happen will be at the ROT level because of the blood flow. So that murmur will be dependent on the amount of blood flowing through that ROT region. So turbulent flow across the narrowed ROT produces that. Exact location is based on the site of obstruction. If it's a predominant valvular, it will be higher up. If it is a infundibulate, it will be lower up. DCRV can be further lower down. And wherever is the obstruction, beyond that, if it's an intact septum, beyond that only you will have a left parasternal heave. So usually it's an early peaking murmur. Intensity of the murmur will depend on what are the characteristics. Suppose you at times find murmur is very good and the patient is, we will come to that later. But some of the things that apart from the amount of blood flow that determines will be the amount of blood flow across ROT, and another important thing is the viscosity of blood. So that is another important thing. The altered Reynolds number is the reason why the viscosity of blood leads to the change in the murmur. Anemia increases intensity, whereas hyperalcohol viscosity reduces the intensity. So coming on to ECG in tetralogy, we had a discussion like we again reiterate the findings like it's RVH, right axis deviation, right ventricular hypertrophy, and early transition. The next question comes, what is early transition? Early transition means earliest appearance of S wave in the V2. It's not equal, it need not be equal, it need not be more than R wave in V2. Earliest appearance of S wave is what by definition is early transition. So why do you get early transition? So we had the argument in the morning you have heard. Sir also pointed out that even though everybody describes it as it's a large coronal defect, the ECG is recording the posterior wall, but the unfortunate part is that is so true. There are some tough like VSDs alone that happen. So many of them, they don't have that early transition. So we really don't understand why that is clearly early transition, but for practical purposes, you can answer like this. If the examiner asks you, then you can go on to these details. So you understand what I'm saying? Like if you find a large VSD alone, there is no PS. You must have seen Malaland VSD alone in echoes, and there is no PS. You could carefully look at those ECGs. Many of them, majority of them, don't show the characteristic transition like this. So that is the problem. And one more thing to look at is the often V5V6 we don't look at. But what is the importance of V5V6? What does it tell you in tetralogy? It tells you the amount of pulmonary blood flow. So the pulmonary blood flow is very good, the LV forces are more. So if the pulmonary blood flow is very poor, the LV is chickish and the LV forces are not there. So I'm talking about only tetralogy. We'll go to the other physiologies later on. So you all know that both comes in various sizes and shapes. So same way, tetralogy ECG X-rays can be of various shapes and sizes. But then everybody asks, the favorable question is, why the heart is boot shaped in tetralogy? Why is it boot shaped? One person. He will get extra chai today.
And the pedicle that is formed by the...
So you have the pulmonary bay that produces characteristic appearance. So important thing is decrease pulmonary blood flow and always look at the right-sided or the left-sided arch. Because that was once upon a time very important, but now even for a BT shunt, the surgeons don't depend on us. They are able to do if it's the right arch, left arch, so the importance have come down. But otherwise, the right arch used to be one very key finding based on which the diagnosis, the prognosis, and the outcome of surgery all were dependent on. So, moving on now from tetralogy to various other physiologies. So, what are the other top-like physiologies? So, you have DYV VSD-PS, tricuspid atresia VSD-PS, TGA VSD-PS, you have CCTGA VSD-PS, you have AVSD-PS, you have single ventricle and various heterotaxy syndromes. These are the various possibilities of tetralogy-like physiologies. Okay, so you simply, if you have to answer, simply think like this. Okay, so tricuspidal atretic, there can be AVSD. Then if you go to great results, there can be DYRV, there can be TGA, there can be CCTGA, and there can be single ventricle, and there can be heterotaxy. So sequentially, you can enumerate everything. So, how do you differentiate between each of them? Because otherwise, some people have started sleeping. They all know that they can get the slides or they can get the recording and see. So, anybody point by point, what are the conditions that can be diagnosed by clinical examination? So, first and foremost, most important thing is LV dominant or RV dominant. LV dominant apex. Once you find an LV apex, there are very few conditions that should come to your mind. So what are the cyanotic annular heart disease, not tetralogy physiology alone, that can produce LV apex? Tricuspid atresia VSD-PS, okay. Single ventricle, some form of single ventricle can have. Epstein's can have, very good. PAIVS, very good. Pulmonary atresia with intact ventricular septum. So you have to have a left, think like this, like if you have to have a left apex, RV has to be diminutive or RV has not be there. So that happens in tricuspid atresia and intact septum pulmonary atresia. These are the two conditions that are there. And another one condition is Epstein's anomaly, where RV is in trouble. So these are the three conditions where RV is totally in trouble. So what are the thing? Where there is no RV or only one ventricle is there, that is single ventricle. So one more rare condition that you may not say also that is okay, that is when you have DYRV VSD-PS with restrictive VSD. That is an eccentric condition that I think we must have seen maybe around 10 cases in AIMS in total. But that is DYRV VSD with PS with restrictive VSD means what? So DYRV, there is no outlet for LV. LV outlet is only VSD, that gets restricted. That means the LV picture becomes suprasystemic. You have findings like aortic stenosis like findings, heaving apical impulse, all those things will be there. That's a very eccentric situation, but that is one very important thing where none of you should make a mistake. So that is one. So how do you diagnose CCTGA? CCTGA has a very peculiar findings. You can easily pick them up and say this is CCTGA. So what are those findings? Number one, very simple. When you find discordance between your situs and the position of the heart, that means situs inversus levocardia, situs solidus, dextrocardia, that discordance generally increases the chance of CCTGA. Number one. Number two, L post aorta. L post aorta means it's a left and anterior aorta. So in my left L post aorta means my aorta will be here, left and anterior. In my second position, either you find A2 loudest here or a palpable sound here, or you find a pulsation here. Any of them. So you can put your foot down and say this is likely to be CCTGA. An L post aorta, either you find one single sound which is the loudest here when you think P2 is absent, when the patient is cyanosed, and you find a pulsation here or you find a palpable sound here. All the three suggest that it is going to be CCTGA. So So as I told you, like pulsation in the second intercostal space is L post aorta and LV impulse, tricuspid atresia, single ventricle, Epstein and PIVS. I have put them in bracket because they are actually not classical tetralogy like physiologies. And then DVR with restrictive VSD as we have discussed. Then murmur out of proportion to cyanosis. This is what Sir pointed out. Sir asked in the morning also. So what do you think? Like suppose you have been taught like, okay, a blue patient, significantly blue patient, should not have a good murmur. Should have very, very faint murmur. But if he has a very good murmur, so what is the explanation? Very simple explanation. Something else is playing apart from the pulmonary blood flow. That means what? Either an admixture physiology or a transposition physiology is at work. Very simple. So your pulmonary blood flow is very good, you are putting a good murmur, very good murmur, still the patient is blue. That means something else is at work. So most common something condition is either TORV or TGA. TGA doesn't happen because TGA, the PA becomes quite posterior and then it doesn't happen, that doesn't produce this. So commonly this problem happens in DORV. So why this happens? Because there is an unfavorable streaming apart from the pulmonary blood flow in a DORV. That happens in significant minority of proportion of patients, but when you are up against it, like you find a classically very blue patient, the saturation in the 70s, but you find a good murmur, you should think of some other thing producing more cyanosis. Clear? So, other things, moving on, what are the other things that suggest you various other physiologies is murmur of aortic valve regurgitation, the AV valve regurgitation. So obviously that indicates it has to be AV canal defect or CCTGA. And then early diastolic murmur of PR. That is very rarely you find it, but if you find it, you should point out towards either TOF with AR or TOF with absent pulmonary valve. Other causes, other common causes, other rare causes could be truncus arteriosus, truncal regurgitation, and PDA with PR. So these are the cyanotic congenital heart disease that can produce, that can have significant EDM. So there is nothing is there. It's like simpler than 1 + 1 = 2. Only thing is you should know what is 1 and what is 1 and what is the addition. So we already decided complete heart block we told, and mesocardia and dextrocardia, CCTG more likely. So one more important, it's a smaller point, it's a minor point, but for the relative overall, if you look at say 100 TOF, compared to them, if you look at TGS, the cyanosis is generally likely to be more. So TGA VSD PS is likely to be very, very blue compared to a TOF. But TOF, you can see, TOF can be very blue to mild blue to pink also. But in general, 100 tetralogy, 100 TGA VSD PS, TGA VSD PS is likely to be very blue. Today, CCTGA and some of the single ventricles are likely to be less blue. So this may also help you in differentiating from history as well as physical finding, which is likely. So these are minor points, relative points. But other ones are very important points. So why are they different? Because as I told you, for the same degree of pulmonary obstruction in QP, the QEP is lesser than in tetralogy. That is the fundamental hemodynamic physiology. So there is something else at work where something else is reducing the Q effective blood flow. So how are they different clinical presentation wise? Generally, there is early onset of cyanosis. The QP may be greater than, QEP will be far less than QP, and the flow across RVOT may be more than tetralogy for the given amount of cyanosis. And murmur in RVOT may be louder than in tetralogy. And cyanosis will be more for the same degree of QP. So these are the various things based on which hemodynamic can be thing. So I will touch upon one slide on each of the communal lesions that you are likely to encounter in the exams. So DORV VSD-PS. It is the most misunderstood disease in clinical presentation wise. Most of the DORVs you cannot distinguish from tetralogy. Most of the DORV VSD-PS you cannot distinguish it from clinically from tetralogy. Why? Because most of them are subaortic VSD. That is the commonest variant. So that is almost like tetralogy. So even surgeons don't expect us to report whether it is tetralogy or DORV VSD-PS anymore now. At one point of time, they used to be very, very frantic about it. Now we override is 50%, 60%. All those things don't matter for the surgeons now. So it hardly matters clinically, whether it is 60% override or 50% override, whether the cytometal continuity is there or not, provided it's a subaortic VSD and it is normally related weight vessel. So you will find it very difficult to differentiate on echo also. Clinically, there is no way you can differentiate on echo, except only one thing, the right axis deviation will be more than some textbook write plus 120 plus and somebody says plus 135. So if you find a right axis deviation which is beyond 120 degree, then you should think of DRV VSDPS. Just everything else remain the same. So clinically you cannot differentiate normally related vessels with subaortic VSD. Subpulmonic VSD is similar to TGA VSDPS. A subpulmonic VSD with DRV subpulmonic VSD without PS is known as toxic being anomaly. So the operative mortality, operative outcomes, everything like TGA VSD. Same way, DRV subpulmonic VSD behaves like TGA VSD PS. Whereas non-rootable or inlet VSD, they behave like more like admission physiology with PS. And this rare disease we have discussed that restrictive VSD will have LV apex and LVH. So the most common 90% variant you cannot differentiate it from petrology, except for some finding in ECG. So it may have relatively deep cyanosis and maybe having a loud murmur for a degree of cyanosis and ECG may be characteristics. So this is about DRV. So TGA VSD-PS, so you have relatively deep cyanosis and loud murmur for the degree of cyanosis. This often is not found because I told you TA is not there in the here. So ECG may have biventricular hypertrophy with right axis deviation and X-ray is very characteristic that shows the narrow pedicle. So CCTJ VSDPS has a lot of good findings based on which you can put your foot out and say, this is a CCTJ VSDPS. So cyanosis is variable. So many of them are generally not very blue, or if they are blue, also mildly blue. And may have bradycardia if there is CHB associated with it. And palpable native with aortic pulsation in the left second intercostal aorta. And S1 may be soft because of PR prolongation. ESM is less prominent because of the posterior pulmonary valve. And it's better held in the third left intercostal space, subvalvular. And AV revegetation murmur may be heard medially. So these are the various findings by which you can think about CCTJ. So ECG CCTJ is very characteristic. So there can be conduction abnormalities, and there are absent Q waves in V5, V6, and Q wave in V1, V2. Absent Q waves in V1 and AVF, Q waves will be found in 2-3 AVF, 2 and AVF. So this is very characteristic. So LAD, left axis deviation, but it's not very common in setting of CCTJ VSDPS. So this is another important thing. I think this is given in nicely, much more nicely in Tandon's book. How many of you have that book? Dr. Rajan Tandon's book? So nobody can enter the exam hall without reading that book. That book takes 2 hours to read. So that's so good. So you should all read that book. So Rajan Tandon's bedside diagnosis of CST. So it's a very simple book. It won't take you more than 2 hours. It's beautifully written. So most of these things are given there. So the most common finding you find is right axis deviation and RVH. So right axis deviation RVH means TOF, DRV, TGA and single ventricle. If you have right axis deviation with LVH, hypoplastic RV and single ventricle. Left axis deviation with LVH is tricuspid atresia and single ventricle. Whereas left axis deviation with RVH is extremely rare, then you have AV canal defects, the primary one. So single ventricle is predominantly there everywhere. Single ventricle you can say for anything and get away. But simply right axis deviation with right ventricular hypertrophy with left axis deviation is AVSD, that we all know. So that is very clear. Left axis deviation with LVH is tricuspid atresia, that also we know. So I think the rest of things are very easy. So just looking at ECG axis and LVH or RVH, you can make a simple diagnosis, a very simplified, oversimplified algorithm. So some basic about management. So two ventricle repair will be possible in all these conditions like VSD with PS, DRV with VSD PS, CCTJ, AVSD PS, and TJ VSD PS. So single ventricle palliation will be the rule in tricuspid atresia VSD PS, single ventricle, most of the heterotaxy syndromes. So they are going to be single ventricle pathway. So in these conditions, what determines whether the patient will go, the conditions on the right of the screen, what will determine whether the patient will go for a single ventricle or two ventricle pathway. So whether they have adequate two ventricles, whether one of the AV valves is hypoplastic or atretic, some of them can have with these combinations. And most importantly, in DRV, in TGA, in CCTGA, not in AVSD, but most of the other conditions, you have to have an LV which is iota BSD, you should be able to route LV to iota. So if it's not routable, you have to do some other procedures. And the AVSD has to be a balanced defect. So these are the various things that determine whether the patient will go for a single ventricle palliation or a two ventricle palliation. So I'm just touching about the basic thing in management. So how do you determine the surgery? So these are the various factors that are important. So obviously we look at whether the need for surgery, whether the patient has symptoms or not, whether the patient, how much is the cyanosis, whether the patient can wait or not, whether the anatomy is one pump or two pump, what are other associated complexity, whether the patient needs a conduit or not, and how good is your expertise at your place, and associated dial lesions, what are the lesions. These are the various things that determine what surgery at what time. So in children, two ventricle repair is possible, TOF-like physiology. Most of the Indian centers are now comfortable to operate around 5 kg of weight, roughly around 5 months of age or 6 months of age. We are all comfortable in operating. So palliative, what are the palliative options that are available? If we cannot operate by that time, patient is cyanotic spell, but 1 month old, 3 kilo, what can you do? One BT shunt, what else is possible? So RUT stenting is possible. If there is a PDA dependent thing, PDA is there, then you can do a PDA stenting. So you should know something about RUT stenting, PDA stenting and all those things. And then ICR is generally, now we are okay with 5 months to 2 years, and generally conduit, if there is a need for a conduit, except in TOF with absent pulmonary valve or truncus arteriosus, generally rest of the conditions, we generally operate around 1 to 2 years of age. Most of the patients who require a conduit. Ideally, we would like to operate around 4 years of age. So single ventricle pathway. So if it is a BT shunt, so we are talking about only PS pathway, BT shunt and Glenn. Glenn, at what age you can do Glenn? Ideal age is, nowadays we can do a Glenn, we say around again the 4 months to 5 month age, we can start doing Glenn. And generally, ideally, if everything is all right, then we should do a Glenn by around 1 year of age. And at what age you should do a Fontan? So Fontan should be done in 3 to 4 years of age. That's the ideal age. But sometimes you can actually need not do a BT shunt in all of them. Directly you can do a Glenn in many of them. If they present late or they're doing well till 1 year of age, if there's no spell, nothing is there, mildly cyanosed, you can wait till 1 year and then get a Glenn directly. Or very rarely you can, then you can go from Glenn to Fontan, or rarely you can go to from BT shunt to Fontan also rarely, or you can do directly primary Fontan also in selected patients. If everything else looks all right. So what is the upper limit at which Glenn is very effective? Upper limit of age. I'm asking something which is physiological, that's why I'm asking. At till what age Glenn is very effective in relieving cyanosis? Suppose, for example, my question is 12-year-old comes with some strikes that it's a VSD-PS. He's blue. You want to operate on him. Will you do a direct Fontan or will you send him for a Glenn followed by Fontan? 12-year-old. Anybody wants to answer this? So 12-year-old, everything else is all right. We will prefer. Why? Glenn may not relieve cyanosis enough. So why? Use your mic so that everybody can hear it.
Ratio of SVC blood to the IVC blood changes, like normally in the newborn.
So the ratio, what she's saying is ratio of SVC blood to IVC blood changes. That change happens around 6 to 8 years of age. So beyond that, the quantum of blood that is going to proportion of body's blood that is coming from SVC changes. So beyond that, generally cyanosis relief is not enough. But if you have a borderline patient where Fontan is not possible, you have no other option but to go through the Glenn pathway, but convert them into Fontan very quickly. But this is a physiological thing, we expect you to know this. Like. So in algorithm in adults is that we already discussed. So generally we tend to go for a primary Fontan, Glenn only when there is LV dysfunction or borderline such situation where the pressures are high or then there is a significant AV vegetation where repair may not be successful, then you better do a Glenn first. So whereas generally ICR or conduit is the preferred option, palliative is only when ICR is not possible. So next, another important thing is we'll go to the TOF variants. So we discussed about TOF, we discussed about TOF physiologies. Now we go to the TOF variants. So what are the TOF variants? Like ASD with intact septum. So how do you differentiate ASD with intact septum or PFO with intact septum with PS? So PS intact septum with a PFO. which earlier era used to be called as triology of fallow. How do you differentiate this from tetralogy of fallow? It's a very fundamental basic question. So that's why this has been often asked in the exam. This tells you a lot about how do you correlate hemodynamic with clinical findings. A very beautiful example. So there is no VSD. So what will be there? There will be cardiomegaly, there will be heart failure, there will be parasternal heave, JP will be elevated, there will be TR, everything will happen. So how do you differentiate? So you find almost everything is abnormal here. You find a dominant A wave in JVP. If there is failure in TR, you start getting CV waves. You have cardiomegaly. You have a good 3/3 parasternal heave. The S2 depends on the pathology, whereas you start getting RV, S3 and S4. Pulmonary ejection murmur is generally proportional to the severity of the lesion. And it is generally a late peaking murmur. And you start getting TR murmur. So whatever I said, nothing, it becomes everything here. Almost everything is abnormal in this. So pulmonary atresia, so very simple. So 5 to 10% of tetralogy physiology can be pulmonary atresia. Onset of cyanosis is generally in infancy. So in 25% in infancy can have heart failure due to increased pulmonary blood flow. So you have to look for continuous murmur. Generally in adults, if you find a continuous murmur, it's likely to be pulmonary atresia. So RVOT murmur should not be there. You should not have an RVOT murmur because it's pulmonary atresia. You cannot have an RVOT murmur. And other ones like TAF with absent pulmonary valve, presents early with heart failure and mild cyanosis, associated lung abnormalities, and to and fro murmur will be classically found, and then cardiomegaly with prominent PA segment on X-ray will be there. This is a classical X-ray. So some things that will help you in getting out of trouble. So adult tetralogy, some of the series have reported congestive heart failure in 15%, hypertension in 7%, AR in 7%, ECG may show LVH in 0.7%, absence of RBH in 3.4%, QA in lateral leads in 8.8%. So these are all from reference text. So if you find something like this, then you can explain some of them may have this. So you should know this because sometimes you see all of them. So you say, how this is this? So you should know all this, that there are always exceptions. And then another important thing is, why do you get heart failure? When do you get heart failure in tetralogy? All of you collectively will tell all the answers, but one fellow will not tell all the answers. That is the problem in this. In the exam, you have to answer. So what are the common conditions? Because of time, I will quickly go through. So anemia, restrictive VSD, that is Hoffman variant. You can have AR, PR, TR. Then you have infected endocarditis, ventricular dysfunction, surgical shunts, collaterals, rarely arrhythmia, hypertension, and aortic stenosis can all produce. They are all very rarely. So rest of the things are very important, right? So these are the things that you should know. Still, surgical stents and collaterals is important, but most commonly the student starts with collaterals. So collateral is generally the last cause of heart failure in tetralogy. Pieces you should know: right aortic arch, the triology in tetralogy we have seen catch 22. So symptoms associated with tetralogy, why there is most of the things we have discussed, and CCS, which continuous murmur. So these are the various we discussed about this. So what are the causes of continuous murmur in cyanotic conjugal heart disease? So this is what it is. So some of the resources you should read is one of the cardiology clinical methods. As Sir also pointed out, this book is almost we sat together and made all the things that are essential for a current day examination patterns, and we wrote it from all the best, individually contacted all the best teachers around. So this book is fantastic. You should read that. And for adult congenital heart disease, I would suggest you to go through American College of Cardiology guidelines. All of you should read the relevant areas. It's just 3-4 pages you should read. So the indication, the boxes you read, that's good enough. And Raj Tandon textbooks you should need. Mainly that was by Prabhakar and KK. That has a lot of good stuff. And then Raj Tandon bedside diagnosis of CST, all of you should read. So some of the things that I didn't answer, but I would ask you in the exams will be, so why cath and tetralogy, adult tetralogy? What to do if the coronary abnormality is found? What are the results of top corrections? Long-term follow-up of operated issue, how often PR develops and all those things. How do you know sudden cardiac death? Indications of PVR. So very simple to remember, indication of PVR is 160 by 80. If you remember 160 by 80, that is good enough. So what is 160 and what is 80? RE volumes. So if you say 160 by 80, remember it like this, you will remember it for your lifetime. Okay. Then percutaneous versus surgical PVR, when to do, what to do. These are the various management questions that may be asked in your exam. So hope I made it simpler, not more complex. Thank you. I'm okay. Any questions? I know one question that is going to come up, sir. Can you give your slides? How many of you want the slides? You can have the slides. I will leave the slides. You can have it. No problem.
I think it's more the talk behind the slides, sir. Slides will be available. It's the person talking. They all come for the person talking, sir. So in any case, yes, sir, please.
Top patient in V1, T upright and T negative. Does it have any implication?
Sir,
T in top patient, V1 lead, T upright or T inverted. Any meaning is there?
T-wave inversion V1.
V1 lead.
Sir, generally, by and large, it is said that T-wave inversion V1 generally happens when the RV is in trouble. But it may not be true in very early in life. It can be the typical neonatal pattern that can persist also. Maybe, I think.
Stop. The T is inverted and 50% T upright. Mostly adult cases T upright will get.
Will get T-wave. So it is thought that it is part of the early children's the T-wave inversions like.
Like that as RE person not suprasystemic, so he should even upright. So
Yeah, there was one more question.
Sir, yeah, that is another thing. Yeah, it's still relevant, sir. Another thing that I missed is Nakata synthesis and Nakund ratio that I should be aware of. Like when Kath is saying, next discussion will be on that. That is still relevant because PSIs is the paramount in outcomes. Like so, surgeons can do anything with RUT, anything with this. When PSIs is borderline or not good, then they cannot do anything.
Sir, among various TOF physiology, is there any sequence we follow that which one will have more spell and which one will have? Because they ask this question frequently.
More spell and less spell, I think generally spell will be lesser in CCTG, VSDPS and single ventricle PS. Transfusion also. Spell will be less common.
And if we say about DORV and this normal TOF, then which one will be having more, sir?
So it all depends. DORV is not one disease. The problem is DORV, VSDPS, normally related. The common garden DORV, VSDPS will be almost like tetralogy. I don't think much of a difference can be there in terms of amount of spell.
clinically and historically,
You cannot differentiate. You should not try to differentiate also.
ECG, as you told, more of erratic depression, sometimes get counterclockwise deprivation.
One comment.
So one of the questions that has come on the group is there a RV heave necessarily in Eisenmenger versus a patient having a TOF? If there is a patent RVOT, is it that all Eisenmenger, after the pressure equalizes, will there still be a heave? There's some
Eisenmenger, whether there will be a heave?
Yes, sir. Is there a heave? Because the same physiology would it work?
No, there is no heave in Eisenmenger except in pre-tricuspid shunt. So
Yes, sir.
pre-tricuspid ASD Eisenmenger can have a heave, but VSD Eisenmenger or PD Eisenmenger, AP window Eisenmenger will
Sometimes
not have a heave.
Eisenmenger also, you downside totally follow because people loud, so it looks like people out here, no. Sometimes we make wrong diagnosis, Eisenmenger to AST, tetralogy Eisenmenger also. Clinically very difficult to
Only the
differentiate.
pre-tricuspid shunt
Yes.
will.
Yes, pre-tricuspid can.
Tricuspid can.
So Eisenmenger will get a click. Similarly, pulmonary attack may get a click, no murmur. So difficult.
One more Viva question asked is, a paper on adult tetralogy. Dr. K. Abrams,
Is there any paper on adult tetralogy, sir?
Lot of papers, sir. I think from one great paper from CMC Vellore that has, I think, the some of the largest series.
Abraham, sir.
Abrams, sir. That is something that you should read here. There's an adult CST paper, large series is there.
If there are no more questions, we'll have, sir, second talk, which is on hemodynamics. Sir, you wanted to be interactive?
Yeah.
Yeah, please. because this is for you particularly. We have actually pulled back 3 cases for this. If somebody can, all of you can take part in it. Please move around with the mics.
So we are going to the nightmare series. So the word hemodynamics, I think immediately hemodynamics race is thrown at the exams, the student's face comes down. So I think it's nothing. It's again very simple. So this is standard across DM, DNB exams. I don't know why you people are so scared of hemodynamics, because you have never put in effort and time, because you want to put wire and stent. That's all. So I think let us work into a basic scheme of things. How do you approach a trace? How do you approach a data set that is thrown at you? So these are the 2 likelihood possibilities in hemodynamic traces. You will be either shown a data set at you, or you will be thrown a trace. Some waveform, something will be thrown. So you should have a basic approach to that. And unfortunately, in anything, in everything in life, you have to practice. Nothing happens without practice. So you have to sit and look at the traces, and you have to spend time interpreting them, and you have to look at these numbers. And then only you'll, because you are not trained. If you look at it, you are not trained without knowing the diagnosis. You never do a cath. As many of you, I think this presentation I made and worked on it because I really some of my best students who can catheterize any given case. Be it the most complicated anatomy, they will be able to catheterize. But when they are thrown a trace like this, or when they are thrown a number like this, they fumble. That is because you are not trained. So you have to be trained. It's a very simple, basic process. You look at it, you will immediately make it up.
Sir, like trainers are lacking.
Sir,
Trainers are lacking.
Trainers. So what is this? What are the important findings from this?
Can one person take it up, please?
But it will take time. So
Yes, sir. Okay.
Or I will bring out some of the important ones. So the first and foremost thing when you are doing this, you should look at the SVC saturation. The SVC saturation in a cyanotic patient very low. That means overall oxygen extraction too much is being extracted. That means there is low cardiac output at place. So when you are the fresher, ask for help. If you find when you start a cardiac catheterization, when you first sample that is taken is SVC sample. The SVC sample is too dark in a cyanotic patient, immediately call for help. This patient is in trouble. That is the fundamental thing that you should understand. This is not for exam, but that's for your life. A PH patient you are catheterizing, you take out the sample. If the SVC blood looks really bad, dark, immediately call for help. This patient is not to be done by inexperienced people because they are in a very, very low cardiac output state. So there's a step up in RA. So atrial level step up is there. What else is there? So one is A waves are not given. That means patient could be in AF. Already it's written at the top. AF is there. Then what else is there? What is this? You look at the QP versus 7. Still no output in the AF. Already is given, like it's actually a case of severe MR. But actually, if you look at, there is a gradient across LV to wedge. There is a gradient. So this is DSD with MS with MR. So you know the basic calculation. This again nobody answers in the exam. This again is taken very seriously because most of you are now using a common software. That software gives you all the numbers. So you don't know the basic flow calculations and all. If you're asked about all this, you should know. So what is the QPBQS in this? So now you for that, why 3:1? Can you take a mic? So you should know why this kind of a trace is thrown at you is simply that you know all the calculations. You understand what is being done. That is why this kind of a trace is thrown at you in exams. So that means you know the formula for QP, you know the formula for QS, you know how to calculate QP, QS when they are given a data set. So you can take the mic and explain how this is 3:1. So the answer is 3:1. She's right. How this is 3:1?
The saturation of aorta minus RA upon pulmonary vein minus the pulmonary artery saturation.
So QS by QP.
Yes.
So because
30 by 10.
QP by QS ratio, but this is in the denominator, so you put it upside down. So this is how it is like. It's a 3:1. So for this, you should know the formula for QP, you should know the formula for QS, and you know how to calculate this. You understand? Everybody got it? So some of the operability issues. So how do you decide, like, what are the things you look at? What is the first and foremost thing? Is there a base saturation or not? So it is 93. Then look at the step up. We know this is VSD with severe PH. So look at the step up. What is the amount of step up? It is roughly around 10, 12. So look at the step up. Number 2. Number 3, look at the mean pressures. Ideally, aorta should be given, the aortic mean pressure and PA mean pressure, and look at the diastolic pressures. Because other pressures are going to be the same in VSD. The systolic pressure is going to remain the same from aorta and PA. The only thing can differentiate will be the diastolic pressure and the mean pressure. So they are all very bad. The patient is 16-year-old. We give oxygen, and what has happened? What do you look at after oxygen? So you look at the saturation has improved to 98 and the step up has improved to 20. And then what you look at, most important in the pressure is the diastolic pressure. There is a fall from 70 to 50. Whereas this has remained the same. But overall there is a 6 millimeter fall in the mean pressure. So the calculations are given. PVR is 15.8 and oxygen is, on oxygen is 6.4. What do you do? Operate or not operate? So all the back benches will say operate, all the front benches will say don't operate. So because we are all burnt our fingers, we all know, we have the experience. So the important thing is, there is something that is missing in this. What is missing? What we should have calculated that has not been calculated. So we haven't taken dissolved oxygen into consideration. Because you look at the PO2 is 400. So what is the importance of dissolved oxygen in this? So dissolved oxygen generally is an insignificant, inconsequential part of the overall oxygen content carrying blood. But when you are giving so high pressure oxygen, in such a situation, this becomes important. You have to take it into account. So if you instead of using the saturation, you start putting PO2 on the saturation, then immediately the QP becomes 6.8 and the PVRA becomes 10 units. So 16-year-old, 15.8 coming to 10 units, absolutely inoperable. No doubt about it. So don't jump into the conclusion, and some other things that you should know. Based on this, I will introduce some other things that this is very essential that you should all know this. So this is, what is the significant step up? So mean step up or highest step up. What does it mean? Whether you take one sample or whether you take multiple samples and take a mean. So mean is 7 and 5. Very simple to remember. That is 11, 5 and 10. So this I think all of you should be aware of. The step down, how do you define a step down? A step down of greater than 2% happening with an aortic saturation of less than 92%. Is what is the oximetry definition of a right to left shunt. So it's a very complicated problem. Like it's not just about just these numbers or PVRA. So it depends on a lot of other things like anatomy of the defect, associated lesions like lung and airway obstruction, the altitude, the trisomy, the Down syndrome, and all those things. And there are very unknown things, but the most important factor is the age of the patient. The same data I would have operated possibly if the child is 2-year-old. I would have done a patch closure of VSD. I would have put a patch closure or something if the child is say 1.5 years or 2 years, or a fenestrated closure. Because our results are very good, and 1.5 years, if there is cardiomegaly in X-ray, something is there, then we would have taken a chance. But definitely not in a 16-year-old. So the most important factor is the age of the patient. So this is something that you should all be aware of. In this question is asked. So this is, I think, again, I'll send the slides to you so you can distribute it. So this is the various criteria that have been used to say operability. This is what, at least when you're asked the numbers, you should know these criteria. So various vasoreactive agents that are used are oxygen, nitric oxide, a combination, isoprene, adenosine, PGE1, and even IV sildenafil have been used. And this is the response criteria that has been used. But what is repair and treat strategy? So we have accumulated all the data and put it as a review article. So there are very little data. What do you understand by treat and repair? You treat the patient with pulmonary vasodilator and repeat cath and then operate on them. So this strategy, there are very little data and the initial results are actually disappointing. So it's not very encouraging. So what is there? This trace. So aortic saturation is 81. So I've given limited data. PVR is 25.2. So what this patient had was VSD with MS. The patient had VSD with MS. So that is why even with this data also we went ahead and operated. Why I put this slide is, if you have something like significant obstruction, severe MS or severe pulmonary vein stenosis, whatever data you get, whatever PVR you get, they are irrelevant. If the obstruction is severe and that can explain everything, you should go ahead and operate. So this patient actually had a very gratifying results. The PA pressure post-surgery after MBR and VSD closure was 44/15 and 27. So some basic, this will be interactive like. So we start from there. So you can introduce yourself and start this.
Myself, Dr. Nurul Kamal Malik, by the DM resident first year.
What is this?
So there is testing.
Huh?
The first is fine.
Can you be louder?
Yeah.
Say LV to aorta pullback. So what is the diagnosis? Say LV to aorta pullback. What is the diagnosis?
Newly joined in first year. DM.
First year.
Yeah,
Okay. So no problem. You can attempt like. Where is the gradient? What is happening?
Yeah. Suddenly,
So always whenever I think what is the answer? Anybody wants to answer? Next.
Sir, it's a single pressure tracing, which shows we are coming back from a higher pressure to a lower pressure. So it's a left-sided tracing. We're coming back from the LV into the aorta, and there's a gradient, systolic gradient that is there after we have entered into the aorta, which is suggestive of either a coarctation of aorta or a supravalvular AS.
Yeah, that's very, very correct. So what you have to look at is when such a trace is thrown, there are three complexes are identified. One is this group of complexes where this is clearly like an LV trace. There is no confusion in this. This is what it is. This is underlined. You may not be seeing it. This is underlined. So this is like a arterial trace, and this is another arterial trace. There are three sets of traces here. So always whenever a trace like this is given, identify this pattern first. So where is the gradient happening? Is it happening between two ventricular type of traces or between two great artery type of traces? So clearly it's very simple. Once you start approaching like this, all these traces will be nothing. All these pullback traces will be nothing if you start analyzing it like this. So here, one ventricular trace, one aortic trace, and one aortic trace, and there is a gradient between these. So this has to be a supravalvular AS. Why this is not coarctation of aorta? So diastolic pressure. So there is no diastolic gradient. So if it is coarctation of aorta, there will be a diastolic gradient between this and this. And nobody can actually pull it from LV into take a gradient across aorta, practically. That also will not be possible. And another important thing is, so that is the most important thing. So same way, all these traces, it's very simple, and once you start identifying, so it will be very easy for you. So any trace is given, the first answer most of the time is broken Burrow phenomenon. So what you are supposed to look at? So is it there or not? Is it fixed AS? How many of you say this is broken Burrow? How many of you say it's fixed AS? Everybody has to raise their hand. It's a must. So how many think this is broken Burrow phenomenon first, HOCM? No, nota nahi hai isme. Nota is not allowed. How many say this is broken Burrow phenomenon? Nobody. How many say this is fixed AS? So rest of them are nota again. So rest of them will count for HOCM. So what is the basic fundamental thing that you have to understand? Somebody was saying this. You take your mic.
Pulse wave, sir. It is late picking here, sir. In the other one, after the post PVC, there is increase in the gradient, but there is no drop in the pulse pressure. This is a fixed aortic.
Fixed AS. That's right. So this is actually, you look at it here, there is no drop here. That is why this is a fixed aortic stenosis, and this is how it will be if there is a broken Burrow phenomenon. So at your stage, DM stage, we expect you to understand this small little hemodynamic thing. So nothing, everything that is shown is not broken Burrow phenomenon. So now again, you tell me, I told you the fundamental understanding, how do you approach this? Now you approach this and tell me what is this. This is MPA to RV pullback. If you are able to answer this, you understand. But you same philosophy you apply. So what is it? This side, PA trace. What is this? One ventricle type RV type trace. Another one is RV type trace. So gradient is happening between two RV type traces. So where is the obstruction?
Sir, there is
go ahead.
So there is a difference between the, there are two RV cavities. There is a difference at outlet and before. There is a high pressure chamber inlet which is separated from RVOT.
So this is classical inflatable PS. So once you start approaching like this, it becomes very easy and there is no confusion. So this is the pullback. So this is valve PS, how it looks. The valve PS pullback is also given for comparison. This is following a procedure. Acute MR, post
Mitral
stenosis, post BMV. So how do you say that?
So there is a large V wave, sir.
So there's a large V wave. How do you identify a V wave?
It is more than 3 times the A wave.
A wave, yeah. So how do you identify A wave? Very simple. Look at the P wave, and the wave that is coming next is the A wave. So the large wave is the V wave. And there is no gradient, but still there is severe MR. So echo valve area is 0.6. The trace is given. Why this is so?
Yeah, sir, Rennie, sir. Sir, here there is no gradient across the LA and LV, and step up at the RA from SVC is 53, RA is 90. So mitral valve planimetry is 0.6, so suggestive of Luton-Becher syndrome.
That's very correct. Like, so clearly, what are the other situations where you don't find a gradient? So gradient obviously need not be there in all patients, but somebody having a adult patient with 0.6 valve area, you definitely expect a gradient. So you don't find a gradient because the Luton-Becher syndrome is there. ASD is actually shunting left to right. So this is a tough one. So let us see how many of you get it right. So the one in red is the descending aorta. One in pink is the MPA. One in yellow is the LPA.
So branch PA stenosis. There is a ventricularization of PA pressure.
Huh?
There is a ventricularization of PA pressure, MPA pressure. Branch PA stenosis.
Branch PA stenosis. So that's very correct. Like, so it's like a LPA stenosis. But why the trace is like this? What do you call this? So this is known as ventricularization of PA pressure. The PA pressure, PA trace looks like a ventricularized trace. This happens in two conditions. One, PR it can, severe PR, free PR it can be, and then peripheral PS. So these are the two situations. You can have a ventricularized PA pressure. So we'll go to some of your this thing. We already discussed the basic thing that is very clear that we discussed in the last lecture also. So A cyanotic, S2 is widely split. There is a 3/6 ESM at base. So this time, no nota absolutely. Otherwise, you won't be allowed. Without this vote, you won't be allowed to chide now. So this is, how many of you say this is ASD? If you don't say this is not ASD, everybody has to give an alternative answer. So how many of you say ASD? If you don't answer, raise your hand, you have to tell what this is. And why?
It's an acyanotic disease with saturation of femoral artery 98 and step up at RA, significant step up. But the RA and LA pressures are not equal. And there's a connection into the RA with either a restrictive ASD from the LA or
ASD won't produce this amount of step up. So there has to be something in.
So it's a PA-PVC that's draining into the RA.
So understand what he's saying. So it looks like a step up. Clearly a big step up is happening at RA level, significant step up. But you look at RA pressure and look at the pulmonary wedge pressure, and they have not entered LA also. So otherwise they would have entered LA. Somebody is doing a cardiac catheterization. So this was a case of two veins draining into PA-PVC. So we wanted to have a look at the QPQS before we send him for surgery. So that is why the cath was done. So this is not an atrial septal defect because these two are different. Otherwise these two should be the same. Split can be there. This I thought by now they should have got the answer. TAPVC. Supracardiac TAPVC. Likely because SVC is 88. So likely supracardiac TAPVC. Can it be common atrium? Unlikely because SVC is 88. So SVC again cannot be 88. If it is a common atrium, SVC should be 62 or 67 or something like that. So understand why the TAPVC? So everything else is the same, nearly the same. So clinical diagnosis of tetralogy, this is the cath data. Hoffman variant, you can use the mic clip. So why do you say? So ideally, both the pressures in all top like physiologies, both the RV and LV pressure has to be equal. Here there is a significant difference, like 120 versus 90. Okay. So this is. You understand? Everybody understands? The pressures are not equal. Pressures have to be equal. That means the VSD is restrictive. So what you call that VSD, restrictive VSD is Hoffman variant. So suppose when you look at LV pressure more than RV pressure. So that is the only condition that happens is DORV, VSD, PS with restrictive VSD. That is the only condition where LV pressure can be higher than RV pressure in tetralogy like physiologies.
Yeah,
so,
but atrial saturation should
IVS means the RV won't be making so much pressure.
Okay.
It can actually at times a simple pump can produce a lot of pressure, but getting in and measuring that pressure may not be easy and possible.
Okay.
But generally it won't have such a pressure.
Because PA, we didn't get the
And one more thing is there has to be desaturation happening at LA level.
LA level.
So if it is PAIVS, LA should be desaturated and LV cannot be 88 or even.
Okay.
The desaturation has to be happening at LA and LV level maximum. It's basic common sense thinking, logical thinking only. You just have to know the thing and then think through. That's all. For saving time, so I say all the pressures are normal. All the pressures that are given is normal. So sorry. This is not all pressures normal. Yeah. TGA with what? Why do you say this is TGA?
Saturation
Cyanotic?
of PA saturations are more than aortic saturation.
So
And
this is TGA like physiology.
yes, sir.
So intact septum or VSD?
Intact septum.
Why?
The RV pressures and LV pressures are different.
Very different.
Yes.
So if it is a VSD is also there, it has to be a restrictive VSD.
Yes.
So what about ASD?
ASD is there. Sir.
Adequate.
Yes.
So you have to link the pressures and then find out. This is the total diagnosis should be TGA intact septum with an ASD, which is non-restrictive.
RA saturation is 57, isn't it? RA is 57.
Is it?
RA is 57.
Yes, sir.
So if it's adequate size ASD, RA saturation might have gone a little bit up. Your RB 57 RA, RB is 67. Did we expect more saturation RA?
Yes,
Because PA 88. And out is 70, of course.
But I thought the pressures are nearly equal.
Yeah, pressure is equal. Only saturation little. It may be.
Maybe the sample must have been taken higher up in RA.
Catheter there. Down.
Down. Catheter may be somewhere else. So this is one. The pressures are all normal for sake of simplicity. The pressures are all normal. So now identify the condition. So basically what is it? There's a desaturation happening at LA level, pulmonary vein to LA level desaturation. So what are the causes? So these are the various possibilities you should consider. It can be so these are the various possibilities. So pulmonary vein desaturation, somehow the formatting is not coming right. So it can be hyperventilation, so you have to look at PO2, PCO2. The pulmonary, one pulmonary vein you could have taken, the other pulmonary vein lung disease could be there. So the other may be producing pulmonary fistula. For all of this, you have to identify all pulmonary vein desaturations. So that could be one possibility. Or it can be unroof coronary sinus or Epstein's anomaly. So all of them are the typical patterns. So I would end my talk with some practical take-home points. So you should know the basic hemodynamics, normal hemodynamics, what is the normal things at each of the chambers. So what is the normal expected oxygen saturation and normal pressure? What is the normal QP and what is normal QS? This is very simple. So there's nothing much in this. Then you have the normal waveforms you should be able to identify in each of the chambers. So you have to go through in detail and you should be able to identify each of the waveforms, how they appear, and what are the normal values in that. So another important question that I didn't answer is how do you differentiate between LV and RV? Think over it, next question is going to be that. So from trace alone, how do you identify LV versus RV? One at a time, anybody wants to answer?
The absolute levels and the shape of the trace, more importantly, the shape of the trace.
What is the shape of the trace in RV and what is the shape of the trace in LV?
So the upstroke will be much faster in LV and it will be more sustained, so it will form a plateau, whereas in RV it will be a triangular form of a trace. With
So
a
it's a
slower
triangular in
upstroke
RV.
and a less sustained peak.
Less sustained, no sustained peak. Then the low dB by dt. The upstroke also is not that faster. And these are the other differences. So the slide is there, okay. So these are the various differences between RV trace and LV trace. So the upstroke is not rapid, the pressure is triangular in shape. That's the most important thing. There is no sustained peak and there's an early fall. And the pressure falls to zero, which never happens in LV. So these are the various differences between RV and LV trace. So trace, I think if you know all the traces, as I told you, even if a complicated pullback is shown, you just identify the parts and identify the gradient and always compare with your previous, whatever ECG is given, at times just the rhythm could have changed and the hemodynamic could have changed. So all those things are very simple. You just apply your mind, you will be able to make it. So for the pressure data, I made this simplified algorithm. So this is very simple. So just 4 steps. Just do these 4 steps. So whether the particular pressure that is given is normal or abnormal, is the pH, PVH, whatever it is there, identify that. Next, link the pressure next in line. So what I mean by that is, so this pressure, that the RA mean pressure is linked to the RV end diastolic pressure. In body also, in reality also. Same way, the RV systolic pressure should be the same as PA systolic pressure. And PA diastolic pressure should be linked to the wedge mean pressure. And the wedge mean pressure is directly linked to the LV EDP. And LV systolic pressure is linked to aortic pressure. So immediately mentally you start linking, immediately the gradients will सामने आ जाएगा. Clear? So immediately go through. First and foremost thing, is it normal or abnormal? Then next step is whether it is next in line, is there a gradient or not? Just go through 1 to 1. If you practice it, it just takes 2 seconds. And is there a gradient that is significant or not? And always compare LA versus RA versus LA or wedge. They should be same or different if there is a large VSD. And same thing is true for RV versus LV. So if you do these 4 steps methodically, you should be able to crack any numbers that are thrown at you. So for this, you should know some basic things about gradients also. So what is a significant gradient? This is the significant gradient slide. So at pulmonary artery and aortic level, it is 25. At peripheral PS and like great vessel level, it is 20. And at tricuspid valve level, it is 1.9 peak the end diastolic gradient, mean of 5. Whereas mitral, any end diastolic gradient and mean of 5 is significant. So this is all by hemodynamics data. This is what is significant. And then you should know some basic amounts about the classification of pH. In children, how do you classify? How do you differentiate this? I think everybody knows. But pH classification, some of you may not know. So especially in children, you should know this. And shunt lesion. So this we already discussed. I've shown this. So then the important thing is once you find a shunt at the thing. So what are the causes of shunt at that level? For example, what are the causes of step up at the atrial level? ASD is very simple. Everybody knows. PFAC immediately comes to your mind. So what are other conditions that can produce a step up? So remember one thing. One chamber above and one chamber below can contribute to your step up. And coronary fistula and RSOB can happen to any chamber. So then your list will be complete. If you think like this, your list is complete. So what are the common causes? So ASD and PAPVC. So ASD, PAPVC, LV to RA shunt, BSD with TR, RSOB to RA, coronary fistula to RA. This is a complete list. I don't think anything else is there where there's a step up, significant step up happening in RA. And what are the causes of step up at the ventricular level? A BSD or a low ASD or a PDA with PR or an RSOB to RV, AVSD and coronary fistula to RV, sorry, this is RV. So step up at the great vessel level, PDA, AP window, outlet VSD, coronary origin from PA at times can produce left to right shunt, RSOB and coronary caval fistula. So what are the causes of right to left shunt? So pulmonary vein desaturation, we discussed about this. And then desaturation at the LA level, lot of causes. So you can have Epstein's anomaly, tricuspid atresia, severe PS with TR, unroofed coronary sinus and common atrium-like picture. Desaturation at LV and aortic level is Staff and Eisenmenger. And desaturation at the descending aorta level, so Eisenmenger PDA with interruption. So again, stepwise approach to this oximetry. First and foremost, first oximetry, look at the FA, whether patient is cyanotic or acyanotic. So that clarifies a lot of things, first and foremost. So second, if this is cyanotic, identify the physiology. So what are the three possibilities? Admixture, TGA. If they are not there, definitely there has to be a step down. So look for step down. So with this step, if it's a acyanotic annular disease, look for a step up. So this is all you have to look at in the oximetry numbers. Keep the life very simple. And in the pressure data, as I told you, very simple, 4 things: normal or abnormal, link pressures next in line and identify the gradients, and then always connect RA to LA and RV to LV. So with this, you can crack any trace thrown at you without much difficulty. But do a bit more practice. So practice makes everybody perfect. So keep practicing this. And friends, and most importantly, once you got the knack of it, catch hold of 10 juniors and teach them. Like I am doing. So, okay. So, thank you. Any questions?
Ramakrishna, can you tell? The students are confused about hangout interval.
Hangout interval. So anybody wants to answer what is a hangout interval? What is hangout interval?
Hangout interval is the difference between the actual pressure crossover and the closure of the valve. It is depend on the impedance of the great vessels. It is more in the pulmonary vessel compared to the aortic vessel.
Have you understood what he said? Anybody wants to improvise? Make it clearer, make it more simpler?
Sir, hangout interval is the delay in cerebellar valve closure following the crossover in the great arteries of the pressure. To the actual anatomical case, there is an actual delay in the cerebellar valve closure.
I had one of the slides. You can have a look at that. That's what, actually, that's what we wanted to answer.
If there are no more questions, we just break for tea. ASAP, we have to come back. And we'll have 3 more cases after this. We'll try to squeeze in 20 minutes. So Jivitesh, sorry for that. We'll have your cyanotic and then we have 2 more. Thank you. I actually wanted to keep the cyanotic, in line with this, but I thought the traces was a great lecture. Thank you so much, sir. Thank you from all of us because we learned a lot. Thank you so much. We still have 1 session. Please join us after the tea. Thanks. Can we make a small announcement outside that we are ready for the next session? So people start coming in. Sir, no, nobody's left. Sir. Many are still around. 80% are still around. Dr. Dilai wants to leave for Cochin, sir. He's from Lizzie. I thought we'll give him, then we'll have Jivitesh's too. Because he's from Jaidabad. Dilai is around? You're around. The patient is Subrat Kumar, right? Can we have you here so that we can start with the next case? Jivitesh, since he needs to fly to Kochi, if you don't mind, we'll take second. Sir? Yes, sir. Ramakrishnan sir is left. Sir, he's here. Sir is here. But I think he'll be leaving soon, sir. Can I have Prabhavati ma'am, Das sir and CP Patil? Sir, we are recording the event, that's why. Yeah, because people who could not attend, sir, we are actually recording it and we can make it available to. Can I ask Barwa sir, ma'am, and CV Patel sir to start, please? Please, sir. Can we have the, okay, the patient is here. We'll try to abbreviate it to whatever 20 minutes, 25 minutes if we can, please, okay? We'll try to finish all three cases. All three are very interesting cases, so please let's try to finish all three.
Good evening, everyone, respected teachers and my dear friends. My patient is Mr. Subrat Kumar. He is a 39-year-old gentleman from Odisha. I'll briefly summarize the history, sir. With a history of tuberculous pericardial effusion 15 years back, that was when he was 24 years of age. Okay, sir. Okay, sir. Yes, sir. My patient is a 39-year-old gentleman from Odisha. He had a history of tuberculous pericardial effusion 15 years back when he was 24 years of age. He took complete course of anti-tuberculous therapy, following which he remained as asymptomatic till 2014 when he developed an episode of generalized edema, which subsided with oral diuretics. Tuberculous pericardial effusion. Tuberculous pericardial effusion. Yes. That was in 2007, 15 years back, sir.
15 years.
Yes, sir. Following that, he was asymptomatic. Then in 2014, he had an episode of generalized swelling of face, abdomen, and lower.
Treatment at that time.
Sir?
Taken full treatment.
Yes, sir. He completed. He took complete course of ATT. Following that, he was asymptomatic. Then in 2014, he had an episode of generalized swelling of the face, abdomen, and lower limb, for which he consulted a general physician and he took oral diuretics, following which his symptoms subsided. That was in 2014. That was for 1 month. He took treatment.
Since 2014, he having swelling.
He had an episode of swelling in 2014.
One episode.
One episode, yes, sir. He took oral diuretics. Following that, his symptoms subsided. Then he was asymptomatic till 2 years back during COVID pandemic. While checking his pulse saturation using a pulse oximeter, incidentally they found to have his high pulse rate. So he consulted a general practitioner and he was started on beta blockers. He did not undergo any cardiac evaluation. That was 2 years back.
High pulse rate.
Sir?
High pulse rate, you said, no?
Yes, sir.
Was it a palpitations he had?
He did not have any symptoms at that time.
History should be in the form of a patient's, whatever is telling you.
So it was an incidental detection.
Pulse, he can't tell, no?
He used the oximeter.
Pulse oximeter.
Yes, sir.
He used and he told.
Yes, sir. It was during the COVID pandemic. So everyone was using this pulse oximeter. He used it to check his saturation. That time they found that his pulse rate was high. So he consulted a general practitioner.
How much it was high?
It was around no? He told it was around 140, 150.
140.
140, yes, sir. Following which he consulted a general practitioner and he was started on oral beta blockers. Then 1 month later, he developed generalized swelling of face, abdomen, and lower limb. This time he consulted a general physician and he was referred to a higher center for further cardiac evaluation, and he was evaluated with echo, transthoracic echocardiogram, transesophageal echocardiogram, and cardiac CT scan. That time there was no history of dyspnea, history suggestive of paroxysmal nocturnal dyspnea, no palpitation, no chest pain, or history of syncope. Then during that admission, he also received one episode of electric cardioversion, following which he took oral vitamin K anticoagulant for 1 month. Electrical cardioversion.
For what?
He just told that he is not aware for what, but he told that he received one disease shot.
Yes, you told me you are asymptomatic, is it? You are asymptomatic.
Sir?
Only swelling there, no asymptomatic, no breathlessness, no palpitation, no.
He didn't have palpitation during that time, but following that, he has since last 2 months occasional palpitation, which was rapid onset and offset, which was not associated with exertion and relieves with by itself.
How many episodes in
He
these
does not
2
remember
months?
how many the frequency and the episodes, sir. It lasts only it was very rare. It lasts only for less than 5 minutes.
Less than 5 minutes.
Yes, sir. Otherwise, no history of dyspnea, dyspnea on exertion.
Was it a regular or irregular
So
palpitation?
it was irregular, fast, rapid
Irregular.
onset and offset, not associated with any exertion.
No syncope at that
No
time?
syncope, no, sir.
Any chest pain?
No, sir. No history of chest pain, syncope, dyspnea on exertion, PND, or syncope. Yes. Since then, he's on. Since then, he's on combination of diuretics, loop diuretics, and spironolactone, digoxin, and Novak. Currently, he's admitted for surgical procedure, and he right now he's asymptomatic.
Any other comorbidities?
There is no history of CVA, no history of diabetes, hypertension. He not a significant past history. On examination,
No. So just tell us what do you think it is?
so with this history, giving he has a past history of tuberculous pericardial effusion and history suggestive of 2 episodes of systemic venous congestion. The most likely diagnosis will be a constrictive physiology. The other possibilities, since he has a history of palpitation and he was cardioverted, another possibility will be a restrictive cardiomyopathy, because atrial tachyarrhythmias are rare in constrictive physiology, though it may be seen. Then the other possibility can be
What rare? What is rare?
Sir,
What is rare in constitutional physiology? People what rare?
He said
atrial
arrhythmias.
Rare in constitutional physiology.
I didn't get you, sir.
Why it is rare in constitutional physiology? What are the atrial tachyarrhythmia? How do you know atrial tachyarrhythmia?
Tachyarrhythmia, sir. Sorry, sir.
Tachyarrhythmia.
Yes, sir. Because pulse rate was high and he had fast heart rate. He had complaints of palpitation.
What is the incidence of atrial fibrillation in constitutional pericarditis?
I am not aware of the statistics, sir, but it is seen in constrictive pericarditis as well, sir.
Why it is uncommon? It is common, no? One of the causes of atrial fibrillation is constitutional pericarditis.
Yes.
I was saying it is uncommon on rare. What is the indication of atrial fibrillation and in cardiovascular atrial fibrillation in constitutional pericarditis?
If the LA size is normal, we can try cardioversion. Otherwise,
Constitutional pericarditis. Constitutional mechanical cause there, no?
Yes,
Mechanical cause for atrial fibrillation there.
Yes.
Why do cardiovert?
If there is any LV dysfunction, then we can attempt a cardioversion. If there is any LV dysfunction, we can attempt a
LV
cardioversion.
dysfunction.
Yes, sir. Because tachyarrhythmia.
How do you know LV dysfunction in the presence of atrial fibrillation fast ventricular rate? How do you know that?
The patient will have left heart symptoms, like in the form of dyspnea on exertion or PND. But
So tell me indication of cardiovascular in atrial fibrillation. Tell me.
yeah, okay. First one will be non-valvular, non-valvular cause of atrial fibrillation with LV
Okay.
dysfunction. That is the most important cause. We have to cardiovert in such kind of patients, sir. Then those refractory to medical management.
Hemodynamic?
Hemodynamically unstable patient. Hemodynamically unstable patient. AF with hypotension. We have to cardiovert.
Okay. Any other conditions you have to do? Mostly you require cardiovascular atrial fibrillation, cardiovascular.
Sir,
Any other conditions? I mean, atrial fibrillation in any other indication? I mean, cardiovascular
other
atrial
indications.
fibrillation. case of atrial fibrillation, not related to pericarditis.
Non-valvular cause of atrial fibrillation, we get cardiovascular. Yes, sir. Yes, sir.
Which one is it? First one?
And I would also like to consider a possibility of isolated tricuspid valve disease. The cause is atrial fibrillation and systemic venous congestion. But since he has a past history of tuberculous pericardial effusion, very likely to be a constrictive pericarditis post tuberculosis.
Isolated tricuspid disease.
Tricuspid valve disease.
What is the etiology?
Likely a carcinoid syndrome, because isolated tricuspid valve disease due to rheumatic heart disease is very unlikely without the left heart.
Carcinoid syndrome.
Carcinoid syndrome, yes.
What are the causes for right heart failure?
Right heart failure, the most common cause is secondary to left heart failure. Then it could be secondary to pulmonary arterial hypertension. Then shunt lesions, pre-tricuspid or post-tricuspid. Then restrictive cardiomyopathy and constrictive pericarditis.
You know what the term ARVC?
Yes, arrhythmogenic right ventricular cardiomyopathy. Yes.
And absence?
Epstein's also. Arrhythmogenic cardiomyopathy.
Arrhythmic cardiomyopathy. Why?
Because it can involve the left
using RV.
It can involve the left ventricle also, sir.
Which is common.
Right side is more common, sir.
Right side is more, or biventricular is more common.
Biventricular, then right and left.
EMF.
Yes, sir. Right. Coastal areas of Kerala, sir. Coastal areas of Kerala, yes, sir.
Why it's common in Kerala?
There is a hypothesis that there is the coastal areas are rich in this heavy metal, so that could be the cause for this RVM.
To wake others up, I'll tell you the story.
Okay.
Lord Parshuram, no? He went to Kerala and threw his axe. His axe is an atomic weapon.
Yes.
So the sands of the Kerala beach are full of thorium.
Yes, sir.
And so he started eating. Then the Keralites went to Gulf. They converted all their tapioca into beef. So now they have got coronary artery disease, they don't have.
Yes, sir. Yes, sir. Yes, sir. So on examination, he is conscious, oriented, comfortable, not dyspneic or orthotic at rest. He is average build. Height is okay, sir. Yes, sir. His height is 167 centimeters. Weight is 63 kilogram. BMI of 22 kg per meter square. There is no musculoskeletal abnormalities. There is bilateral pedal edema, symmetrical, non-tender, up to the ankle. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy. His pulse is 80 per minute, irregular, with varying volume, predominantly normal. All the with normal character, vessel wall are not palpable. All the peripheral pulses are well felt. Pulse apex deficit is 5 beats per minute. BP is right upper limb is 90 by 60 millimeters of mercury in supine position. Lower limb systolic BP by palpatory is 100 millimeters of mercury. Respiratory rate is 14 breaths per minute. Abdominal thoracic. He is afebrile by touch. Saturation is 97 degrees, 97% in room air. JVP is elevated. It is elevated up to the angle of mandible with absent A wave, absent A and Y X descent is absent. Y V wave is normal with rapid Y descent. The respiratory variation could not be appreciated because the JVP was elevated up to the angle of mandible. Cardiovascular on inspection and palpation, the trachea central precordium is normal, chest is symmetrical. Apex beat is localized to left fifth intercostal space in 1 centimeter to mid clavicular line, normal character. There is no palpable heart sounds, no thrill, no left parasternal heave, no epigastric pulsations, no palpable, no visible pulsations in second left intercostal space. In percussion, the left heart border corresponds to the apex, right heart border is retrosternal. Liver dullness is felt in right 6 intercostal space.
What?
Liver dullness is percussed in the right 6 intercostal space. Second left intercostal space is that is resonant. In auscultation,
No, right heart border, what? Right heart border?
right heart border is retrosternal.
No enlargement, right?
No cardiomegaly.
Okay.
In auscultation, S1 is normal, S2 is normal with normal phasic split. No S3, no S4.
S2 normal.
S2 normal with normal phasic split.
Normal?
Phasic split. Inspiratory increasing S2. No S3, S4. There is no pericardial rub or pericardial knock. There is no other murmurs. Other systemic examination, the GI system, there is hepatomegaly 2 centimeters below the right costal margin, firm, non-tender, non-pulsatile. The other systems are normal.
No additional sound?
No additional sounds, no pericardial rub or no. I looked for specifically for pericardial rub and pericardial knock, but I could not get, sir.
No ascites, nothing. No ascites?
There is no free fluid.
Okay.
So my diagnosis is acquired heart disease.
You said the cardia is normal except the JVP.
Except the JVP, the pulse and the JVP. Otherwise, there is no other
No,
significant.
pedal edema there. Pedal edema.
Pedal edema,
Yes, sir.
And irregular.
Yes, sir. So my diagnosis is acquired heart disease, constrictive physiology, most likely a constrictive pericarditis sequelae to tuberculosis, pericardial tuberculosis. No pulmonary venous hypertension, no pulmonary arterial hypertension. NYHA class 1 in congestive cardiac failure, in atrial fibrillation with controlled ventricular rate, no evidence of infective endocarditis.
What constriction physiology you have told, except the JVP is raised, and I think edema you have just told. Apart from that, anything, nothing
No, sir, nothing else.
suggestive of constrictive physiology.
Because based on, I made the conclusion, I came to the conclusion based mainly on the history, and then the physical findings are not much contributory, but they are also suggestive of a constrictive physiology, because the heart is, there is no, usually in constrictive pericarditis, we do not get any murmurs or additional heart sounds.
What is broadband sign? Broadband sign.
Broadband sign.
I'm not sure.
Are you getting systolic drawing? Any?
Sir?
On the back, did you look carefully? On the back, that's what sir is
Okay, sir.
asking.
I did
And the
not check.
apex, did you look carefully? Is there any retraction?
No,
These are all
sir.
the things you should look. Of course, you said no pericardial knock.
Yes, sir.
And second sound,
Normal.
Second sound was normal.
Second sound normal means our John said no. 90% of cases heart is normal. Second sound normal means heart is normal.
Here the history is a bit clear. He has definitely had a pericardial aspiration. I mean pericardial.
Aspiration there?
No, it's
No,
not
aspiration was not done.
done, is it?
Not done.
Not done. So, in such cases in the exam, it is better not to say constrictive physiology directly.
yes.
Because you know very well that to differentiate between restrictive and constrictive by CAT or by anything is almost impossible. So generally, when you are giving a differential, when you are giving a diagnosis, better to state that it is restrictive physiology. It may not be. Constrictive pericarditis is one form of restrictive physiology.
Okay.
So to say constrictive physiology and chronic constrictive pericarditis will set the notion that examiners may think that you know the diagnosis or something like that. So better to be a little, just like saying pulmonary arterial hypertension.
Okay,
You
sir.
don't have to say Eisenmenger's straight. So use the word, don't use the word, and then as sir said, there's really the evidences of constriction at the moment are very less.
Only thing that only has got only atrial fibrillation there. That's all. Only atrial fibrillation.
Yes,
What about superior mediastinal syndrome? Superior mediastinal syndrome.
and low nitrifiltration maybe.
Usually they will have facial congestion and Engorg's veins.
Engorg's?
Engorg's veins already face and facial congestion. He doesn't have that.
So there is no feature suggest of obstruction of respiratory cava.
No, sir.
But so now discuss now, Asha, so no cardiomegaly, no significant cardiac events. Auscultation telling the patient has heart failure. Is he in heart failure or not?
He's in heart failure, congestive heart failure.
So no cardiomegaly, no much cardiac events. The restricted, it is restricted physiology. So we want to discuss restricted cardiomyopathy versus constricted pericarditis.
What is Kussmaul sign?
Kussmaul signs is normally during inspiration there is fall in JVP, but in constrictive pericarditis or
No, not like Kussmaul sign is.
Kussmaul sign is in paradoxical increase in JVP during inspiration.
No, there is no drop. There is no drop or no
increase in JVP during inspiration.
Absence of fall.
Absence of- okay.
What are the constricted Kussmaul sign? What are the conditions, clinical conditions?
Causes, sir.
Where will you get Kussmaul sign?
Okay. In constrictive pericarditis, cardiac tamponade.
Cardiac tamponade, okay. Cardiac tamponade.
Then
Cardiac tamponade you get Kussmaul sign.
Why you don't get Kussmaul in cardiac tamponade?
No, he already told cardiac tamponade. They get tamponade in Kussmaul sign.
Tamponade we don't get.
Why not?
No, you told me why you don't get.
Because in cardiac tamponade, during inspiration there is fall in the intrathoracic pressure and the intrapericardial pressure. So
why not here? Same thing. Integral pressure is here. Here is the integral pressure also. It no integral space, of course.
the RVs collapsed. So RVs collapsed. So there.
Anyway, you can answer. Kussmaul is absent in cardiac tamponade.
Yes. Good.
Sir.
Where is the answer there?
See, pericardial space is there. That is potential space is there. Here there is no space. So intrathoracic pressure is transmitted to interpericardial space. And so drop in RE pressure, so blood comes in. Inspirate drop occurs. Here there is no potential space. Both pericardia that are glued together, added together, there is no interpericardial space. So Kussmaul is not a sign of
Cardiac tamponade.
Tamponade.
if I will get, we can get effusive constrictive pericarditis, you may get. Effusive constrictive pericarditis, you may get. Or pericardial tamponade won't get Kussmaul sign. Any other conditions will get Kussmaul?
RV infarction. RV infarction.
Good. Then acute RV failure, RV pulmonary embolism.
Yes.
And then what else?
COPD. Bronchial asthma, acute exacerbation.
No. No, tracheostomy disease, TS, tracheostomy and RA mixed supposing is uploading or trachea opening, you may get it. Any other conditions? Are you severe RV heart failure?
Any RV?
RV heart failure. So Starling law doesn't work there. Understand?
Yes, sir.
Huh? So these are considered a Kussmaul sign.
Okay.
Fine. Then, sir, what?
Feel good?
Supposing the person has got no history like that, what diagnose you are doing? No history of pericardial, tuberculous pericarditis or no history.
I didn't get this.
No history of tuberculous pericarditis.
Yes, sir. So,
How do you differentiate constrictive pericarditis from restrictive cardiomyopathy? Tell us.
in restrictive cardiomyopathy, restrictive cardiomyopathy, they may have associated left heart syndrome, whereas associated left heart syndrome, whereas in restrictive cardiomyopathy, they usually present with
Associated left heart syndrome means what?
features of left heart failure. symptoms, sorry sir, left heart symptoms. They may have dyspnea on exertion, PND or orthopnea, and usually they may present with arrhythmias
He has cardiac no?
and conduction defects.
Auscultation, physical finding, what do you get? Physical findings. You suspect it is not constricted, it is restrictive cardiomyopathy.
There will be cardiomegaly and restrictive cardiomyopathy.
Usually may not.
RVL
Restrictive heart is no may not cardiomyopathy. Usually not.
RVL large. Then
Irrigation and murmurs. MRTR, irrigation and murmurs.
There will be
evidence of pH.
Yes sir, pH will be there.
Additional
Additional sound. The early RVS you may get.
And RVR is the deficiency.
You can get S4 also.
Yes, yes sir.
You may get S4 also. And ECG? From ECG, how to say it is restriction versus constriction?
ECG restrictive, you will have, there will be low voltage, low voltage.
Okay.
ECG.
Low voltage can get also cystic cardiomyopathy sometimes you get.
Then conduction defects.
Yes. You get RBB or any other conduction defect goes in favor. And bilateral enlargement is a feature of what? Bilateral enlargement.
Bilateral enlargement is a feature of restrictive cardiomyopathy.
And what is it? Okay, go ahead.
Bilateral enlargement suggestive of
Restrictive cardiomyopathy. Yes, sir. Yes, sir. A 12-lead ECG with normal standardization, atrial fibrillation with controlled ventricular rate, with heart rate of around.
It is normal voltage or low voltage complex?
Low voltage complex if the QRS is less than 2 large squares.
No, low voltage or normal voltage?
This is normal voltage, sir.
Normal voltage?
Yes, sir. In the chest leads, the QRS complex are more than 2 large squares.
No, it is less than 5, almost 5 only, no? Less than 2?
In chest leads, it will be less than 2 large boxes. In chest, less than 2 large boxes. Also,
Less than?
10 millimeters, less than 10 millimeters in chest leads and less than 5 millimeters in the lead leads.
That's better.
Yes, sir.
It's 7. It's 7 and 5. Low voltage complex.
Low voltage.
Okay, then
Normal axis, then
what is the low voltage complex and constrictive? Right?
if there is associated effusion,
What is the low voltage complex?
associated effusion, effusive constrictive pericarditis can go low.
No, without diffusion, without diffusion.
I don't know, sir.
Right? Without diffusion, constriction that all the thick, inert material.
Calcific pericardium.
They are inert material.
Okay, sir.
They can conduct electricity.
Okay, sir.
Any other condition is low voltage complex besides constriction?
Pericardial effusion.
What other conditions can low voltage complex?
Pericardial effusion.
Then?
And then restrictive cardiomyopathy.
Restrictive cardiomyopathy, what type? Which variety? What the cause of restrictive cardiomyopathy?
Infiltrative
Amyloidosis. Then?
Obesity.
You should go just like
COPD, obesity.
Obesity. Any other condition in endocrine disease?
Hypothyroidism. Hypothyroidism.
You should tell it is.
Go states.
But
Sir, you questions of Mike?
Yeah. Any low output states, they can have a low voltage, okay? Heart failure, severe, low ejection fraction, they can have a low voltage.
okay, sir.
Yeah.
What abnormalities you look for?
I'll look for pericardial calcification.
How
And
do you look for calcification?
this is an X-ray PView with adequate exposure but slightly rotated, so the cardiac size cannot be commented.
The cardiac size cannot be commented because it's a rotated film. Calcification, then we'll look at the left border below the main pulmonary artery segment, lateral view, sir. Posterior aspect.
AV group. And over the right ventricle? No? Oh. Fine. So what do you tell us? What is this?
The left heart body, the aortic knuckle is normal. The main pulmonary artery cannot be commented because rotated filling. The left heart border also cannot be commented. The otherwise,
No, to me, I think it is a emphysematous chest and corporeal and GAP raised because of corporeal. Chest is emphysematous, the COPD, corporeal and GAP raised because of corporeal.
the lung fields does not appear emphysematous, sir.
Huh?
Lung fields doesn't appear emphysematous.
Oh, it looks like emphysematous, low. It looks like, no. Intercostal, space is all more or less horizontal. Both lung fields are.
Carinal angle,
There is
left
broadly
bronchus.
widening of the carina angle, but since it is a rotated film,
Very rotated film. Very symmetrical. Very much symmetrical.
Left
Okay, go to lateral.
dilated.
Take a lateral X-ray.
So the fluoro is
Huh?
fluoro is there. Cath was done. Fluoro is there.
Fluoro is there, huh?
That is there.
Is there no calcium? Is there any calcium? You don't see calcium. So I have got doubt about the constricted pericarditis.
Yes.
So what is your next step?
I would like to do a CT scan. That will give a better picture. We can identify the calcification and the thickness of the pericardium.
Huh?
Can identify the calcification as well as the thickness of the pericardium. So CT will give a
You don't want to take.
echo. Okay, echo. Since CT was there, that's why I got confused.
You don't want to do echo?
I have to do echo, sir. Because I have to differentiate.
If you do echo, you will get 1,500 rupees. If you can manage, you take the money. Next time.
Yes. I have to differentiate between restrictive and non-constrictive, so definitely I'll go for echo, sir.
Of course, you'll get commission, of course, for CT scan. What are the points you look for in a CT scan? What are the findings?
Yeah.
Calcification can be seen on the right side, sir.
Can you get the constrictive pericarditis?
Can it happen without pericardial thickening?
You get constrictive pericarditis without pericardial.
Yes, sir.
Possible? Any report there, any study there, any series there? Proven case constrictive pericarditis or pericard thickness is not there. Not, there is no abnormal thickness.
Yes. Right.
Okay.
The Mayo Clinic series they have done.
Here,
Calcification can be seen on the right side.
And pericardium was thickened also, pericardium.
Thickening.
There is no CT scan available, then echo wise what to do?
Echo, first thing is I have to differentiate whether it's a constrictive or a restrictive physiology. So look at the biotal enhancement.
You tell most two important findings of suggestive constrictive pericarditis. Two important findings.
Pericardial thickening may be seen or it may not be seen in echocardiography. Pericardial thickening may be seen or may not be seen in echocardiography. The other important thing is annulus reversus. Annulus reversus.
What is that?
What is annulus?
The E prime velocity of the lateral E prime velocity is less than the medial E prime velocity in annulus reversus. Normally, lateral E prime is more than septal E prime.
So in this case, actually, all students know. You just take for a case. You just know. You remember this. The differential findings between constriction versus restriction. Echo, MRI, CT. Very important.
Septal bouncing there will be exacerbated interventral dependence that will be seen in echocardiography as septal bouncing.
Other find.
Then hepatic vein systolic mitral inflow velocity.
You just one by one tell the echo findings of constrictive pericarditis. One by one. Put septal bounce you out. Then what else? Pericardial thickening look for.
Yes, sir.
Then third.
Then hepatic vein flow reversal, systolic flow reversal. Then annulus reversus. Hepatic vein flow, systolic flow reversal.
Inspiratory or expiratory? Expiratory or inspiratory?
Expiratory.
Systolic or
Systolic. Diastolic, man. Diastolic flow reversal. I think it's systolic.
I think it's systolic flow reversal.
TR, okay.
IVC will show what? IVC. Not specific. Oh, you told.
Very good.
Now, what is traffic jam sign? You know, there's a lot of smoke in there. It's not specific for constrictive. It can occur in restrictive cardiomyopathy. IVC is dilated. You can see it yourself. There'll be a lot of smoke. But what is important in the smoke is it will come up to the tricuspid valve and stop because the RV restricts. Then when the tricuspid valve opens, the filling occurs in early diastole. So it will move forward. Again, it will stop like Bangalore traffic. So it is this is the traffic jam sign.
Planned after echo CT, I would also like to do a CAT study, though it may not help in diagnosis, just for academic purpose. But it won't help in diagnosis, sir.
What the indication of CAT in constrictive pericarditis?
If patient has
what the indication of during CAT study in constrictive pericarditis?
If there is
imaging it. Either MR, echo or something give you definite answer. What do you CAT study?
If there is a systolic RV systolic hypertension, then
no, what the indicator? No indication, I don't think.
Then,
so tell me the very important, very specific and almost 100% specific sensitivity to diagnose constrictive pericarditis from CAT data.
Systolic area index. Systolic area index more than 1.1 is specific for constrictive pericarditis.
Is there anything like transient?
What is transient or temporary or pericarditis, constrictive pericarditis? Transient pericarditis, constrictive pericarditis, don't know.
If you find normal pressure, you're sure it's constrictive pericarditis, but the CAT is not showing elevated pressures. What do you do? Can you do something and bring out that pressures?
Saline push.
So rapid infusion of saline.
One data infusion in 10 minutes. That's what it is.
Yes.
And can I just summarize it in a minute? How is it?
I think, except for the, of course, science, lack of science, very difficult to tell, but as Sir said, you have to tell that it's more of a restrictive physiology rather than directly telling that it's a constriction. Audible? Rather than telling a constriction directly. Okay? I think otherwise, whatever you have told, okay, but you have to substantiate with all the facts.
Yes.
You're done then.
Thank you, ma'am. Just to end the case, we had done a cath on him. Just to tell you the tracing, the RA was 20 mean, RV was 21, 87 by 21. RVDP was 57 by 21, sir. Then the EDP was again 22, PA mean was 22, and LVDP was 21. So it was fitting in CP. There was a cath study done, but I think we're short of time. We'll go to the next case. Jivitesh, yeah. 25 minutes if possible. Can I have Prabhavati ma'am, sir, and Bachandra sir, please? Ma'am suggested his name, said give him the toughest case that you have. So we gave him the toughest case of the day. Ma'am suggested his name, sir, and she said give him the toughest case of this whole speed. I'm just joking. Sir, the only thing is it's being recorded. No, I mean the questions get recorded. For those who didn't attend.
But when you are talking, the recording, no? Yes. Hot button, please.
So should I just summarize the history or full history or just summary of it?
Ma'am, is it okay, sir? Okay, to summarize the settings.
Yes, summarize the history or
the history. Yeah.
Good afternoon, sir. Sir, my patient is a 27-year-old female belonging to lower socioeconomic status, studied till around 8th standard, working as a manual laborer till the last 2 to 3 years. She's had a history suggestive of congenital heart disease since the age of around 2 to 3 years. At the age of around 2 to 3 years, she had an episode of LRTI for which she was taken to the hospital where the doctor, she belongs to Jharkhand, so she was taken over there to a local doctor who diagnosed her to have a congenital heart disease in the form of probably a hole according to what she's saying. And he told her that she does not require any intervention at this moment. And
you see, you are giving summary, in a concise way.
Okay, just the.
This is 8-year child.
2 to 3-year-old child at the time of diagnosis. Now she's a 27-year-old female.
27 female. The diagnosis of heart disease, hole in heart at the age of 2 to 3 years. That's fine.
At the age of 2 to 3 years. After that, sir, during her entire childhood, there was no significant symptoms which pointed towards any hemodynamically significant left to right shunt or any decreased pulmonary blood flow.
Asymptomatic.
She was asymptomatic. There was no evidence of that congenital heart disease.
On the routine examination, the diagnosis of hole in heart, but patient asymptomatic till what date? Till
asymptomatic till the last 2 to 3 years.
So mention that things.
So now 2 to 3 years back, sir, she's developed a complaint of progressive dyspnea on exertion, fatigue, and exercise intolerance of NYHA grade 2, which has progressed to NYHA grade 3. She also has associated exertion.
Grade or class?
NYHA grade, class 2, class 3 class.
What are the component of NIH?
NYHA, sir.
Components.
Sir, the symptoms that are included are fatigue, dyspnea, chest pain, and palpitations. And it's associated with exertional non-arrhythmic palpitations. This is her primary complaint since the last 2 to 3 years.
Why do you say non-arrhythmic palpitation? Why non-arrhythmic palpitation?
So these are non-exertional palpitations. These are exertional palpitations that increase on exertion, and after rest they gradually come down. There is no sudden increase, sudden onset, or sudden termination of the episode. There is no significant diuresis or syncope associated with the episodes.
Okay. So what can you do? It is what? Non-arrhythmic means what?
Sorry, sir?
Non-arrhythmic means because of sinus tachycardia or volume overload?
Can be a volume overload state, can be associated with heart failure symptoms.
Well?
Can be a volume overload state, sir. Probably exertional palpitations.
Okay.
Sir, my differentials at the end of the history. This is the brief summary of her symptoms. Apart from that, sir, she does not have any significant. She was born to a non-consanguine.
What is your diagnosis?
Sir, at the end of history, sir, I have a very broad differential diagnosis.
Any obstetric is
Sir, ma'am, she has one child born around 6 to 7 years back. The child was born through normal vaginal delivery. She went through the entire pregnancy without any significant difficulties, and she gave birth to a child who weighed around 2 kgs, a slightly underweight child. She herself is a bit underweight, and
she's on any medication?
She is not on any medications. Even after the development of complaint, she was referred to Kolkata 1 year after her onset of complaint. Then after she was referred to Kolkata also, she has not been on any treatment.
And you have advised any surgery? No.
No advice,
No
not
advice.
advised any surgery.
So from history, what is your diagnosis? History, he says he is a known cardiac patient from age of 2 years.
Yes, sir.
Asymptomatic till
25 years
2 years ago.
Yes.
Only he has palpitation, he has got history of palpitation only.
So she has main complaint is of dyspnea, fatigue, and exercise intolerance associated with
What is exercise intolerance?
fatigue, sir.
But in dyspnea, fatigue, exercise intolerance, you are telling, no?
Dyspnea and fatigue, sir.
Dyspnea and fatigue and palpitation.
Yes, sir.
what are the congenital heart diseases which can be asymptomatic up to that age?
Ma'am, at this age, an ASD can be asymptomatic most commonly. And Epstein's anomaly can be asymptomatic till this age. Rarely, some cyanotic condition like Pinktorff can also be asymptomatic and present later. Then, small left to right shunts can be asymptomatic, but might present with some complications like infective endocarditis.
Any other lesions? Pulmonary stenosis, asymptomatic. Bicuspid aortic valve, maybe asymptomatic.
Bicuspid, yes, sir. If we consider bicuspid aortic valve or an mitral valve prolapse without significant MR, they can also be asymptomatic.
Coarctation of aorta?
Ma'am, coarctation of aorta, it has a bimodal presentation, but either infancy.
What is bimodal? What is bimodal?
Sir, infancy, it either presents in infancy or neonatal period with heart failure, or it presents
Bimodal pain heart failure, not other things. Bimodal pain is heart
for
failure.
heart failure. Yes. And it can present in adulthood, 3rd or 4th decade with symptoms of hypertension or complications of hypertension.
Which series you are talking about?
3rd to 4th decade, sir.
Kiska series है? कौन सा?
Coarctation of aortas.
We read that which series it is.
Okay, sir. Forward the name.
Corrected transposition?
Ma'am, corrected transpositions also can present with right ventricular failure in adulthood.
No. Asymptomatic. Correct transfer without any associated effect.
Without any VSDPS can present. Yes. Yes, sir.
So most common is you think of ASD because there is a hole in heart. So you are thinking of ASD here.
I'm thinking of ASD with a left-right shunt, sir. Can be associated with MVP, can be associated with mitral valve abnormalities also.
Can be associated with?
Mitral valve abnormalities if she's presenting right now with dyspnea if she has.
Mitral abnormalities what?
Sir, mitral valve prolapse or regurgitation can be associated, or a rheumatic mitral stenosis can be associated.
Why do you think like that? Why not isolate ASD?
Isolated AS by itself, sir, usually will not be so symptomatic that it will progress to grade NYHA class 2 to 3 just by itself within 2 years at the age of 25 to 27.
Why is the dyspnea now ASD? What they call the dyspnea here? ASD? We call it main problem ASD. So sorry, main problem dyspnea. Sorry. No? So how is the ASD patient double dyspnea?
So usually will not unless there is a left-sided disease. It can present with fatigue or symptoms of decreased right-sided cardiac output, but usually dyspnea will not be there unless it is a significantly dilated RV which is causing a reverse Bernheim effect.
No, why used to develop dyspnea?
Or there can be reasons of desaturation in an ASD. There can be mitral valve abnormalities associated with ASD. Atrial arrhythmias can be associated.
PH can develop dyspnea, PH.
PH at PH is possible, sir. Isomengerization and PS is possible if it's a large defect. But the point that goes against it is that she's never had any significant left to right shunt features throughout her childhood. So that's why I'm putting Eisenmenger a little below in the list, because she has never.
What are talking about Eisenmenger?
Eisenmenger or any pulmonary, if she's got an idiopathic pulmonary hypertension.
We're not talking Eisenmenger. That's a hole in the head. Now talking ASD without Eisenmenger can develop dyspnea, fatigability, dyspnea.
Yes.
When do they become symptomatic?
On third to fourth decade is the time in ASDs.
What is your age now? What is your age now?
25 was the age.
Third decade now. The third decade.
Why do they become symptomatic? That's what.
RV volume overload symptoms will be the predominant features of an ASD. If it's not,
tachycardia.
Right, arrhythmia, atrial arrhythmias can be there. And pulmonary hypertension.
So you're thinking ASD along with macular disease?
Sir, that is one of the DDs. If I will also like to consider Epstein's anomaly among the important DDs for her, because sir, the dyspnea that she's complaining, she does not have any associated PND or orthopnea. So what her symptoms are not suggestive of any left heart dyspnea due to a left heart involvement. So I would like to consider Epstein's anomaly as well. She does not have any history of pedal edema. She does not have any history of cyanosis.
Epstein has the hole in the heart. Why should it be the hole in the heart?
So the ASD is the hole in the heart that there obligatory ASD is there that shunts the blood from the, not obligatory, but
obligatory what? Left or right left?
Right to left, sir.
Right left has to obligatory. What is the difference of obligatory? Obligatory shunt?
It's required for survival, obligatory.
Obligatory shunt or dependent shunt? No, two things.
Dependent shunt, yes.
Dependent shunt only depend on pulmonary vascular resistance. Obligatory means?
Required for survival.
Doesn't require anything.
It is irrespective of the pulmonary vascular resistance.
Yes, ma'am.
Obligatory shunt is.
When you are presenting the exam, please always don't forget to mention, especially also for adults, history obtained from self or history obtained from other, and is reliable. Further, that's some examiners have the habit of telling, why should you say conscious, cooperative, and all that. You should say it is relevant, not say very gentle. Sir, it is of relevance because it gives it mind and also makes the history reliable.
So, any other things? Two things, sir.
Sir, if the congenital heart disease we do not consider.
No. You are told you can't say you cannot make a case. Case has given to you and the patient tells that I have been diagnosed hole in the heart. You can't omit that.
So she just told that I have.
This is if you ask a cross question, then you have to answer this, not from your side. So first ASD you told, and ASD the material you told, then third thing what told?
Sir, an
Epstein's anomaly.
Epstein's anomaly.
Why not you BHD? Small to moderate size BHD now symptomatic. Why not?
So
or BHD with AR now. Then now BHD now AR developed.
AR usually presents at a slightly at an earlier age. Usually.
Okay, earlier age.
Less than 10 years of age is the usual
They
presentation.
start
Developing AR.
Yeah, but they can present in second and third.
But AR, sir, if she's presented with an aortic regurgitation, usually the progression of AR is quite slower. Like within 2 years, it will not make her very, it will not be a very disabling symptom within 2 years.
So you mean that you would have been more symptomatic, you mean?
She has become symptomatic in the last 2 to 3 years.
So that no possibility at all.
So possibility we cannot rule out. Less likely.
Only plain VHD, small VHD.
Plain moderately restricted.
Yes, mild to moderate VHD, no symptomatic nowadays.
So a small VSD would have probably closed. Would have closed.
No.
So it's unlikely.
Yes, some VHD won't close at all. Small VHD won't close. What are the VHD won't close?
Yes. So inlet VSDs usually are closed late or
No, close. Inlet VHD close with subtle aneurysm.
Yes, outlet and inlet.
Properly won't close, isn't? And
less and
And who's
conotruncal malaligned VSDs don't close. Conotruncal or malaligned VSDs will not close.
Conotruncal malaligned VHD with outlet VHD. Of course, inlet, but inlet VHD will close also. We are seeing now these are aquatic device, the inlet VHD is small, become very small now. Okay.
Go to examination.
How do you have to say?
Exam. Sir, on examination, the general condition of the patient is fair. She is conscious and cooperative. Pulse, coming to vitals, pulse rate of around 70.
Positive findings, because the time is wasted. Very positive findings. Based on that, you have to give a diagnosis.
Okay, sir. Sir, the pulse is normal in character. Blood pressure is normal in all the limbs. Her saturation was 92 on room air, or equal in all 4 limbs. With exercise, it dropped to around 80, equal in all 4 limbs. Coming to the JVP had a normal. The JVP was seen at a distance of around 3 centimeters from the sternal angle on the right side, and a prominent jugular venous pulsation was also seen on the left side. The waveforms.
Right side not there.
Sir, the right side is also there, but the left side is more prominent. The right side is responding to an abdominojugular reflex, but it is not sustained. It falls down within 15 seconds. The A wave and V waves are normally seen in both the sides. The V wave is more prominent on the left side and A wave is more prominent on the right.
Oh, that means you coronary sense type of wave. Because V wave is more prominent left side, A is more prominent A side. And don't tell like this. Even if there was, don't tell. Understand? Even if there also don't tell. Whatever right side tell.
Okay, sir.
The finding is correct. Left side is prominent. But this waveforms differentiation. Don't mention those.
Sir, apart from that, she does not have. She has moderate pallor. There is grade 1 clubbing. There is no edema, no icterus, no facial dysmorphic features. Coming to the no features of infective endocarditis.
JVP raised.
So the JVP is not raised. It's not raised.
Not raised. Pulsation seen.
Pulsations are
B is more than A.
B is more than A on the left hand.
Right side A is more than B.
Sir, actually the level of on the left was also more.
Fine. Then?
So saturation was 80% on exercise, 92 without exercise. Coming to the CVS examination, the shape of the chest is normal, symmetrical. There are suprasternal pulsations seen. The apex is felt in the 5th.
No, suprasternal what? It is arterial or venous?
Sir, arterial pulsation. Okay. Suprasternal arterial pulsation are seen coinciding with the carotid and the apex.
No, suprasternal here or here?
Sir, suprasternal here.
That due to what?
So, could be a dilated aortic arch, I'm thinking it to be.
So the apex is felt in the fifth intercostal space at 1 centimeter lateral to the mid-clavicular, at the mid-clavicular line. It is RV type. There is no cardiomegaly on percussion. RV impulse grade, RV heave grade 1 is felt. Pulsation, suprasternal pulsation are the only pulsation that are seen and felt. A thrill is present at the over the precordium, from the left lower sternal border till the base of the heart. So it's extending throughout the base of the heart. It's a systolic thrill. The first heart sound is normal. The second heart sound is single with a prominent A2. There is no S3 or S4, no added sounds. There is a pansystolic murmur of grade 4/6 intensity, which is harsh in character. It starts at the lower left sternal border, and as we proceed up, there is a mid-systolic accentuation to that pansystolic murmur. The murmur is best heard at the upper part of the precordium, the right and the left upper sternal borders. There is a thrill associated with the murmur. So other systemic, this is the cardiovascular examination. The systemic examination limit.
We are not able to grasp the murmur of pansystolic.
So it's a pansystolic murmur, grade 4/6. It starts from the base, it starts from the left lower sternal border, and it's extending up to the base of the heart.
So pansystolic murmur starting from the lower left sternal border going up to the base of the heart. Okay.
Get from murmur because
Grade 4.
Then what happens somewhere in between?
So there is a systolic accentuation of the murmur as we go up mid-systolic accentuation. Probably I'm attributing it to.
You don't take two murmurs, only one murmur, you mean?
Sir, I felt that it was one murmur. I could not appreciate the second murmur.
So this is murmur starting first sound, going to second heart sound. Now it's falling short of.
Sorry, sir. Sir, it's reaching the second heart sound.
And there is mid-systolic accentuation there. There is mid-systolic
Accentuation before the second heart sound.
Okay. But going to the second heart sound.
It is reaching the second heart sound.
Possibilities.
What do you think of this murmur?
So this murmur I feel is a murmur of a VSD.
Okay.
And but it is mid-systolic accentuation there.
Mid-systolic accentuation, sir, I feel that there is a component of pulmonary stenosis that is.
Then how can you go to A2? But still there are, RE pressure still less than your LV pressure in spite of my pulmonary stenosis. Okay.
Or you are telling that there are two murmurs, one pansystolic.
No, if
you
are going to say that, make it two murmurs. Okay. You make it two murmurs. Pansystolic murmur there, and there is a upper one. There is a.
So conceptually, I can explain it with two murmurs, but what I heard was one murmur probably engulfing the. I could not appreciate the
BHD PH you are thinking of, BHD discharge, BHD PH you are thinking of, because P2 didn't hear.
P2
didn't hear. So P2 didn't hear means significant PH must be there.
Yes, sir.
If significant PH is there, the murmur can be pansystolic. Same murmur can be pansystolic. We can hear the murmur in upper pansystolic. It should fall short of second sound.
Should fall short.
If P2 not audible, so it must PH must be significant. Understood?
Yes, sir.
So BHG PH fine, okay. BHG PH left right sound, still left right sound there.
So it's the shunt from the.
If you are getting murmur starting fast sound, if murmur starting fast sound, BHG PH there, still left right sound there. No. But hemodynamically telling.
Hemodynamic.
Murmur starting fast sound means isovolemic contraction phase sound is operating to LV to RV.
Yes.
Understand?
So this first heart sound should not be normal.
BHD must be there. Understood? So BHD PH, that means left right sound is there.
Yes,
you can't get RV apex.
Yes, sir.
You can't get RV.
RV apex is not explainable if there's a significant left to right shunt.
Either normal apex or LV apex.
So apex is RV. That is the.
Apex is RV as evidenced by.
So it's not localized. It is a diffuse apex. It's shifted 1 centimeter laterally, and the retractions I could not make out that well. But I could definitely not localize the apex.
Any other Auscultation finding there or finish here? Any other findings there?
Sir, cardiovascular system. These are the findings.
But okay, you tell us. Then you give a diagnosis. We'll ask you. We'll grill you now. Your diagnosis VHGPS. That's all. We know that VHGPS.
Your diagnosis?
Ma'am, my diagnosis is a cyanotic congenital heart disease. I'm thinking in terms of a TOF physiology that is presented late. I'm thinking in terms of a DORV with a subaortic VSD-PS that is causing an RV apex. It is also causing the VSD murmur and.
No, VSD murmur won't get. VSD murmur if you get, then LV apex will get. Remember, DORV, VHGPS, if you are getting VSD murmur, LV apex will get. If VHGPS, normally get arteries, you are getting pancytocin murmur with mixed absensation, LV apex will get, or normal apex will get at least. LV, RV apex won't get.
Sir, my other differential that I was.
I know. Why there is suppression persistent?
Sir, DORV, my explanation was the dilated aorta is.
Why aorta dilated? DORV? Aorta dilated in case of treatise follow. Why DORV aorta dilated?
So the right to left shunt that's happening, that's.
Aorta dilated. Why acid dilated?
That's.
No, that's not.
Continuing.
Have you seen treatise follow suppression persistent?
No, sir.
And then. Why the suppression persistent there?
Could be an associated arch dilatation.
Why?
If there is a bicuspid valve or.
Backstart valve, why outer dilated? Unless patient has got autopathy, gross autopathy.
Fits in with PS tetralogy of fellow or DORV? It fits in with DORV according to you.
What is against tetralogy of fellow here?
Ma'am, over here, main thing that is against is the murmur. The murmur is the main thing that goes against the entire.
Why there is palpitation? I don't understand. You told volume overload palpitation. You told why? Where is volume overload? Which ventricle volume overloaded?
None of the.
You can't explain.
Cannot explain the palpitations.
You can't explain.
So it's a moderate anemia.
Anemia.
He said some moderate anemia is there.
You told.
He said, what is the saturation?
Saturation now is 92 on room air and 80 on exertion.
Okay, the guy is exercise.
And sir, I'm also LSVC is finding that I think is there. LSVC probably, if the other DD I thought was of including a VSD.
LSV opening where?
If LSVC is directly opening to LA, that can explain our cyanosis.
No.
If we are not considering, if our murmur, the VSD murmur of a pansystolic VSD along with cyanosis, but the only thing that is going against is the RV apex.
Told the site is, no?
Negative and 1 in avial now.
One?
What is it? P wave is negative in 1 in avial, positive in AVR, with normal progression of R and P1. Just of dextro.
What are the cost of P inversion in lead one?
Say first atrial cycles.
No. Axis.
The axis of the P wave is around 120 degrees. 5 AVR, positive.
Causes of P inversion in lead one.
topic atrial rhythm or
Can it be limb lead reversal?
lead reversal.
Could you limb reversal, lead reversal?
Oh, there is left and right.
I don't think so. It's possible, sir. If you have a positive, beta positive, na? Wrong, I think, lead reversal. It is limb reversal.
Limb lead reversal, sir.
Limb lead reversal. Because you are
But
positive.
you did not get anything on the right side. Nothing. It's not on the right side. Situs inversus is not there.
Did you look for the situs?
Right. I felt
So precardially,
No, but
they don't look like extracardial.
I think it is lead reversal, sir. No? So AVL should be here.
the progression of R waves is normal V1.
But there is atrial situs inversus. So atrial situs inversus is there, but the
Atrial
precardial leads
situs
are not showing anything great. So it is possible we are dealing.
situs inverse.
Okay, so in that context, you have an atrial situs versus have a cardiac displacement. What would be the diagnosis, or what do you think of?
At the first diagnosis.
With the pulsation and the
ECG.
suprasternal notch,
ECG.
Yeah.
think of.
So what do you, anything you want? Is ECG repeated? If you want to ECG repeat or not repeat? If you think CCTGA, you want to repeat the ECG?
Yes, sir. I want to because no Q waves are seen in V5, V6, and I want to see whether the leads are placed without any lead reversal, and then
It's already confirmed that no lead reversal.
They don't try ECG. Any more you want for ECG? From ECG? Anyone?
Reversal will be
Or right side lead to see the loop of the
small
ventricle.
Q, sir.
Loop of the ventricle. Clock तक नहीं. There no clock. Loop is ventricle. Do you look, what do you get L ventricle ECG? V1, V2, you take V2, V3, V4,
What will be there?
what will be there? In L loop ventricle.
L loop ventricle, the outlet chamber will be on the left side.
अरे नहीं रे, the direction of the depolation. So Q will go to right chest lead. Yes.
You may take V3R for.
X-ray करो.
So it's a plain chest X-ray, PA view, good inspiratory fill, adequate exposure. Coming to the cardia, the apex is RV type.
Situs.
Situs.
How do you decide situs from X-ray?
Sir, we can look at the gastric shadow and
Not
the
seen,
bronchus.
not seen.
Bronchus.
Bronchus also we can look right and left over here, right and left bronchus.
You have everything white now, so
I can't make out the right and left bronchus over here.
so how will you?
How will you tell the
But you
situs
have a
position?
structure on the left side, which is going straight, which may give us the diagnosis.
So the
And the arch of.
yeah, the pulmonary artery.
Pulmonary artery not put on here. Bronchus, air bronchus, bronchus.
Based on the bronchus, how do you say whether it is?
No, what's that?
Uh,
Yeah, that bronchus was straight going down.
Yeah. So there is definitely a situs inverse, probably the.
Okay, so suppose situs inversus, mesocardia. So what do you think? Corrected TG.
Cyanotic heart, correct?
Corrected TG.
Correct.
It is corrected.
Structure on your left side.
Left side that
going
left
straight
side
that
will be the aorta, and the right side will be L-pose
Could be L
aorta.
transpose aorta. That is why probably it's going out.
And
And you're getting pulsations there at the system. Then it's coming down.
that's why telling that P2 is here anatomically P pulmonary artery anteriorly posteriorly here. Pulmonary artery position anteriorly posterior.
pulmonary artery.
So P2 not audible. So it is loud. But in it is loud, it is little loud.
P2 is prominent.
Prominent. So it is a correct presage VGPS. Okay. Okay. Dekha, echo dekha. And patient won't be much cyanotic usually.
What are the other associations of CTGV?
Any other association? What
Apart
other
from
association of corrected
VSDPS,
TGA?
what are the other associations?
Dr.
Heart block.
Heart block means what? Heart block. Axis pathway, then
Left-sided AVVR.
where to get the murmur? That is very specific murmur. Where to get?
Left.
Where to get murmur? The murmur comes to sternum. That murmur comes ready to sternum. MR3, or there's some MR murmur ready to sternum. One of them is this one. Not able to know. That is, we must be bad.
Any situation, corrected TGA, where you don't get heart block. What are those two situations? When it is situs inversus and when it is critical PS or pulmonary atresia. When you don't get heart block. It's given in Parlov.
%3 per year.
2% per year up to 40%.
How will I record a husband? I don't know this because here there's already some displacement. You take a corrected transposition patient and you want to record a his bundle electrogram. How will you record?
And it has a long course that courses through the RV, the anterior aspect.
No. Can you go through our traditional way of femoral vein and then go across it, the tricuspid valve septal, get a his bundle there?
Flexible won't get left side. I mean,
It is
right
a
side.
mitral type of valve.
Right.
So go from the left, go femoral, go into the aorta, go into the non-coronary cusp.
That you can get it.
And from there you'll be able to record the his.
Normally also can get his bundle from the non-coronary cusp. Yes. So I think the arteries moves with the ventricle. Yes. So you can see that the outer is, left side. The pulmonary stenosis. Any cross section there? How do you read out equal? So now what is happening? The left side, your more you read out echo. You reverse it, no, is it? Yeah, reverse it. Echo is reverse or what?
No, sir. No, sir. Right side.
Okay. So then it is not normal, it is. You read out echo.
So cytosynthesis with the echo. So it was reported as situs inversus with an LTGA, with normal pulmonary venous drainage, mesocardic heart, sir, with a subpulmonic VSD with of 18 mm size, with valvular gradient, valvular pulmonic stenosis gradient of 110, with normal mitral and aortic valves.
Only pulmonary stenosis.
120, sir. 110, sir. Yeah.
Only pulmonary stenosis.
Valvular pulmonic stenosis, sir. Valve.
Supply VSD also there.
Subpulmonic VSD with valvular pulmonic stenosis. So, ma'am, bidirectional relation.
You are going to give your exam now? Then if you get a case like this, you'll surely pass. So very happy.
So we actually wanted to learn.
No, you're correct, but you this BSD, the minimuscular BSD in post summer review. How can say it is supply BSD? Say that post summer review can't get supply BSD.
Short access condition. So there were a lot of incongruent things in this finding. So we wanted to learn this case also along with him. In the sense, so another thing was it is like side by side, but the X-ray looks like an anterior position. I mean, you have a narrow pedicle. It doesn't look like an L-post GA. The second space also is a little dull, as he said. And that PS murmur, we all thought it was just one outflow tract murmur, sir. We didn't get two murmurs. If the teachers can help us actually recognize it, because it was very complex for all of us to.
So because mesocardic.
Sir? Right, sir. Correct. So there are two different appearances. P2 was very soft and the split was heard, sir. Right, sir. Right, sir. Right, sir.
Almost like a.
Sir, can you take the mic?
Accentuate, particularly when it is reaching the infundibular, is in DCR because the active contractions of that muscular will accentuate the murmur and make it more like a rejection site. And lower down, it will be a pansystolic murmur.
Gradient is quite high.
Yes, sir. So the other thing which we thought was subpulmonic with PS is unlikely because the VSD would drain into the PA. So PS becomes unlikely in that. Like a thoracic. True, usually, yeah. Like a thoracic wing situation.
Yes.
Ma'am? No, we should not get it. Flow is going into correction. And the flow is going into the PS. But VSD PS, yes.
Good, very good. Very good.
Thank you, Jyotish. Thank you so much. Thank you so much. So we'll try to squeeze one last case. Sir. Dr. Sachin from Sathya Institute, Puttaparthi. One last case, 20 minutes. I promise we'll finish in 20 minutes. I request all the faculty to stay back for 15-20 minutes.
Good evening, all respected teachers. Good evening, all respected teachers and dear colleagues. I am presenting a case of a 17-year male, Prashant Kalapnor. He is a resident of Karnataka, studying in 11th standard, and he is coming from the lower socioeconomic strata. The history is narrated by his father, who is a farmer by occupation. He presented with chief complaints of muscle cramps on ordinary activity since 3 years. That is the only complaints he presented with. And to elaborate the history, father said that he noticed muscle cramps on lifting heavy weight in farm. He was helping in the farm activities with the father, climbing 2 flights of stairs, running while playing, and going to school. And these are on and off episodes. It is not a regular event with him. Since 3 years, patient is having muscle cramps. However, there is no history of shortness of breath, orthopnea or PND, no history of recurrent respiratory tract infection in childhood, no history of edema, abdominal distension, prolonged fever.
Muscle cramps or it is?
Sir? Sir, the history is suggestive of muscle cramps, sir, and fatigue also, sir. That history of claudication is not given, sir. Typical history of claudication.
Where are they found, these muscle cramps?
Sir?
Which muscle?
Sir,
Both
his
calf feet and
lower limb muscle, sir. He's
Lower
getting fatigue and muscle cramps in both lower limbs.
There, which muscle comes?
Calf muscles. Calf muscles on ordinary activity.
So muscles, calf muscles on exertion, and you have to know whether it is neurological or vascular etiology. So from the type of this so-called you described cramps, can you know whether it is a neurological or it is vascular?
Sir, vascular etiology is more likely in this case. 17-year male. So neurological cause I am not considering, sir.
Characteristic. From the characteristics. So if it is a claudication pain,
yes, sir,
or a cramp of the muscle,
yes,
how will it manifest? It will
sir,
come after
claudication-
walking a
yes,
few.
sir. Walking a few steps. It manifests as pain, ache, or fatigue in the
Yeah,
muscles,
so it will be
group
a-
of muscles, and relief with the rest, sir.
Neurology?
Neuro pain?
Neurology, same thing, no? Walking, bending, changing posture, bending.
Yes,
and
sir.
pain.
Neurological claudication will precipitate on sitting straight forward and standing, sir, and it will relieve on bending forward. Neurological
If it
claudication.
comes from the spine.
Okay, then.
Sir, there are no other, there is no history of edema, abdominal distension, prolonged fever, cough, hemoptysis, convulsion, or history suggestive of focal neurological deficit. Past history is significant, sir. He was diagnosed to have hole in heart at the age of 12 years of age, following which he was advised follow-up, and which he lost follow-up following the first consultation. He consulted to Sathya Hospital, Whitefield, underwent some procedure through right groin 3 years back at the age of 14 years of age. He is 17 years of age at present. So details of this father is unable to give. His family and personal history is not significant. Treatment history, he's on tablet.
After groin procedure, he got relief?
Sir, I have asked, sir, but he has not given any history suggestive of relief of the symptoms following the groin procedure. And the boy is asymptomatic at present, sir. He is not, the patient is asymptomatic. He himself is not giving any complaints. So whatever history is extracted from father is history of muscle cramps he noticed on ordinary activity since last 3 years.
Same muscle cramp is continuing now?
Sir?
Muscle cramp is continuing?
Yes, sir. They are not often, sir. Actually, intermittent is telling only. The relief of symptom also he has not given, sir. History. So to summarize the case, I have 17-year boy studying in 11th standard, told to have hole in heart at 12 years of age. Underwent groin procedure through right groin 3 years back at 14 years of age. Presented with
at what age?
14 years, sir.
14 years.
He is 17-year, sir, and presented with symptoms suggestive of claudication, sir.
But you never mentioned claudication. You will cramp.
He's presented with muscle cramps, fatigue since 3 years, sir, on ordinary activity.
See, I told you several times, don't translate patient language in English. Muscle cramps, tell you claudication is different thing now. What muscle cramp? Claudication. So
Sir,
what do you diagnose then? Hole in the heart and some procedure done.
Yes, sir.
You don't know whether it's got relief from the muscle cramps and all, you don't know also.
No, sir.
You going to school. He's playing with your friends.
Sir,
So what is he performing in school?
He's going to school by walking, and he's saying that he's not playing with mates, but doing some farm activity, sir.
Oh, he stopped going to school now.
No, sir, he is going to school. He's in 11th standard.
When you work in the field, is any cramp anymore or no cramp?
Sir, there is no progression of symptoms and no relief, sir.
Tell that after the belief is got relief.
Yes, sir.
You just mention those things.
Yes. There is no relief of symptom following the procedure.
So honestly, you are dragging yourself in trouble.
Yes.
So what is your diagnosis then? Is the
Sir,
hole in the heart,
the-
some procedure done from
at the-
government, got relief.
Yes.
Before that, he has got leg claudication.
Sir, after the history, the diagnosis points towards the coarctation of aorta, sir. May be associated with VSD or PDA. However, childhood history of recurrent respiratory tract infection is
VSD or
not
PDA?
given. VSD as most common associated lesion with PDA. VSD or PDA?
Or VHG, large VHG, small VHG, restricted VHG.
Restrictive VSD, sir.
Why not teach a case of aortic? You dilate aortic.
Possible, sir. Aortoarteritis.
VHG are there.
Yes.
Yeah, why not aortic?
After history only, sir. Not much differential I can put. After history, other aortoarteritis possibility cannot be ruled out, considering the vague history of fatigue and claudication.
Why not AHT? Why to see BHT? Asymptomatic. AHT asymptomatic.
Yes, sir. The presentation of ASD.
Why? Why BHT? I say AHT it is.
Sir, association of.
These muscle
OA
come
with-
different. Muscle come different. Maybe you was diagnosed of pulmonary stenosis, you got a dilated pulmonary valve. Or aortic valve you got dilated. This muscle cramp is different. We told muscle cramp is not really, no, there no decrease in muscle cramp also we told.
Yes.
Muscle cramp is still persisting. On what basis you are thinking coarctation aorta?
Sir, just on the basis of.
You should have penned like
similar-
this. He has got some claudication limbs or weakness in limbs. So after balloon procedure, after ground procedure, got relief. You should print it like this. What are the cardiac lesions are common with the and commonly associated with coarctation aorta? Cardiac
Sir,
lesions.
lesions associated with coarctation of aorta, VSD, hypoplastic aortic arch,
Hypoplastic aortic arch.
interrupted aortic arch.
Coarctation aorta, I'm asking coarctation aorta.
Sorry, sir.
Hmm.
Sir, VSD, PDA,
What else?
bicuspid aortic wall,
Huh?
bicuspid aortic wall, sir.
Okay. Then?
Mitral wall abnormalities, sir. Supramitral ring can be associated with COA.
There's syndrome, the elevated obstructive syndrome.
And
now.
there is a Schoen's complex. Schoen's is part of Schoen's complex, sir. Coarctation of aorta, supramitral ring, subaortic membrane, and COA.
Then metal valve, one more thing, metal valve.
Single papillary muscle, sir.
Huh?
Single parachute mitral valve, single papillary muscle. Sir,
He told,
pardon, sir. Yes, sir. TG also associated, sir.
Details follow? Details follow coarctation. What is the association?
Sir, two obstructive lesions, sir.
If it there is a BIB and it's assuming white, details
Sir,
follow.
left and right severe obstructive lesion do not coexist, sir. It is not, TOF is not associated, sir.
Why not?
It is, survival is not possible, sir.
So that's the reason why. Because patient won't survive, God won't give two problems.
Yes.
What is the theory behind the coarctation?
Two theories, sir. One is through during development, sir, hemodynamic theory of during intrauterine life, reduced flow through the aorta leads to coarctation, and the second one is, sir, ductal tissue, persistence of ductal tissue in the descending aorta near the insertion of ductus that causes associated contraction of the aortic segment leading to COA.
Here is the last in total follow large VHD there. Get coaptation aorta. Coaptation aorta, the coaptation is not associated. You told no. So large VHD there, left to right. Then why not?
VSD.
You can have ESD and coact. No?
Yes,
Only
sir,
according to
VSD.
the theory, you can't have coarctation of aorta in tetralogy of fallow like situation. Isn't it?
Sir, can you
Coarctation is
please-
rare, no? Tetralogy of fallow?
He told. Oh, he told.
Finding.
Yes, sir. Sir, positive findings, sir. Pulse is 80 beats per minute
Coaptation
regular.
aorta, listen, coaptation aorta, the obstruction is in, where is obstruction usually? Where is narrowing occurs?
Sir, obstruction is in descending aorta, sir.
Then why the claudication occur calf? It should occur thigh also.
Sir,
You told calf only.
Sir?
So presentation is not correct actually. That I am testing upon.
Sir, the development of collaterals and collateral supply reaching toward, so distal muscles will suffer more, sir, because of the, it depends on collaterals development. So proximal muscle will have less symptoms, less affection.
Okay, so the present. So read there.
So pulse is 80 beats per minute regular, normal character. There is radiofemoral delay present. Bilateral femoral pulses are feeble. Dorsalis pedis artery pulsations are feeble, sir. Bilaterally.
Bilateral?
Bilateral femoral and dorsalis pedis pulsations are feeble, sir. There is radiofemoral delay. There is no radioradial delay. Blood pressure is 172 by 60 in upper limb and 148 millimeters of mercury systolic in lower limb, sir. Saturation is 99% in all 4 limbs. There is no cyanosis, clubbing, icterus or lymphadenopathy. JVP is not raised with normal waveforms with negative hepatojugular reflex. And there are no dysmorphic features, sir. So, cardiovascular system examination, inspection palpation, visible prominent carotid pulsations are present. Chest is symmetrical, no scar, sinuses.
Supraspinal
Apex,
Supraspinal.
present, sir. Suprasternal and carotid pulsations are visible. Chest is symmetrical. Apex impulse is located in left 6th intercostal space over the midclavicular line, forceful and sustained. S2 is not palpable. Epigastric pulsations are absent. No thrill. No parasternal lift, sir. Percussion is suggestive of situs solidus, sir, abdominal situs. On auscultation, S1 is normal. S2 is a reverse split with loud A2.
Reverse split.
Yes, sir.
Reverse
split, sir, with loud A2. No S3, S4 audible.
What about P2? Loud A2. What is P2 normal or absent?
A2 is louder than P2, sir.
A2 louder than P2. P is normal, no? Normally what happens? Normally?
Sir, normally A2 is louder than P2.
Okay. Here same thing. A2 is louder than P2. Now it is.
Sir, reverse split is split during expiration, sir. Is to split during expiration.
Split in inspiration.
Expiration, sir.
Inspiration, expiration.
Expiration, sir.
Okay.
There is continuous murmur over left first and second intercostal space, grade 3 by 6.
Here.
Yes, sir. Left first and second interspace, sir. Infraclavicular, yes, sir.
What's the murmur here?
Continuous murmur is there. Grade 3 by 6, sir.
No, the character what's the murmur?
Sir, it is peaking at S2, sir.
Okay.
Continuous murmur peaking at S2, present in the left and first and second interspace. It is low frequency blowing
Low frequency. Okay, low frequency.
Blowing
It's
murmur,
around
sir.
second short sound. Fine then.
Yes, sir. It is soft blowing low frequency murmur. Peaking at S2, S1 is normal. No S3, S4.
No S3, S4.
Yes, no, sir.
You are taking a heaving type of X.
Yes, sir.
Forceful heaving type of X.
Yes, sir. S4 I could not appreciate, sir.
And second sound.
Sir,
second
sir.
reverse split.
Reverse split, sir. Into
And you constant murmur will get in here only. Is it?
there are systolic murmur over the back is present, sir, in the interscapular area. Sir, I also got ejection systolic murmur over a right second intercostal space, which is. So diagnosis is a cyanotic congenital heart disease, coarctation of aorta with PDA, sir. In view of not in failure or infective endocarditis.
This is not going to give diagnosis. Okay, we are given the right left sound, left right sound, or no sound.
Sir, PDA with left right shunt.
How much it is?
Sir, it is 1.5 to 2, 2.2.
1.5 to 2.
QPQS, yes, sir. It's moderate size PDA. No signs of failure or infective endocarditis and patient in sinus rhythm.
You are getting ejection non-prepared. Ejection system
Sir,
murmur, right second
that
space.
could be due to associated aortic stenosis with CoA, sir.
Aortic stenosis.
Maybe bicuspid aortic wall with aortic stenosis.
What is the other event? Congenital aortic stenosis or acquired aortic stenosis?
Congenital aortic stenosis, sir.
Or the valvular or subvalvular? Or
Congenital.
Valvular.
Sir, the radiation to carotids I could not found.
What other?
Maybe subaortic.
Subaortic stenosis.
Subaortic membrane.
Subaortic membrane. Why are you getting murmur?
The murmur will be, sir.
I'm going.
What type of murmurs can be heard in coarctation? What are all the murmurs which could be heard?
Sir, I didn't get question, sir.
No, in addition to coarctation can produce what all murmurs?
Different murmurs in CoA.
In the precordium, in the back, of course, you know, you'll get a
Right,
continuous
yes, sir.
murmur and all. But in the precordial area, what all murmurs can you get with coarctation, with some associated lesions also, which can give rise to a heaving apical impulse?
Ejection systolic murmur of subaortic membrane can be audible in left third intercostal space.
Subaortic membrane.
Left third intercostal space, which is not radiating to carotids. There may be murmur of there can be murmur of mid-diastolic murmur of congenital MS or
No, that is okay. Shown complex, yes.
suprametal ring.
Coarctation per se, I am asking. Coarctation per se can give rise to murmurs.
Coarctation per se, sir, collateral can give rise to continuous murmur, sir.
Yes. So it could be a collateral murmur.
Continuous murmur and murmurs over
Why do you
the.
put PDA? It could be a collateral.
Why should we put around second sound?
Sir, murmur over the backs are also audible, sir.
No, it is collateral. Collateral between what?
Collateral, sir, between.
Which collateral will give you continuous murmur in front?
Or collateral between
That second space.
internal. That murmur coincides with PDA, sir. In this
PDA.
case. This case.
So how do you get the second sound paradisical here? How do you get a paradisical sound here? I don't understand. Because the PDA.
Sir, the split is audible in left third and.
I don't know, what is the explanation for that?
Let's assume it's paradoxical. What is the explanation?
Tell me, what are the conditions to get paradoxical second sound?
Sir, paradoxical split is seen in PDA, LBBB,
PD is a common cause.
severe aortic stenosis, hypertrophic obstructive cardiomyopathy,
You don't think there is also LVB there?
RV pacing, RV ectopics.
You mean there is RV, okay, you mean there is RV, LVB there? Here, you are suspecting LVB? Or PD giving rise to paradoxical split here? Yes, you are telling yes not very significant. Your parenthesis yes not there.
Yes. Sir, because of the delayed P2.
Why PD gives a paradoxical split? I don't know. Why do PD give? Why do you get paradoxical split in PD?
Sir, because of the
Because of what?
delayed P2 and early A2, sir. Early A2 and delayed P2.
RV?
Early A2 and delayed P2.
RV? What do
Early A2.
Early A2.
Early A2, why it should cause paradoxical split?
Early A2 go. Early A2 go what to go to? Early A2?
Sir, sorry, delayed A2 because of the prolonged LV ejection, sir. LV or aortic angle.
So A2 should get postponed. Then only you'll get a paradox. So then only P2 will come in front or before. The order should be P2, A2, isn't it?
So do you mean how to hang up time interval is prolonged here? Why you get a paradoxical split here in the PDA? Good answer in exam.
Yeah.
If you are doing a paradoxical split.
It's one of the books which mentions paradoxical split. They have described it as type 1, type 2 paradoxical split. It was Jonathan Abrams. Please try to get the book and read it. Again, the old edition, we don't know if it's available or not, but it is downloadable from LibGenRS. You can download from that site.
So 12 lead surface ECG with normal standardization in sinus rhythm with heart rate of around 75 beats per minute with QRS axis of plus 60 degree. And there are counterclockwise decolorization, sir. And left ventricular hypertrophy with prominent septal Q views suggestive of a volume overloaded left ventricle.
Why there is RBV there? Partial RBV or income to RBV
So
there?
equiphasic.
There no?
There are equiphasic complexes in the V2 and V3 leads, sir.
What equiphasic
V2,
complex,
V3, V4 suggestive of.
That is not capsule phenomena. They are RBV there or not? V1? RSR pattern there. RSR prime. And axis 60 degree in the presence of LVS.
RSR pattern in one complete RBB, sir. Here.
You mean that the ECG is a parallel split or a wide split? Okay, there volume will be there.
Volume overloaded LB, sir.
Will be there.
Yes.
Because of doctors.
And there is a left atrial abnormalities there, sir. Left atrial enlargement is there.
Enlargement there. So
yes, sir.
volume overload there also. How do you explain T inverse lead 2, lead 3? AVF also.
2, 3 AVF.
And ST elevated looks like a Brugada pattern in lead 2. What is this?
Early
Barrel shape.
early revolution.
Purpura pattern, that is, what is that? It is more, this is now, and also still with V3 also. It looks like what? Pericarditis,
Sir,
MI, or Durgada, what is that? Durgada,
there
no?
is notch at the downstroke of R wave in V5, V6, sir. This pattern is suggestive of early reproduction.
Okay.
But you can get ST elevation like this when there is severe LVH also. Can get.
Okay, T inverse can explain term LVH or just some other pathology? In inferior leads. Sachin, the exam last question like this, you have answered to. Okay. Go dekha. X-ray.
Sir, this is a chest X-ray PA view, well centralized film, well exposed, showing situs solitus, levocardia. CT ratio is 0.5, sir. Cardiomegaly not there. Apex appears to be, sir, LV type of apex, sir. There is a enlargement of right atrium occupying more than 2.5 spaces on right side.
Aorta?
Left aortic.
Ascending aorta.
Aortic dilatation is there, sir. Ascending aorta is dilated and there is
segment.
MP is dilated, sir.
And the radiological epi window, what is happening?
No evidence of pulmonary venous hypertension.
What about the pulmonary vascularity?
Pulmonary plethora is not present. No pulmonary plethora.
Okay. There is a aortic knuckle.
What the pointer is there?
Sir, the aortic arch is on left aortic arch, sir. The indentation of aorta left side. Sir?
Aortic knuckle should be visible, no? If the aortic knuckle is not visible, then something is covering the aortic knuckle. Could it be the left subclavian artery, which is, could be, or it could be left subclavian artery itself, dilated left subclavian artery, no? It can obscure the aortic knuckle in case of,
Knuckle not seen, radiological knuckle not seen in coarctation.
because it's obscured usually by the left subclavian artery, which is dilated.
Is there evidence of coarctation now? You told collateral murmurs there, no? Where is it? Huh? Rib notching there? Rib notching there or not? There, I think.
There, right side.
The right side seen. There is? There? Oh. Where to see? Where to see? Superior or inferior? Sorry, margin. Okay.
Posteriorly.
All right. Okay, fine. Yes, supposing coarctation aorta, the rib notching is absent on left side. What do you think of? One side not seen. Right side not seen. Okay, right side not seen. What do you think of?
The aberrant Cleveland artery. Taking origin.
तो रिपोर्ट पढ़ दो.
So the patient had a coarctation with 100 gradients, sir. Cath was done, LV 230 descending out a 130 with a suprametal ring with a 22 by 10 gradient across it. 22 by 10 gradient across the suprametal ring and 5 millimeter PDA, sir. 5 millimeter PDA. Yeah. So we just play it. Play it if you want.
Okay, fine. There is no forget, no supramental ring, supposing, coarctation outer. And he doesn't want surgery. He wants that he should do this. What will do for this case? There's PDA and coarctation there. And you cardiologist should treat the case. You don't want to give to surgeon, or the patient doesn't want surgery. How do you manage this? No, authority will tell. No or no? Put a copper stent. Huh?
PDA device, sir, and
But copper stent.
covered.
If you want to cover both, sir, in one thing you can cover both, close the PDA and open the coarctation.
Is there any danger of putting a covered stent there?
Dissection, perforation.
Diastolic spill over. This is
Diastolic spill.
Yeah, diastolic tealing, we call it.
Can talk across the OA segments.
no.
Diastolic tail.
That one.
Yes, sir. Yeah, so we are ending, sir. I can just request all the faculty and the delegates, thank you all for staying back. Please join us for the last 5 minutes of a closing ceremony. Ma'am, can you just give a vote of thanks followed by Aarti?
Sairam all, just stay back for 5 minutes. We'll have the Aarti within 5 minutes. First of all, heartfelt gratitude to Swami for spearheading speed right from 9 years ago, right from its conceptualization in our minds and conducting it successfully year after year. Right from the initiation, the thought, the inspiration, and to the final step is really all his work. I thank deeply on behalf of all of us present here, I thank Dr. Dash for initiating this speed 9 years ago, coming all the way every year. Last time also in 2020, sir came, and now also, despite all the COVID risks and everything, we really thank you, sir. This is on behalf of all the students present here who have learned since morning. Speed was sir's brainwave idea, everything, and it has been successfully going on from the last 9 years. We cannot thank you enough, sir. I also thank our esteemed faculty in-house, Dr. Barua, and like Prayag said in the morning, all faculty are really our Sai family, because every year our faculty have contributed to speed year after year, and all your seniors, everybody has come to this, this very hall, learned, attended, and pass their exams. So thanking Dr. Iyengar, Dr. Balchandar sir, Pravati ma'am, Dr. C.B. Patil sir, Dr. Kiran Varghese sir, Dr. Ramakrishnan sir, Hemant Madan sir, even though he was not well traveled. In-house, really like to thank Prayag for all the efforts put in, right from And no mention actually. We've just as a team put everything together. Darshan, Kushal, Dr. Adesh, all our DNB students as well. And our technicians, Chandrapa, for making all the echo recordings and arranging everything which we had to, the whole thing. HMIS team and AV team for putting things together. The canteen for the food, tea breaks, everything. And you can see this team of CCT girls, they are our cardiac care technology girls. You can see them all over. If you see there, she's there. If you see them, they're here. And right at the back, 20 of them. So they are the ones who have really done all the hard work this time and every time. There are a multitude of girls, right from first year to interns to staff, and they carry all the roles very, I would say easily, with a lot of ease they do that. Right from serving to registration to lamp arrangements to garland to rangoli to everything, including taking care of housekeeping work, cleaning up, washing the dishes, everything they have taken up roles and they have successfully executed this whole thing. So I really thank them. And also like to really thank Wasim, the florists, for pitching in and putting this all together and making it look very pretty. I thank our managers, Saikiran and Srinivas, who've been working despite their schedules. Also thank Pawan and Mahesh, and despite all the family difficulties that they had to go through, and there are very personal things, but till yesterday evening, Mahesh was here doing all the work before he lost his child. So there's been a lot. There are people who put in their best for all of you, honestly. I thank all of you, first of all, for raising our enthusiasm for this event. We had a lot of queries from faculty when we called them for the event, like, why are you holding this? There's COVID going on. COVID was increasing suddenly. Are we going to cancel it last minute? It will be a big loss for this, for that. So many doubts, so many queries. And in spite of all that, when we let out the registrations in one day, we had 160 registrations. We don't have that many people today, I know, because I think some theory exams were announced a couple of days ago and a lot of people dropped out for that. But I think the hall has been full and I'm very, very grateful to all of you. When we saw that 160 registrations, we realized there is a need. There's a need from the side of the students, and it is our duty to take this forward. So it is because of all of you that this event has been conducted. So I thank each one of you. I also thank all the ones present here for staying back till vote of thanks. So that is really great. Also, you've all risked yourselves traveling all the way from various parts of the country. Thank you for that. I know you're all close to theory exams. Dastar used to tell us, be careful before theory exams because, and any exam, because traveling, all that. But still, we have had a lot of participation in today's event, including the enthusiasm which all of you showed in the interactive session. So really thank you for that. That was really good. I also thank the volunteers for coming forward and presenting cases. So that was very, very enthusiastic. You are really the COVID warriors and you guys deserve the best. So wishing every one of you the best. I don't know how many final years are here, but hope you all do very well in your exams and have a safe journey back. And we have a special guest actually, Naran Prabhu sir from HR Puttaparthi, Sairam sir. And thank you for sitting patiently through this whole proceedings right from morning. Sir has been here with us. And thank you for being with us and gracing the occasion. And yes, sir. Sairam sir, Sairam. Thank you all and wishing you all the best for your exams. Sairam.
Dr. Patil, sir, you try. Hey, come here. Thank you, sir. Thank you very much.
जगदीश हरे स्वामी सत्य साई हरे भक्त जना संरक्षक भक्त जना संरक्षक पति महेश्वर ओम जय जगदीश हरे शशिवदना श्रीकरा सर्वा प्राणपते स्वामी सर्वा प्राणपते आश्रित कल्पलतिका आश्रित कल्पलतिका आपद्बान्धवा ओम जय जगदीश हरे माता पिता गुरुदैवमु मरियंदयु नीवे स्वामी मरियंदयु नीवे नाथ ब्रह्म जगन्नाथा नाथ ब्रह्म जगन्नाथा नागेंद्र शयन ओम जय जगदीश हरे ओंकार रूप शिव साई महादेवा सत्य साई महादेवा मंगलारति अंधुकु मंगलारति अंधुकु मंदर गिरिधारी ओम जय जगदीश हरे नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम नारायण नारायण जय सद्गुरुदेवा शांति 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 समस्त लोकाः सुखिनो भवन्तु समस्त लोकाः सुखिनो भवन्तु समस्त लोकाः सुखिनो भवन्तु